Welcome everyone. I hope my voice is perfectly clear to everyone. Good evening. Yes, your suggestion has been taken, and after general pharma, I'll first start with antimicrobials. Okay. So let's start our wonderful revision program. And before starting, just thanks the Almighty or the things in which you believe that we got such a wonderful life, such a wonderful opportunity to learn something being a human. And let's start our journey. So today I'll cover each and every point, each and everything in this LRR session. It will be a long session and I need a cooperation from all of you students. Sit, relax, keep your mind open, forget about everything right now. For today, just focus on this LRR. Okay? Chaliye. So, in this section, I will be discussing PYQ and PYTs of past 5 years, 5 to 6 years of INI-CET. I'll be telling you about the newly approved drugs also in this session. Okay. So the session will be long, but relax. Okay. Everything will be covered. So let's start with the first part, that is general pharmacology. And it is very important to overcome your fear. That's great. So, forced alkaline diuresis is done for the poisoning of, what is the answer? The answer of this question is aspirin. Okay. Now let's understand the concept behind it. Now remember, any acidic drug, it becomes non-ionic or lipid soluble in which media? In acidic media, a drug becomes lipid soluble. And similarly, basic drugs, they become lipid soluble in which media? Basic media. And the point to be remember is that these drugs becomes water soluble in opposite media. Opposite means acidic drug becomes water soluble in basic media. Basic drug becomes water soluble in acidic media. And the pH at which a drug becomes half, 50% water soluble, that is ionic, 50% lipid soluble. This pH is known as pK value of a drug. This is known as pK value of a drug. Understood this point? So let's see the concept behind it. Can we say if there is a poisoning of any acidic drug, what we should do to the urine? We will turn the urine pH opposite. So in acidic drug poisoning, we will do forced alkaline diuresis. Now, you students can tell me the reason why. Because in alkaline media, acidic drug becomes water soluble and they are easily excreted out in urine. And how we do forced alkaline diuresis? By giving a drug sodium bicarbonate. By giving a drug sodium bicarbonate, we turn the pH of urine alkaline. Similarly, in basic drug poisoning, we will do forced acidic diuresis. It means we can convert the urine pH acidic because basic drugs becomes water soluble in acidic media, and we do this thing by giving a drug ammonium chloride. Now the point is which drug we have to remember. So we have to remember the name of acidic drugs. So acidic drug is aspirin, acetaminophen and barbiturate. Remember, three drugs only. So that is why we were doing forced alkaline diuresis in aspirin poisoning. And basic drugs, remember, if any drug is a basic drug, it will end with the word "ene." It will end with the word "ene." Amphetamine, morphine, atropine, quinine, they all are basic drug. And try to remember amphetamine out here. It is an important question. Now just see the MCQ again. Can we say all other drugs are ending with the word "ene"? So because all drugs are ending with the word "ene", we will do forced acidic diuresis, while in aspirin poisoning we will do forced alkaline diuresis. Next question. Incorrect match regarding the drug and antidote combination. So tell me the answer, you already know. Would you like to give sodium bicarbonate in amphetamine poisoning? Absolutely contraindicated. No, it will become more lipid soluble and it will get reabsorbed back. So in poisoning, we will give ammonium chloride. So the answer is C. So incorrect match is C. Great. Now let's make a list of all the drugs and their antidotes in one place. Expect one MCQ always from this list. So what is the antidote of digoxin poisoning? That is digibind. Digibind, remember, it is also known as digifab. It's an antibody against digoxin. It is an antibody against digoxin. Then we have lignocaine, bupivacaine. All drugs which end with the word cane are local anesthetics. Here the antidote is 20% intralipid emulsion. They act as a soap-like molecule and attach with them. What can you recall and tell me the antidote of aspirin poisoning? Yes, we already know it is sodium bicarbonate. But what is the antidote of paracetamol poisoning? Remember, I will be telling you paracetamol causes hepatotoxicity. It will make some toxic molecule. Later I will tell you the antidote will be N-acetylcysteine, and how N-acetylcysteine will protect the liver, that will also I will tell you. Similarly, morphine, opioid poisoning, we give naloxone. Amphetamine poisoning, we just discussed. The antidote is ammonium chloride. Now, tricyclic antidepressant. Let me write the name of one tricyclic antidepressant, imipramine. Again, the antidote is sodium bicarbonate. Again, the antidote is sodium bicarbonate. Okay, fine, great. Organophosphate, which I will be telling you, atropine. While carbamate poisoning, antidote is atropine. But in organophosphate poisoning, I will add one more drug, that is pralidoxime. So remember, oximes are only given in organophosphate poisoning. But what should be the antidote of atropine poisoning, which is obtained from belladonna and datura plant? We give a drug physostigmine. Just remember this list. Concepts I will be telling you shortly. What about the antidote of poisonous alcohols? Methanol and ethylene glycol, these are neurotoxic molecule. They can cause brain damage. Here the antidote is fomepizole. Fomepizole. While what is the antidote of diazepam, lorazepam, midazolam? All these are benzodiazepine. Here the antidote is flumazenil. Now you student may get confused between fomepizole and flumazenil. Remember, in benzodiazepine, any drug, you will find the word arm. You will find the word arm. Here you will also find the word arm in flumazenil. And fomepizole, all words से end कर रहा है. All means always alcohol. So alcohol, methanol, ethylene glycol, fomepizole. Simple and easy. Then we have calcium channel blocker poisoning. That is calcium gluconate. Give calcium from outside. And in beta blocker, lol wale drug, ismolol, atenolol, metoprolol, they all can cause bradycardia and patient may die. Here the antidote is one hormone known as glucagon hormone, because glucagon hormone will produce opposite effect. It will lead to tachycardia. Absolutely fine. Now this was the last year question. So tell me, what is the antidote of methanol poisoning? Yes, the answer is fomepizole. Fomepizole. Opioid poisoning, naloxone. Naloxone. Benzodiazepine poisoning, flumazenil, we just discussed. And what about arsenic? Arsenic is a metal. Here the antidote is British anti-leucite. British anti-leucite. So the answer out here comes out to be C. I hope it's correct. So let's talk about all the metal poisoning. Remember, in the metal poisoning, we give chelators. Chelators are given for metal poisoning. So the first chelator is British anti-leucite. BAL. Let's write the short form BAL. And use the first two words of BAL, B and A. And another name of BAL is dimercaprol. You can see merc word is coming. Can you tell me M for which metal poisoning we will be giving dimercaprol? So B for you will write bismuth poisoning, arsenic poisoning, and merc stands for mercury poisoning. We give BAL. Very important, many times asked. Very good. Calcium disodium EDTA we give for lead poisoning. Penicillamine given in copper poisoning. And I will be telling you shortly, in copper poisoning can be seen in one disease known as Wilson's disease. And lastly, you can see deferrioxamine, deferriprone. Above drug is an IV drug, lower drug is an oral drug. Own word is coming, to oral hona chahiye ye wala. So FE word is coming. They are seen in iron poisoning, and iron poisoning you will get in option thalassemia patient, because thalassemia patient require repetitive blood transfusion, which will lead to iron overload in the body. So that is why we give in iron poisoning. So remember, direct questions will not come. They will give you a clinical scenario, thalassemia, Wilson disease, etc. Now let's talk about, in relation to drug absorption, what does the term rate of absorption means. Now remember one concept always. Wherever the word rate comes, rate always means time. Remember 11th and 12th class, rate always means time. So what is the answer? What is the answer of this question? है ना, रेट का मतलब हमेशा टाइम होता है. सो द आंसर इज टी मैक्स. सो व्हाट डज इट मीन? अंडरस्टैंड वन पॉइंट. व्हेन यू टेक अ ड्रग orally, don't you think slowly and slowly the drug will come into your plasma concentration of a drug will increase, and it will increase with time. So we make a graph, concentration time graph, when you give a drug, and this highest point, let's mark this highest point. Can we say this is the maximum concentration Cmax, and it is coming in which time? Tmax. So Tmax tells you about how fast the drug is coming. It tells you about the rate of absorption. Rate means how fast the drug is entering into your body after getting absorbed. Cmax tells you about the maximum plasma concentration. And lastly, can we divide this whole area? This whole area, it is known as AUC, area under the curve. So area under the curve tells you about the total extent of absorption, that how much amount of total drug is entering into the body. And this AUC, it is used to calculate the bioavailability of a drug. BA means bioavailability is calculated by area under the curve. How do we calculate? We see this area under the curve when we have given a drug orally, and we divide this by area under the curve when we give a drug IV. Why? Because IV route will always have 100% bioavailability, because complete absorption will happen, complete drug will come. So this is the formula of bioavailability. Very good. Now let's talk about some one-liners. Can you tell me in which route the drug first goes to the liver and then it reaches to the heart? So because liver is in between, before a drug can enter into the body, the liver will degrade the drug. This is known as first pass metabolism of a drug. So yes, it is seen in oral route, because in oral route, the drug from stomach and intestine enters into portal vein, and portal vein first drains into liver. Now which enteral route bypass the first pass metabolism of liver? Yes, the answer is sublingual route and rectal route. Because sublingual and rectal route, the drug directly reaches to the heart through sublingual vein and hemorrhoidal vein. Liver does not come in between. So which route has 100% bioavailability? We have just discussed intravenous route. Now remember, there are different brands of same drug. Different brands of same drugs, they are known as generic drugs. Don't you think generic drugs, when you take orally, they should have same bioavailability? But sometimes, because they are different brand, little bit variation can happen, and the acceptable variation is 80 to 125% in bioavailability. And if two drugs are between this range, we call these drugs equal to each other. Equal to each other means bioequivalent drugs. And if a drug is bioequivalent, you can easily interchange the brand of these drugs in your patient. But wherever the word bioequivalence comes, remember one exception to this rule. The exception to this rule is phenytoin. Remember, we never change the brands of phenytoin in our patient, because this variation can be harmful among different brands. They can lead to seizure. So never change the brands of which drug? Never change the brands of phenytoin in your patient. Otherwise, we can change the brands of other drug in our patient. Now let's talk about a recent last year question. Cyclosporin causes cholestatic jaundice due to inhibition of. Any student who can tell me the answer of this question? The answer, it's a tough one, but let me explain you. The answer is MRP2 protein. MRP2 protein, which is also known as P-glycoprotein. Now remember, in our liver, bile is excreted. Bile is excreted. And this bile is excreted by P-glycoprotein. So if you inhibit P-glycoprotein, bile will accumulate in the liver. And if bile will accumulate in the liver, it will lead to cholestatic jaundice. So let's talk about this P-glycoprotein. P-glycoprotein is also known as MRP2 protein. It is known as multi-drug resistance protein. So that is why it is also known as MDR2 protein, that is multi-drug resistance protein. So why it is known as multi-drug resistance protein? Because if any drug who is getting absorbed into the body, this P-glycoprotein holds this drug and it again throws the drug out of the body. So it causes drug efflux and the concentration of the drug in our body reduces. So P-glycoprotein, remember, it is the enemy of a drug. So because it will not work in free, it requires ATP, it requires energy. It is also known as ABC protein. ABC stands for ATP binding cassette protein. It is also known as ATP binding cassette protein. Remember, P-glycoprotein is enemy of a drug. It does not want the drug to remain inside the body. So if I say it is present in GIT, can we say it will reduce the absorption of a drug, which will decrease bioavailability of a drug? If it is present in kidney and liver, don't you think it will increase the excretion of a drug into urine and bile? Agreed? So if I inhibit bile, it will lead to cholestatic jaundice. And similarly, it is present in barriers like blood-brain barrier and placenta, and cancer cells can develop resistance to a drug because they can express P-glycoprotein, and which will reduce the entry of drug into brain, fetus and cancer cells, which will lead to resistance to a drug. So that is why multi-drug resistance protein. Any drug which is identified by P-glycoprotein, which is a substrate of P-glycoprotein, this drug is used in heart failure, we all know, digoxin. But there is a point that there are certain drugs which can increase the activity of P-glycoprotein. Let's call them as P-glycoprotein inducer. So rifampicin, a TB drug, is a P-glycoprotein inducer. So tell me, student, one question of last year, that why rifampicin has a very poor blood-brain barrier entry. Can you tell me why rifampicin cannot enter into the brain? Because P-glycoprotein throws this rifampicin out of the body. Now, similarly, we have a drug which are P-glycoprotein inhibitor. Mnemonic is quack. Try to remember verapamil and try to remember erythromycin and clarithromycin. Now tell me, if you will combine rifampicin with digoxin, why it reduce the effect of digoxin? Because digoxin will be excreted out in urine very easily. It's a P-glycoprotein inducer. And similarly, if you combine clarithromycin and erythromycin with digoxin, digoxin will not be removed out into the urine. So these drugs can lead to toxicity of digoxin. And now, can you tell me the answer of our MCQ? How cyclosporin causes cholestatic jaundice? By inhibiting P-glycoprotein, which is also known as MRP2 transporter, I hope this concept is clear to each and every student now. Yes or no? I need a little bit thumbs up so that I can move ahead. Now let's talk about which of the following factors are involved in the calculating loading dose of a drug. Remember, loading dose is the first dose which we give in our patient. It is also known as initial dose. So for a moment, let's forget this question. Let's learn the formula of loading dose. So when you give loading dose IV, it depends upon volume of distribution. Volume of distribution means how much drug is entering into the organ multiplied by how much will remain in the plasma, that is target plasma concentration. And what about after you have achieved the plasma concentration, target plasma concentration, we start maintenance dose. So maintenance dose depends upon the clearance capacity of the body into target plasma concentration. Now remember, this is what I have written IV. Now let's say I want to give this drug orally. When I want to give oral loading dose or oral maintenance dose, I will divide this whole formula with bioavailability. I will divide this whole formula with bioavailability. Agreed? Now let me give you a trick how to remember it. In loading beta, you can see D word is coming. In maintenance, D word is not coming, C word is coming. So in loading, remember volume of distribution, and in maintenance, it depends upon the clearance capacity of the body. Now let's divide this two formula among themselves. It will bring the formula of half-life to us. So half-life ka symbol we all know is T half. It is equal to 0.693 volume of distribution upon clearance capacity. And remember, half-life does not depend upon bioavailability. Half-life does not depend upon absorption. This is a separate MCQ. Agreed? And this formula you can write as 0.693 upon K. So what is K out here? K will be Cl upon Vd, and K we call it as elimination rate constant. K का मतलब क्या होता है बेटा? Elimination rate constant. Agreed? Now, let's come back to our formula back. Let's come to formula. Tell me the answer of this question. Last year, January question of INI-CET. Which of the following factors are required in calculating the loading dose of a drug? Okay. I think let's cut this. Let's cut that. Let's make it maintenance dose. चलो मेंटेनेंस बना देते हैं इसे, ठीक है? डोंट वरी, थोड़ा ऑप्शंस कर लो. अब आंसर बताओ बेटा. मेंटेनेंस डोज किस किस पे डिपेंड करती है? क्लियरेंस पे करती है, plasma concentration and systemic bioavailability. So the answer comes out to be A. अब ठीक है बेटा, ठीक है? So I know, okay, understood this point? Good. Now steady state concentration. Let's say you have started giving a drug continuously. Its 95% concentration is achieved in how many half-life? 4 to 5 half-life. And after 4 to 5 half-life, the action of the drug will start. So at steady state concentration, the action of a drug start. Now just imagine you have stopped a drug. When we stop a drug, slowly and slowly concentration will fall. So after how many half-life? 95% of the drug will be eliminated outside. Again, the answer is 4 to 5 half-life. So when 95% of a drug is eliminated, we call it as complete elimination. So steady state means कितने टाइम में 95% अचीव होगा? व्हेन वी स्टार्ट गिविंग अ ड्रग 4 to 5 half life. When you stop giving a drug, after how many half life? 95% of the drug will be eliminated. Again, the answer is 4 to 5 half life. Now remember, there are certain drugs which even after complete elimination, their action persists in our body. These drugs are known as suicide inhibitor. Now remember, suicide inhibitors are also known as hit and run drug. They are very long acting drug even after stoppage. Sir, why? Because they inhibit their enzyme. Because they will inhibit the enzyme in which fashion? In irreversible fashion. Because they are irreversibly attached to an enzyme. Even after stoppage, their action continues in our body. So what are the drug we have to remember? Remember BARP. ठीक है, वैसे तो कोई भी निमोनिक बना लो. सो फर्स्ट इज बेंजब्रोमारोन. लास्ट ईयर MCQ. I will tell you this drug is used in gout. Then we have aspirin. Aspirin inhibit COX enzyme. In which fashion? Irreversible fashion. Ritonavir. Vir word आ रहा है. वायरस ड्रग. एड्स वायरस. आविर वर्ड आ रहा है. एड्स वायरस का ड्रग है. इट इनहिबिट्स प्रोटीएस एंजाइम इरिवर्सिबली. एंड लास्टली ऑल PPI, प्रोटोन पंप इनहिबिटर, omeprazole, pantoprazole are irreversible inhibitor. Now, a patient with a history of ischemic stroke was started on clopidogrel. Clopidogrel, I will tell you, it's an antiplatelet drug. Now, after 6 months, she had another attack of stroke. What could be the possible reason for the failure of clopidogrel? Remember, clopidogrel is a prodrug. It needs to be converted into active form. As an active form, it is given in the treatment of MI and stroke as an antiplatelet drug. So which CYP enzyme converts clopidogrel into active form? So how to remember? Clopidogrel, CL word is coming. Let's write C and L word one together. है ना? C and L एक जैसा हो गया. So the answer is CYP2C19. So some people have less amount of CYP2C19 in which clopidogrel will not be converted into active form. Now the next word is O. You can see O word is coming. O word aa raha hai. There is a drug known as omeprazole. Omeprazole, remember, inhibits CYP2C9. So can we say it will inhibit the conversion of clopidogrel into active form? So which proton pump inhibitor should be avoided with clopidogrel? You can see the word O word is coming. Now let's see the next word. Next word you can see P word is there. तो P से लिखेंगे हम कौन सा बेटा ड्रग? पेंटोप्राजोल. और पेंटोप्राजोल का एक भाई भी लिख लो विच इज वेरी फेमसली यूज नाउअडेज, rabiprazole. Rabiprazole and pantoprazole has no CYP or least CYP inhibiting action. So they are safe to be combined with which drug? They are safe to be combined with clopidogrel. They are safe to be combined. So now let's see the first drug interaction. So clopidogrel is converted. Omeprazole is a CYP inhibitor. So that is why we avoid combining omeprazole with clopidogrel. Next is very important, estrogen. You know, estrogen is a part of OCP, oral contraceptive pill. Estrogen in our body is degraded by one CYP enzyme, CYP3A4, rifampicin, P-glycoprotein inducer plus CYP inducer. It will increase the activity of CYP enzyme. Estrogen will get rapidly degraded. So can you say that if we combine rifampicin with estrogen, it will lead to contraceptive failure. It will lead to contraceptive failure. Now let's talk about three drug, cat drug, cisapride, drug for constipation, estimazole and terfenadine, antihistaminic drug. They are also degraded by CYP3A4. Now when you combine them with antibiotics like erythromycin, ketoconazole, antibiotics are CYP inhibitor. So can we say they will inhibit the degradation and it can lead to toxicity of cat drug? And toxicity of cat drug, they will go to heart. On heart, they can lead to QT prolongation, and QT prolongation can lead to one dangerous arrhythmia known as torsades de pointes. That is why this cat drug, because of the risk of this fatal arrhythmia, they got banned. And which antibiotic make them banned? Erythromycin and ketoconazole made cat drugs banned or withdrawn from the market because of the risk of arrhythmia. Very good. Next question. True about first order kinetics. So I'll come back to this question. Let's talk about first order kinetic and zero order kinetic, that how, by what speed the drug will be eliminated out of the body. Now remember, first means very good people. In first, remember, the clearance capacity or the power of the body is very good. So clearance capacity is very high. The power of the body to remove a drug, to eliminate a drug is very good. But in zero order kinetic, zero people are useless. The clearance capacity or the power of the body to remove the drug is very low. So zero people तो पहले ही बड़े low होते हैं. They always remain very tired and saturated. So it is also known as saturation kinetic. So how the drug will be removed? See, in first order kinetic, if I will give 100 milligram of a drug, in let's say first half-life, 50 will be removed. 50% of the drug will be removed. In equal amount of time, again 50% of the drug will be removed. So remember, in first order kinetic, a constant fraction of a drug is removed. Let's say 50-50%. But in zero order kinetic, every time a 10 milligram. So this is just an example. An equal amount of a drug is removed because the power of the body is very low. So here the constant amount of a drug is removed, let's say 10 milligram. Now can we say that in first order kinetic, elimination is directly proportional to plasma concentration? The more drug you will give, the more drug will be eliminated outside. But in zero order kinetic, can we say elimination of a drug is constant? Every time only 10 milligram of a drug is removed. While in first order kinetic, half-life remains constant. Every time equal amount of time is required to make a drug half. But in zero order kinetic, half-life depends upon plasma concentration. More drug in plasma, more time it will take to become half. Now remember one point. That this is a trick. See, elimination becomes directly proportional to plasma concentration in first order, while in zero order, half-life is directly proportional to plasma concentration. In zero order, half-life is constant, while in first order, half-life is constant. In zero order, elimination is constant. How the graph we will make? If we make the graph of plasma concentration with time, every time 50% of the drug is removed, and in zero order every time a equal amount of a drug is removed. So can you tell me which graph will be straight line? Yes, zero order kinetic, there is linear decrease in plasma concentration, while in first order kinetic the graph is curved, there is exponential decrease in plasma concentration. Fine. Now which drug shows zero order kinetic? Remember three drug: ATP. A for alcohol, very important, and A for aspirin. T for theophylline, and P for phenytoin. Now remember, all drugs in high concentration show zero order. Same drug in low concentration shows first order. But which drug only show pure zero order kinetic? Alcohol. Which drug shows 0 plus pseudo zero order kinetic? Phenytoin. Just cram this word. Now let's move to the previous question. Tell me the answer of this question. Tell me the answer of this question. First order kinetic. In first order kinetic, half-life is constant, but elimination changes with plasma concentration. So this is the correct answer of first order kinetic. But see the next option. Elimination is constant, but half-life changes with plasma concentration. This is seen in zero order kinetic. This is seen in zero order kinetic. Understood this part? Now let's move to the next question. What is the true about competitive antagonist? So let's see the graph first. Now remember, there are two types of antagonists, competitive and non-competitive. Now suppose I have given an agonist and I am seeing how much effect is produced by agonist on dose response curve. So this is log dose response curve. I am giving the dose of agonist in log and I can see the graph is sigmoid in shape. Okay, now I have added an antagonist. Remember, in cases of competitive antagonists, the dose response curve will shift to the rightward. While in non-competitive antagonists, the dose response curve will shift downwards. It will shift downwards. Now remember one point. Response is known as Vmax. Dose is known as Km. Dose को क्या बोलते हैं? Km. So remember these 3 points now. In competitive, rightward shift in DRC. DRC is dose response curve. Non-competitive, there is downward shift in DRC because you cannot overcome the effect of non-competitive antagonist. You can overcome the effect of competitive antagonist by increasing the dose of agonist. So what will happen to Vmax in competitive? Can any student can tell me? Can you see Vmax? Can you see Vmax? Can we say Vmax will remain same? It will remain unchanged. But to produce the dose, but to produce the response, you need to give higher dose of agonist to win the competition. The Km or the dose required will be increased. Now, in case of non-competitive, you cannot produce same level of response. There is downward shift, so the Vmax will become less. And lastly, will there be any change if you increase the dose of agonist? No, you cannot overcome the effect of non-competitive. See, you can only overcome the effect if you are having a competition. Only then you can make, only then you can win. So you can overcome the effect in cases of competitive. Now what I have done, in this dose response curve, I have made this graph reciprocal. When I make this graph reciprocal, let's say 1 by V, 1 by V is known as 1 by response, and x-axis 1 by Km, 1 by Km means 1 by dose. So when I make this graph reciprocal from sigmoid, this graph becomes straight line. When I reciprocal dose response curve, the graph becomes straight line. Because it is a straight line, we call this graph as लाइन वीवर बर्ग प्लॉट. लाइन वर्ड आ रहा है तो लाइन बन जाता है, लाइन में ऑपोजिट हो जाता है. नाउ कैन यू टेल मी बेटा, कैन यू टेल मी दैट इन विच केस द वी मैक्स विल रिमेन सेम. वी मैक्स जो है सेम किस में रहता है? कैन वी से इन दिस ग्राफ वी मैक्स इज सेम एंड इन द नेक्स्ट ग्राफ के एम इज सेम. So can you tell me in which graph the Vmax remains same? Competitive. So this is a graph of competitive antagonist and this is a graph of non-competitive antagonist. Now let me give you a trick how to remember it. Remember, in cases of competitive antagonist, competitive means the graph will cross. The lines will cross among themselves. If the lines are crossing, it is competitive. If the lines are not crossing, not crossing means non-competitive antagonist. लाइन क्रॉस करेंगी तो कॉम्पिटिटिव मार्क करना है, नहीं क्रॉस कर रही नॉन कॉम्पिटिटिव मार्क करना है आपने. ठीक है बेटा, वेरी गुड. Now let's talk about calculate the therapeutic index of a sedative drug from a given diagram. Now what is therapeutic index? Therapeutic index is LD50 upon ED50. Now what is LD50? LD50 stands for lethal dose in which a person will die in 50% of population, while ED stands for effective dose in 50% of population. Now if we see what is the ED50 out here, ED50 is this one. And what is the LD50? LD50 is this one. So can we say it is 400 by 100? It is 400 by 100. So the answer out here is B. Answer is B. Now can we say this is the area between ED50 and LD50? This is known as therapeutic index. Don't you think if I will give the dose above LD50, the drug will become toxic or lethal? So what does this therapeutic index is telling me about? This therapeutic index, it tells me about the safety margin of a drug, that how much gap is present between LD50 and ED50. If the gap is very large, the drug is safe. If the gap is very small, the drug is very unsafe. It can produce toxicity very easily. Understood? So what does this therapeutic index tells you about? It tells you about the safety margin of a drug, the gap between LD50 and ED50. Now let's talk about, for this was the last year question, for vancomycin dosing, which nomogram scale is normally applied. Now beta, what do you mean by the word nomogram? Nomogram is a graph. Nomogram is a graph which measures the plasma concentration of a drug, and it correlates with the toxicity. Remember, if the plasma concentration is very high, the drug will be toxic. Agreed? So nomogram. Now various drugs, we monitor their effect, we monitor their toxicity by making this graph. Now let's see this graph. This graph is known as Rumac Matthew nomogram. It is used for paracetamol. So there is a line, plasma concentration is this one, and this is time. And if the concentration of paracetamol is above this line, above this plasma concentration, it is hepatotoxic. And if it is below this, the drug will be safe. So these nomograms, their names are given with respect to scientist name. In case of vancomycin, this nomogram is known as Metzger scale. So Metzger scale is a nomogram which we make for vancomycin. Rumac Matthew nomogram we make for which drug? Paracetamol. Agreed? And Halsted nomogram we make for an antibiotic aminoglycoside. You know aminoglycoside? Streptomycin, gentamicin, they all are aminoglycoside. Remember them. This is important. Yes, vancomycin has other nomograms also. But this was a question which was asked. Now let's talk about match the following ligand to its corresponding receptors. So first is insulin. The receptor of insulin is tyrosine kinase receptor. Agreed? Now just with insulin, right? IGF, insulin-like growth factor also. Insulin and insulin-like growth factor, they act on tyrosine kinase receptor, which causes cell division. T3 and T4 hormone, thyroid. Thyroid has intranuclear receptor. So thyroid has intranuclear receptor. Okay. Calcitriol, which is vitamin D. Vitamin D has intracytoplasmic receptor. And lastly, leptin hormone, satiety hormone. It has JAK-STAT receptor. It has JAK-STAT receptors. So let me tell you a little bit about the receptors one. Okay. Now, nicotinic, which is a receptor of acetylcholine. 5-HT3, serotonin, another name is 5-HT, 5-hydroxytryptamine, glutamate and GABA receptors, they are inotropic receptors. They are inotropic receptors. Muscarinic receptor of acetylcholine, angiotensin, dopamine receptor, they are GPCR, which is G protein coupled receptors. Insulin and IGF, they are tyrosine kinase receptor. Growth hormone, cytokines, leptin, they are JAK-STAT receptors. They are JAK-STAT receptor. Now steroids and vitamin D3. Vitamin D3 is calcitriol. They are cytoplasmic receptor inside the cell. While thyroid and vitamin A, retinoic acid receptors, they are nuclear receptors which are present inside the nucleus. Try to remember them. Now let's talk about one receptor in great detail. Question comes, that is G protein coupled receptor. So the shape is serpentine receptor. It is a serpentine receptor. So and it is looking like a snake. And this snake is making how many turns? Let's count the number of turns. So it is making 7 turns. So it is 7 serpentine receptors. And on the tail of this receptor, there is a protein known as G protein. There is a protein known as G protein. So that is why they are known as G protein coupled receptor. Serpentine, in tail we have G protein. Now this G protein is of 3 types. This G protein is of 3 types. GQ, GI and GS. So you can remember KISS word. If it is GQ type, inside the cell, it will activate an enzyme known as PLC. PLC stands for phospholipase C. If it is GI, I means inhibitory, it will inhibit adenylyl cyclase. It will inhibit adenylyl cyclase. S means stimulatory, it will activate adenylyl cyclase. So rest is very simple. Both I and S are acting through adenylyl cyclase, GQ phospholipase C. Now when these enzymes are activated, they will increase and decrease the amount of molecule inside the cell. So PLC will increase IP3 and DAG, inositol triphosphate and diacylglycerol. GI, it will decrease cyclic AMP. And GS, it will increase cyclic AMP. Very logical, आसान हो गया काम. And these molecules will produce effect inside the cell. And these molecule, PL, IP3, DAG and cyclic AMP, they are known as second messenger. They are known as second messenger. So which receptor acts with the help of second messenger? That is GPCR. GPCR, very important. Now let's talk about phase 1 trial is not done for. So let me come to the first trials. Clinical trial. Clinical trial is human testing of a drug. Before a drug can approve and come into the market, we must test a drug. So when we test a drug in human, after that the drug comes into get market, we call them as phases or clinical trial phases. Clinical trials are done in phases. So we go in this direction. First we start with phase 1 trial. Then we go to phase 2 trial. Then we go to phase 3 trial. Now remember, after phase 3 trial, the drug gets market approval. So can you tell me the drug comes into market after which phase of clinical trial? After phase 3. And when the drug comes into the market, we keep on testing a drug, checking the drug. This is known as phase 4 trial. So phase 4 trial is done after market approval of a drug. That is why phase 4 trial is also known as post-marketing surveillance. Surveillance means to keep check on something. Now let's see how we do. In phase 1 trial, which is also known as safety and pharmacology trial, first we check the safety of a drug. Agree? Do you agree? So we take 2 to 5 healthy human, 20 to 50 healthy human, and the trials are unblinded. Agreed? What is the main purpose? To check safety of a drug. So that safety limit after which the drug becomes toxic, this safety limit is known as MTD. MTD stands for maximum tolerable dose. That is the safety limit of a drug. And we check pharmacokinetics, absorption, bioavailability, half-life, etc. etc. Now, can we say that phase 1 trial is done in healthy human? That is why it is not done to find effect of a drug. It is not done to find efficacy of a drug. Because if you want to check the effect of a drug, you will not take healthy human, you will rather take patients. Okay, agreed? तो अगर हमें ड्रग का इफेक्ट देखना है तो पेशेंट लेना पड़ेगा. Phase 1 trial is done in healthy human. So let's see the answer of this question. So what is the answer of this question? Phase 1 trial is not done for. Phase 1 trial is not done to find efficacy of a drug because it is done in healthy human, not in patient. Agreed? Now, after you have found the safety limit, now let's explore and confirm the efficacy of a drug. Efficacy is also known as therapeutic. Therapeutic means whether the drug is effective or not. So therapeutic exploratory trial, 200 to 500 people. We will take patient. Therapeutic confirmatory trial, thousands of patients. And both trial are RCT with blinded trial. RCT with blinding trial. Now, what do you mean by RCT? Randomized control trial. In phase 2 trial, we will give in one group, I will give my test drug. In another group, I will give a similar looking drug known as placebo. And I will explore efficacy. Explore efficacy means whether the drug is effective, yes or no. So whether we have a proof whether the drug is effective, yes or no. So if the drug is effective, yes, then we go to phase 3 trial. So that is why phase 2 trial are also known as proof of concept trial. Whether the drug is having any proof whether it is effective or not. And if the drug is found to be effective, now we will test this drug in thousands of patients. That is phase 3 trial. So in one group, I will give my test drug, and now I will compare my drug with the best treatment available in the market, that is gold standard treatment, because after phase 3 the drug will come into the market, and I will confirm the efficacy of a drug. Confirm the efficacy of a drug means I will find the actual dose of a drug in which a drug is found to be effective. So let me ask you one question, beta, from all of you. Tell me the answer of this question. Which phase of clinical trial are comparative efficacy trial? Comparative efficacy trial means I am comparing my efficacy with already available treatment in the market. So yes, phase 3 trial, one more name, they are also known as comparative efficacy trial, because I am testing my drug and finding and comparing this drug with the best treatment available in the market. Understood this part? Now when the drug comes into the market, we will keep on checking the safety of a drug, that is post-marketing surveillance. How many patients are taking your drug? We cannot count. We cannot make a patient blinded. And we find rare or missed side effect of a drug. We find rare or missed side effect of a drug. Understood this part? Great. Now let's talk about match the following drug with their corresponding schedule under a law known as Drug and Cosmetic Law. Now remember, I'll go from here. Schedule G. G means the drugs which are given under medical supervision, which are given under medical supervision. That means patient will not take the drug himself or herself at home. Patient will take a drug. The doctor or a nurse will only give a drug to the patient. My question from you student is, can you take vaccines yourself at home? क्या आप वैक्सीन खुद ले सकते हो? क्या आप वैक्सीन ले सकते हो? So yes, the answer is Schedule G is hepatitis B vaccine. Schedule G is hepatitis B vaccine. Then we have Schedule X. X means addictive drug, जिनका addiction होता है. Addiction means narcotic drugs. तो X is always addictive. X तो सबकी addictive होती है. Can you tell me which drug is X addictive here? Addictive will be morphine. It will be morphine. Makes sense? Now Z. Remember in nursery class, we all used to say Z for zebra. Z for zebra. Zebra is animal. Zebra animal होता है ना? तो animal में जो drug use होते हैं उनको क्या बोलेंगे? We call these drugs as veterinary drugs. So that will be Z. Last which is remaining is insulin. Insulin comes in H. H is known as prescription drug. Insulin is prescription drug. Patient himself and herself can take at home, and insulin is not an addictive drug. It is just a prescription drug. That is H. Now you can tell me the answer. Now you can tell me the answer. So yes, the answer I think is A. A है ना answer? चलो ठीक है. Now remember, what are Schedule X drug? एक बात बताओ. Schedule X drug अलग चीज है. Schedule X drug is addictive drug. What is Category X drug? Category X drug means teratogenic drug. Category X drug is teratogenic drug. Schedule X drug is addictive drug. Okay? Okay. Insulin beta you can take at home na yourself. Diabetic patient can take insulin himself and herself at home. It is not necessarily it require medical supervision. So it will not come under G. Understood this part? Now let's talk about drugs for rare disease. Drugs for rare disease are orphan drugs. Now, what do you mean by rare disease? The prevalence of this disease is less than 1 per 5 lakh population. Then we call these drugs as orphan drug. Agreed? Dummy drug. Dummy means similar looking drug, but it will not contain active substance. It rather contains inert substance. And see the answer. It is used to maintain blinding in RCT. Tell me the answer. Yes, very good. That is placebo. Now, opposite to orphan drug, that is drugs for highly prevalent disease. Orphan drugs are for rare disease. Drugs for highly prevalent disease are known as essential drugs. They are known as essential drug. So don't you think essential drug should be cheap, cost effective, a price which people can afford, and we should not combine these drugs with other drug. It will unnecessarily increase the price of a drug. Avoid them as FDC. Avoid them as fixed dose combination. These drugs should be available as a single medicine. We should not combine them as FDC. Okay. Now let's talk about a 35-year-old chronic hypertensive woman visits to OPD for preconception counseling. Which of the following anti-hypertensive drugs should she discontinue? So कौन सा drug pregnancy में नहीं देना? So the answer out here is prill wale drug, angiotensin convertase enzyme inhibitor. So let's make a list of first teratogenic drug. Category X drug, thalidomide. So thalidomide in fetus, which malformation it can lead to? It can lead to phocomelia. Phocomelia means, phoco means short, melos means limb. Lithium can affect heart. In heart, it can lead to Epstein anomaly. Remember, it is Epstein with B, not with P. अगर हम B को P कर देंगे तो कहानी दूसरी हो जाएगी, है ना? It is Epstein, not Epstein. Epstein तो आइलैंड है ना? वहां पे तो लोग दिल लगाते हैं, है ना? लिथियम तो एप्स्टीन वाला है, ये तो दिल को खराब करता है, ठीक है? तो एब्स्टीन में दिल लगाते हैं लोग, लिथियम एब्स्टीन करता है, हार्ट खराब होता है. Then remember ACE inhibitor, they will end with the word pril. And angiotensin receptor blocker, they will end with the word sartan. And these are antihypertensive drug. In fetus, they can inhibit kidney formation, renal agenesis. Then we have warfarin. It inhibits vitamin K. Vitamin K is required for bone and cartilage formation. So it can lead to bone and cartilage defect. Remember one defect in nose, saddle nose. Saddle nose. Carbimazole, methimazole, anti-thyroid drug. दे कैन इनहिबिट स्किन फॉर्मेशन. स्किन नहीं बनेगी तो बोलेंगे एप्लेसिया क्यूटिस. यू कैन सी स्किन नहीं बनी हुई इस बच्चे की. दिस इज एप्लेसिया क्यूटिस, स्कैल्प एरिया में. वेल्प्रोइट एंड मीथोट्रेक्सेट आर एंटीफोलेट ड्रग. इनसे फोलिक एसिड की डेफिशिएंसी होती है, सो दे कैन लीड टू एनटीडी, दैट इज न्यूरल ट्यूब डिफेक्ट लाइक स्पाइना बाइफिडा एक्सेट्रा. Agreed? Spina bifida, etc. So now let's talk about pregnancy. This is a very important slide for you. Very favorite slide for INI-CET exam. Pregnancy, various disorder, which drug to be given, which drug is contraindicated. So epilepsy in pregnancy, remember 2L. The drug of choice or anti-epileptic drug in pregnancy is levetiracetam. If levetiracetam is not given, go with lamotrigine. Go with lamotrigine. But which is the most teratogenic anti-epileptic drug in pregnancy? We know valproate, neural tube defect. So never start valproate in pregnancy. Bipolar disorder, we prefer to start with antipsychotic drug like olanzapine, quetiapine, clozapine. पीन वर्ड आएगा है ना, पीन वर्ड आएगा, olanzapine, quetiapine, clozapine. But which drug is the most teratogenic? It is not lithium. It is again and again valproate. Never start valproate. Now hypertension in pregnancy, let's call it as PIH. Pregnancy induced hypertension. For drug LHMC, Lady Harding Medical College. L for labetalol, which is the drug of choice for PIH or preeclampsia. H for hydralazine. M for methyl dopa. And C for calcium channel blocker, nifedipine. And recently new update, nicardipine can also be given. Nicardipine can also be given in pregnancy. Now which drug you will never start? That is ACE inhibitor and angiotensin receptor blocker ARB. That is pril और sartan वाले drug कभी भी प्रेगनेंसी में नहीं देने, रीनल एजेनेसिस हो जाएगा. हाइपरथायरॉयडिज्म इन प्रेगनेंसी, फर्स्ट ट्राइमेस्टर, पहले ट्राइमेस्टर में देना है पीटीयू. पीटी मींस पहला ट्राइमेस्टर. सेकेंड एंड थर्ड ट्राइमेस्टर में दो ड्रग दे सकते हो, दैट इज कार्बीमazole एंड मेथीमazole. दे आर द ड्रग ऑफ चॉइस. नेवर इंटरचेंज द ड्रग इन ट्राइमेस्टर. पीटीयू सेकेंड थर्ड ट्राइमेस्टर में नहीं देंगे, कार्बीमazole मेथीमazole फर्स्ट ट्राइमेस्टर में नहीं देंगे. एंटीकोगुलेंट, ओवरऑल ड्रग ऑफ चॉइस इज हेपारिन. Overall drug of choice is heparin. Heparin is safe in all trimesters. It is safe in all trimester. But what about one oral drug, warfarin? Remember, warfarin can be started after 12 weeks. After first trimester, we can start warfarin. Up to 12 weeks, we don't give warfarin in the female. Agreed? Yes. Now let's talk about antimicrobial on public demand. ठीक है, पब्लिक डिमांड पे एंटीमाइक्रोबियल. ओके, सो लेट्स ब्रीथ फॉर 3 seconds. ठीक है, 1 2 3 हो गया. लेट्स स्टार्ट विद एंटीमाइक्रोबियल. अ मेल पेशेंट विद पुरुलेंट डिस्चार्ज फ्रॉम penis, microscopic revealed gram negative diplococci. What is the treatment of choice? Any guesses? Gram negative diplococci urethral discharge. Yes, that bacteria is Neisseria gonorrhea. So what is the drug of choice? The drug of choice is ceftriaxone. Drug of choice is ceftriaxone. Now you don't have to cram anything now. Understand, just imagine any gram negative bacteria which spreads in community, we give ceftriaxone. Can we say meningococci caused by Neisseria meningitidis? It spreads in community through aerosols. Gonococci spreads in community by sexually transmitted disease. Typhoid, salmonella spreads in community by eating golgappe or pani puri, unhygienic food. H influenza also spread. Any gram negative infection which spreads in community gives ceftriaxone. Okay, ceftriaxone. Ceftriaxone is given by injection. Now it is a cephalosporin. Can you tell me which generation of cephalosporin it is? Ceftri word is coming. Yes, it is a third generation cephalosporin. But understand, if you don't want to give injectable drug, you can give oral drug also, cefixime. So remember, zeme and zone word is coming, these drugs are given. Now the story becomes totally opposite. Story becomes totally opposite if there is hospital acquired infection. Don't you think in hospital person is on ventilator? So these bacteria, they are not spread in community. They cause hospital acquired infection like VAP. What is VAP? Ventilator associated pneumonia. Patient has Foley's catheter, catheter associated UTI. Similarly, bloodstream infections like very important bacteria Klebsiella, Pseudomonas, Acinetobacter, and here the drug of choice is any gram negative infection which causes hospital acquired infection. We give a class of a drug carbapenems, and any drug which is a carbapenem, it will end with the word penem. So can we say meropenem, imipenem? Similarly, Burkholderia capacia, it causes bloodstream infection due to IV drip. Serratia proteus, so very atypical bacteria. Now understand one point out here. There is a drug imipenem. Among all carbapenem, imipenem is a highly or most neurotoxic and nephrotoxic carbapenem. That is why imipenem is combined with the drug cilastatin. Why? Cilastatin reduce the toxicity of imipenem by inhibiting one enzyme, DHP1 enzyme. So this DHP1 enzyme, which is dihydropeptidase enzyme, you don't have to remember the full form. This enzyme converts imipenem into toxic form. So inhibit DHP by cilastatin, always combined with carbapenem. Now one step ahead. If these bacteria become resistant to, if they become resistant to carbapenem, then we give a drug colistin. Then we give a drug colistin. Okay, then we give a drug colistin. But point to be remember is these three drugs BSP, these drugs are resistant. These bacteria are resistant to colistin. So colistin is only given in cases of, it is only given in cases of Klebsiella, Pseudomonas, Acinetobacter, but it is not given in cases of Burkholderia, Serratia and Proteus. Okay. Now let's move ahead. Penicillin, cephalosporin and carbapenem, they are beta-lactam group of antibiotic and they inhibit cell wall. They inhibit cell wall by inhibiting an enzyme, transpeptidase enzyme. Transpeptidase enzyme. Vancomycin also inhibits cell wall. Vancomycin also inhibits cell wall. How vancomycin inhibits cell wall? Vancomycin bind to D-alanine. D-alanine. Remember, these are peptides in peptidoglycan cell wall, and it inhibits attachment of glycans. Glycans means sugars. So it inhibits an enzyme, transglycosylase enzyme. How we can remember? Remember, cell wall is made up of peptidoglycan. So the first part, peptidase, is inhibited by beta-lactams, penicillin, cephalosporin, carbapenem. Second part in peptidoglycan is glycosylase sugars. So glycans are inhibited by vancomycin by binding to D-alanine and D-alanine. But all these drugs which are cell wall inhibitor, they are not effective in cases of mycoplasma. They are not effective in cases of chlamydia. They are not effective in cases of rickettsial infection. Can you tell me why penicillin, vancomycin are not effective? Because they lack cell wall. These bacteria are atypical bacteria. They don't have cell wall. Okay. Now, what is the drug of choice for penicillin allergy? So just imagine when you are eating amoxicillin, it becomes very costly. So we rather take azithromycin sometimes for our sore throat. So in penicillin allergy, we can also give erythromycin, azithromycin. Longest acting penicillin is benzathine penicillin. Agreed? And benzathine penicillin is the drug of choice for, because it's a longest acting drug, it is given for prophylaxis of rheumatic fever or rheumatic carditis. Benzathine penicillin is also the drug of choice for syphilis. Except which stage of syphilis? Except neurosyphilis. In neurosyphilis, we give aqueous penicillin. So penicillin, which can act against both Pseudomonas and Klebsiella, is piperacillin. It is the best penicillin we have, active against all bacteria. Now let's talk about penicillinase resistant penicillin. They are given like cloxacillin and dicloxacillin. They are given for MSSA. MSSA stands for methicillin sensitive staph aureus. But what is the drug of choice for MRSA? MRSA, we give vancomycin. So agreed? So MSSA is different, MRSA is different. Now in vancomycin resistant cases of staph aureus, we give linezolid. Or we can give a better drug, daptomycin. Daptomycin is now better drug for VRSA. Topical drug for MRSA, mupirocin cream. कौन सी क्रीम MRSA में देनी है? 2% mupirocin cream. Red man syndrome is a side effect of vancomycin. Why vancomycin causes red man syndrome? Because it causes histamine release from mast cell. Histamine causes flushing. It leads to red man syndrome. Now remember, in MRSA, we give IV vancomycin. Oral vancomycin is not absorbed, but oral vancomycin, a new drug fidaxomicin, one antibody besletoxumab, and fecal transplantation. It is done for an infection known as pseudomembranous colitis. Pseudomembranous colitis is caused by which bacteria? Clostridium difficile bacteria. It occurs when we give antibiotic, broad spectrum antibiotic. They kill our good GIT bacteria and this harmful bacteria grows. And which antibiotic causes pseudomembranous colitis? The antibiotic having highest risk of causing pseudomembranous colitis is clindamycin. It is clindamycin. Now, what about toxic shock syndrome? In toxic shock syndrome, which occurs because of super antigens of Staphylococcus and Streptococcus, which can lead to, it is caused by staph and it is caused by Streptococcus, in which the patient will go into shock and the patient can have scalded skin also. For the treatment of toxic shock syndrome, to kill bacteria, we give IV vancomycin. It will kill gram-positive bacteria, dangerous bacteria. But to reduce toxin production in toxic shock syndrome, we give clindamycin for the treatment. Here we give clindamycin for the treatment. Now, tell me okay, just remove this word. This slide will come, okay? This slide will come again. Tell me the answer last year question. A patient presented to emergency with fever, headache, stiff neck, vomiting, confusion, photophobia, Kernick sign is positive. Can we say patient is suffering from which disease? Patient is suffering from meningitis. Which of the following is the appropriate empirical treatment? Empirical means we don't know which bacteria has caused it. So the answer is A. So let me tell you, very important topic. empirical treatment of meningitis. So these are the features. The most common organisms which causes meningitis are meningococci, H. influenza, streptococci, and staphylococci. So when a patient comes to us to cover all this bacteria, we give injections of ceftriaxone because it will cover the all commonly caused bacteria. Now, after giving ceftriaxone, let's say you have done lumbar puncture or lumbar tap. You have taken out CSF sample, and after taking CSF sample, you found there are other bacteria which are causing it. Now, if let's say you find MRSA to this ceftriaxone, now you will add specific treatment. For MRSA, you will add IV vancomycin. If Listeria infection comes, then you will add ampicillin. Then you will add ampicillin. If rickettsia or chlamydia comes, remember ceftriaxone is not effective because they lack cell wall. Here you will add a drug doxycycline. You will add a drug doxycycline. And which virus? Herpes simplex virus. You will add a drug acyclovir. So this is how you treat meningitis. Understood this part? Very important slide for you. Now let's talk about what is the most appropriate treatment for a diabetic patient with complicated UTI presenting with septic shock? What is the answer of this question? This is the last year MCQ. Anyone, what is the answer of this question? A tough one, but we will make it very simple. Don't worry. Yes, absolutely right. So your preparation is very good. I'm so proud of you. The answer is meropenem. So let me tell you, urinary tract infection. Let's say the patient is having cystitis, only cystitis, bladder infection. We call this as uncomplicated UTI. We call it as uncomplicated UTI. The infection is in bladder, cystitis. And we have first line drug. We have three first line drug, CCN. C for ciprofloxacin. We have cotrimoxazole. And we can give nitrofurantoin. We can give nitrofurantoin. But let's say from bladder, this infection went to kidney. Let's say this infection went to kidney. If it went to kidney, can we call it as pyelonephritis? Complicated UTI. So here you will start beta lactams. Beta lactams like amoxicillin. And to protect this amoxicillin, I will add clavulanic acid. So what is clavulanic acid? It is a beta lactamase. Beta lactamase enzyme degrades amoxicillin. So it is a beta lactamase inhibitor. Similarly, you can start piperacillin. Tazobactam. Tazobactam is also beta lactamase inhibitor. Okay. Now the point is, if this infection goes into blood, if it goes into the blood from kidney, the patient can go into shock and sepsis when it comes into the blood. Here you will start carbapenems. You know the name of carbapenem like meropenem, imipenem, etc. Meropenem, imipenem, etc. So now you know how to treat UTI. Now what about UTI in pregnancy? UTI in pregnancy, these drugs should be avoided. And what is the drug of choice? The drug of choice for UTI in pregnancy is beta lactams with beta lactamase inhibitor. Beta lactam with beta lactamase inhibitor are the drug of choice. Don't give this drug in pregnancy. Give these drugs in pregnancy always. Any type of UTI in pregnancy. Understood? So see, read this question if somebody doesn't know what is the best answer out here. So can we say UTI with shock and sepsis ho gaya hai? So your answer will be carbapenems. Understood this part? Now let's talk about fluoroquinolone, few point. Fluoroquinolones, these drugs they end with the word floxacin. And these drugs they inhibit DNA gyrase enzyme. Recent MCQ. DNA gyrase, we can also write it as topoisomerase 4 enzyme, which is required for DNA replication. Ciprofloxacin, you will write CYP inhibitor. Levofloxacin, no CYP inhibitor. It has 100% oral absorption or bioavailability. Now, very important point. Levofloxacin is liver safe. Levofloxacin is liver safe. But if you talk about PMT, 3 and 3-fluoroquinolone, PMT, pfloxacin, moxifloxacin and trovafloxacin, they are hepatotoxic. This question is coming many times. 3-fluoroquinolones which are hepatotoxic, PMT. But these 3-fluoroquinolone, they damage liver, but they are renal safe. They are good for kidney, but they are bad for liver. What are the side effects of fluoroquinolone? PQT. They can cause photosensitivity, first MCQ. They can cause QT prolongation on heart, and on they can cause in old age, fluoroquinolone can cause rupture of, they can cause rupture of Achilles tendon. They can cause rupture of Achilles tendon, which is known as tendinitis. It is known as tendinitis. Agreed? Question comes commonly on fluoroquinolone. So let's see the answer of this question. Which of the following is the incorrect match for the use of the following antimicrobial? So enterococcal endocarditis. Remember, enterococci is a gram-positive bacteria. Any serious gram-positive infection, straight away start vancomycin. So vancomycin, any dangerous or serious gram-positive infection. Can we say enterococci is a gram-positive? Staphylococcus is also gram-positive, MRSA. Toxic shock syndrome is also gram-positive. So any gram-positive dangerous infection, we give vancomycin. It is not effective in gram-negative. Second we have is rickettsia. Rickettsia does not have cell wall. So the answer or drug of choice for rickettsia we have already discussed is doxycycline. Now we will come to this bacterial vaginosis. So the answer is B. We have already discussed B. Okay. Incorrect match is B. I think the options are not matching. Forget it. So the only answer which is false out here is B. Okay. B. Okay. So B is false. A, C and D are correct. So A, C, D are correct. So go with the C one. Okay. Now let's talk about, guess this infection. A female who comes to you with gray-white, fishy, smelly discharge, and on vaginal discharge, clue cells are present. Vaginal pH is not very acidic now. The vaginal pH is becoming towards neutral or basic. This is known as Amsel criteria. Can you tell me which infection we are talking about? Yes, we are talking about bacterial vaginosis. ठीक है, चलो next बात करते हैं. Now the female is having yellow-green discharge and there is strawberry cervix, which is also known as hemorrhage in cervix. Which infection I am talking about? Yes, we are talking about Trichomonas vaginalis infection. Understood? In both this infection, the drug of choice is metronidazole. Etc. Etc. means any drug which ends with the word nidazole, like ornidazole, tinidazole. So you can give any drug which ends with the word nidazole. So they are the drug of choice. But remember, metronidazole is contraindicated in alcoholics. Why? Can you tell me why? Because people who live in metro cities, they drink a lot. People who live in metro cities drinks a lot because metronidazole can cause disulfiram-like reaction. It can cause disulfiram-like reaction. Understood this part? Let's move ahead. A male patient presented with painful red vesicle on genital region from past 2 weeks. Zank smear shows below image. So you can see big cells out here. है ना? So big cells, multinucleated giant cells. You can see multinucleated giant cells. है ना? You can see. So which infection it is? Yes, we are talking about herpes virus infection. So this is herpes virus infection. What is the drug of choice? Virus है तो कौन सा drug दोगे? Acyclovir. The drug of choice is acyclovir. Now, what is this oseltamivir? Oseltamivir is a neuraminidase inhibitor, and it is a drug of choice for flu virus. Flu virus means influenza virus. Influenza means H1N1, swine flu, H5N1, that is avian flu. So it is a drug of choice for flu virus. Understood this part? Now let's talk about all the herpes virus. Herpes simplex 1, herpes simplex 2 and varicella zoster virus, we give acyclovir. So from acyclovir we made other drug, valcyclovir, which is a prodrug of acyclovir, pencyclovir, femicyclovir. But if you talk about cytomegalovirus, then the drug of choice is CMV virus का क्या है? Ganciclovir. Ganciclovir. Now in acyclovir and ganciclovir resistant cases, we can give foscarnet and we can give cidofovir. And this cidofovir, it is the drug of choice for respiratory papillomatosis also, which is caused by which virus? Papilloma virus, again a DNA virus. So cidofovir, all DNA virus, it is effective. Now the point is, we have a new drug against cytomegalovirus. That new drug is fomivircine. Fomivircine. Now remember, from this ganciclovir, we made a drug valganciclovir, which is a prodrug also, a prodrug. Now, which student will tell me that why ganciclovir is given sometimes as intravitreal injection? Why it is given in ice? Why ganciclovir is sometimes given in ice? Because cytomegalovirus can cause retinitis. It can cause retinitis in HIV positive people. Now, what about Bell's palsy? The overall drug of choice for Bell's palsy is prednisolone, corticosteroid, because it will reduce inflammation and it will protect the nerve. Remember, protecting nerve is more important than killing a virus. So what is the drug of choice for Bell's palsy? Prednisolone. But yes, you can add acyclovir later on. You can add acyclovir. Okay. Overall drug of choice, prednisolone. Now let's talk about which of the following antimalarial drugs are commonly used in clinical cure of malaria. Okay. Clinical cure of malaria. Understood? Now, let's see first how malaria spreads. You know, malaria is spread by female anopheline mosquito. है ना? The sporozoites, they come into the blood. And these sporozoites, they divide in liver. When they divide in liver, it is known as hepatic schizogony. Then they come into the blood and they affect RBC. When they affect RBC, it is known as erythrocytic schizogony. Then they are converted into male and female gametes. And gametes, they go to malaria, which can lead to transmission or spread of malaria to other people. So gamete is a cause of transmission to malaria to other people. Now remember, they are going in this fashion. This happens in cases of P. falciparum. But in cases of P. vivax and ovale, there is one more stage. When these plasmodia become sleepy, it is known as hypnozoid stage. Hypnozoid stage is seen only in cases of P. falciparum and ovale. Now the point is, when does a person have features of malaria? Agreed? Features of malaria. In this RBC stage, remember, the patient has clinical features. Clinical feature beta kab aate hain? RBC stage pe. Now let's see what are the drugs we have. Now it is very easy to remember. The drug which will kill hepatic schizogony, primaquine. Do you agree? The drug that will kill hypnozoids of P. vivax and ovale, primaquine. ठीक है? And a new drug is there, tafenoquine. A new drug to kill hypnozoids of vivax and ovale. This is known as tafenoquine. When you kill hypnozoid, it is known as radical cure of malaria. This is known as radical cure of malaria. Now, the drug which can kill gametocyte and inhibit transmission of malaria to other people. Again, primaquine. Again, primaquine. Don't you think easy ho gaya kafi? Primaquine. Now, what about clinical cure? In clinical cure, you will write all drugs except primaquine. So in clinical cure, all drugs except primaquine. Makes sense to you? So primaquine is not effective in which stage? Erythrocytic stage. So which drugs we will do to kill RBC? We give chloroquine in cases of Vivax and Ovale. And in cases of P. falciparum, we give ACT, artemisinin based combination therapy. समझ आ गई कहानी? Now don't worry, I'll give you the guidelines, you will understand it very easily. So first tell me the answer of this question. Which of the following anti-malarial drugs are commonly used for clinical cure? Can we say we give artemisinin based combination therapy? Artesunate is a type of ACT. Agreed? Chloroquine is also given for P, Vivax and Ovale. Do we give primaquine? No, primaquine is not effective. And the brother of primaquine is tafenoquine. Not effective in cases of clinical cure or erythrocytic stage. So the answer out here comes out to be A and C. Samajh aayi kahani? Good. So let's see now what the guideline says. Very simple and easy. Uncomplicated malaria. P, Vivax and Ovale. We give chloroquine. Can you tell me why we are giving chloroquine? To provide clinical cure. And why we are adding primaquine for 14 days? To prevent, to kill what? Radical cure. To give radical cure. In cases of P. falciparum, we give ACT, artemisinin based combination therapy with primaquine. Why we are giving primaquine? Primaquine here it is given as a gametocidal to prevent transmission of malaria. Now, which ACT to be given? In all states of India, we give ASP. ASP stands for artesunate with sulfadoxine pyrimethamine. But in northeastern states of India, like Assam, Manipur, Nagaland, these states' name will come to you. We give AL, artemisinin with lumefantrine combination. But if the word comes complicated, complicated means we have to give IV drug. Uncomplicated means we have to give oral drug. Complicated is a dangerous condition. The only drug of choice is IV artesunate. IV artesunate. Now this is malaria in pregnancy. Malaria in pregnancy, primaquine is contraindicated in all trimester. So in P, Vivax and Ovale, we only give clinical cure. We will not give radical cure. Okay. In P. falciparum, first trimester, quinine plus clindamycin. Second and third trimester, same artemisinin based combination therapy. While complicated malaria in pregnancy, artesunate in all trimesters. Understood? Remember this by heart. Now tell me, an HIV positive mother diagnosed in third trimester has a viral load of 1200, delivered a child, most appropriate ART antiretroviral therapy to be started. Okay. So tell me the answer. What is the answer of this question? A, B, C, D. A tough one. This is a tough one. So the answer out here is B. Answer out here is B. So let me tell you, newborn prophylaxis from HIV positive mother. See this newborn child first. See this newborn child first. If this newborn child, mother is having less than 1000 copies in blood, we call this infant as low risk infant. But if the mother is having more than 1000 copies, don't you think from breast milk this HIV can enter into the neonate? So this is high risk infant. In low risk, in neonate we will give nevirapine syrup for 6 weeks. Agreed? And continue breastfeeding. Continue breastfeeding. No problem with that. Breastfeeding should be continued. But in high risk infant, we will add one more drug, nevirapine plus zidovudine. We will give for 6 weeks if we are not giving breastfeed. But if we are doing breastfeeding, we are telling the mother to do breastfeeding, then this combination should be given for 12 weeks. So now see the question again. See the question again. Mother is having viral load of 1200. Understood this part? That is more than 1000. High risk infant. So high risk infant में क्या देना है? High risk infant में nevirapine and zidovudine 12 weeks with breastfeeding. Why not A? Why not A? It is given for low risk infant. It is given for low risk infant. Understood this? So you should be very specific in INI-CET. Now let's talk about which of the following drug combination is given for pre-exposure prophylaxis in HIV. Pre-exposure prophylaxis. Which combination you will give, beta? Pre-exposure. I'll tell you the answer. The answer out here is tenofovir with emtricitabine combination. Tenofovir with emtricitabine combination. Beta, one question Sandesh is asking. Sir, if the mother has taken previous ART therapy, let's say the mother is taking ART, still check the mother HIV count. Two cases will be there. Either the ART in mother will be responding or not responding. If it is responding, viral count will be less. Consider this infant as low risk infant. And mother, it depends upon the mother viral count. She's taking ART or not doesn't matter now. It only depends upon mother में कितना HIV है. Mother में HIV का लोड ज़्यादा है, consider it as a high risk infant. Mother में तो ART चलती रहेगी. Understood this part? Okay. बेटा क्लिंडामाइसिन हम सूडोमेम्ब्रेनस में नहीं दे रहे थे, हम टॉक्सिक शॉक सिंड्रोम में दे रहे थे. Okay. Now, what do you mean by post-exposure prophylaxis? Post-exposure means it occurs after needle stick injury. Needle stick injury किन में होती है? डॉक्टर्स में होती है, नर्सेस में होती है. So post-exposure prophylaxis is given in doctors and nurses, healthcare profession. It is given for 28 days. And it should be started as early as possible after needle stick injury. And in post-exposure prophylaxis, we give how many drugs? We give 3 drug combination. We give 3 drug combination TLD, which is the treatment of HIV also. That is tenofovir, lamivudine and dolutegravir. Makes sense to you? Tenofovir, lamivudine, dolutegravir. Now one point also. This tenofovir and lamivudine, these 2 drugs, they are approved for HIV. They are also approved for hepatitis B virus also. It is also approved for for hepatitis B virus also. Next point, what is pre-exposure prophylaxis? Pre-exposure prophylaxis is given for high-risk individual who are at risk of acquiring HIV. उनका कुछ profession ऐसा है. Can we write it as commercial sex workers? Agree? Men having sex with men. Intravenous drug abusers. They are at high risk of acquiring HIV. Here we give pre-exposure prophylaxis, and here we give not 3 drug. Here we give 2 drug combination for pre-exposure prophylaxis. Agreed? So drug of choice for hepatitis B is also tenofovir. Okay? Now here try to remember this one. Tenofovir and emtricitabine combination orally daily till the person is continuing his or her profession or his habit of intravenous drug abuser. But what are the other approved regimen? We can give tenofovir with lamivudine combination, cabotegravir, which is an integrase inhibitor, and linacapavir, which is some capsid inhibitor. They are available injectable. So this can be a potential question for INI-CET. Okay. Okay. So this is the pre-exposure prophylaxis. सिर्फ आपने high risk देखना और start कर देना है. Now new drugs for HIV. So you know HIV virus contains envelope, and envelope contains glycoprotein, and inside the envelope we have capsid. It attaches to human cell, and with the human cell, HIV virus enters into the human cell by binding to CD4 receptor and CCR5 receptor. So we have new HIV drug which are entry inhibitor, enfuvirtide, envelope fusion or entry inhibitor. So these drugs all are entry inhibitor. Enfuvirtide inhibit GP41, glycoprotein 41. Fostemsavir, it inhibit glycoprotein 120. Ibalizumab, this is important. It has been asked. Bali. You know, Bali is in Indonesia. Let's say you cleared exam, you went to Indonesia or Bali. You were so enjoying your life that accidentally or intentionally you made so much love that you acquired HIV. सो कौन सी मोनोक्लोनल एंटीबॉडी एचआईवी में अप्रूव्ड है? द ओनली मोनोक्लोनल एंटीबॉडी अप्रूव्ड इन एचआईवी इज इबालीजुमैब. इंडोनेशिया, बाली, एचआईवी. रिमेंबर लाइक दिस. It inhibits CD4 receptor. Maraviroc, it inhibits CCR5 receptor on human cell. So these drugs you have to remember. Ibalizumab has been asked many times in your INI-CET exam. A patient with HIV is newly diagnosed with rifampicin resistant TB. Which of the following is the appropriate regimen? What is the regimen now for rifampicin resistant TB? Yes, that is now the treatment has become B-PAL-M regimen. B-PAL-M regimen is the treatment of choice. So let's talk about first line drug for tuberculosis. TB first line drug. They are given for drug susceptible TB, HRZE. HRZE, and among them, remember, these drugs are oral drug. These drugs are oral drug. Streptomycin is now not the first line drug. And streptomycin is an injectable drug. So nowadays we don't give injectable drugs for TB. Agreed? What is the treatment of drug susceptible TB? Intensive phase give HRZE. Continuation phase give HRE for 4 months. In drug resistant TB, we give second line drug. So the mnemonic you have to remember is BEL. Remember a mnemonic? BEL. BEL stands for, BE stands for bedaquiline. Very important. Linezolid, levoflox and moxiflox. BEL, CC, clofazimine and cycloserine, and DEPT. So we will discuss these drugs one line. Question definitely comes on these drugs. Now remember, what are the first line drug? HRZE. Beta, can you tell me which name is not matching properly? R for rifampicin, we are fine with it. E for ethambutol, we are fine with it. But don't you think isoniazid should start with the word H? It should start with the word I. And pyrazinamide should be started with the word P. But they are having difference in name. Why? Because any drug having different symbol is a pro-drug. कौन से टीबी वाले ड्रग प्रो ड्रग होते हैं? जिनका सिंबल अलग होता है. Why? Because isoniazid entering into TB gets converted into active form. Its active form starts with the word H. Understood this part? Isoniazid inhibit mycolic acid synthesis, which is the cell wall of TB bacteria. What is the cause of isoniazid resistance? Isoniazid resistance occurs because of mutation in one gene. Mutation in catalase. There is one gene known as CAT-G gene. CAT-G gene, remember, makes one enzyme catalase peroxidase. Catalase peroxidase converts isoniazid into active form. Rifampicin inhibit R for RNA polymerase enzyme. And this RNA polymerase mutation, which is encoded by RPOB gene, will lead to rifampicin resistance. And this RPOB gene mutation, it is detected by a test known as CB-NAT test. Rifampicin resistant कैसे check करते हैं? CB-NAT test. Pyrazinamide inhibit protein synthesis. Ethambutol is the only bacteriostatic drug. Other drugs are only and only bactericidal drug. इनमें से static कौन सा? ethambutol, and it inhibits some arabinogalactan synthesis. It inhibits arabinogalactan synthesis. Side effect of isoniazid, INH. I for insanity. आदमी पागल हो जाएगा. Why? Isoniazid enters into brain, causes hallucination, and it can lead to memory loss. And outside the brain, it can lead to peripheral neuropathy. And these two side effects is treated by vitamin B6 or pyridoxine. Plus isoniazid is also hepatotoxic drug. Rifampicin, R for rifampicin, it causes red urine. Remember, if there is orange red urine, it is harmless. Do not stop rifampicin, but rifampicin is also hepatotoxic. If it causes hepatotoxicity, stop giving rifampicin. Pyrazinamide, most hepatotoxic drug. So first three drugs are highly hepatotoxic. Ethambutol affect eyes. Which anti-TB drug affect eyes? Ethambutol, it can cause optic neuritis, which can lead to decrease in vision. It can lead to it can lead to decrease in vision. It can lead to decrease in vision. Try to remember this one only. Now, what is drug resistant TB? MDR, multi-drug resistant TB, H plus R resistance. That is isoniazid with rifampicin resistance. Extensively drug resistant TB. Extensively drug resistance TB is MDR TB plus Bell resistance. Can you tell me what does Bell stands for? Bell याद आ रहा है किसी को Bell से? B for bidaquilene. L for linezolid. L for levoflox and moxifloxacin resistance. What is levoflox and moxiflox? They are fluoroquinolone resistance. But there is a subcategory pre-XDR-TB which stands for MDR-TB with fluoroquinolone resistance only. That is levoflox and moxiflox resistance. So how to treat these TB? So let's start understand this part. Remember the treatment of MDR TB, that is H plus R resistance. Remember one thing, in our country, there is a widespread isoniazid resistance. So we only detect rifampicin resistance by CB0 test and we straight away start the treatment of MDR-TB. So MDR-TB and RR-TB, rifampicin resistant TB, have same treatment. The treatment is B-PAL-M regimen, where B stands for bidaquilene, pretomanid, linezolid and moxifloxacin, which is given for 6 months. But if you talk about pre-XDR and XDR-TB, M को remove कर दो. क्या बन गया? M को remove कर दो. It becomes B-PAL regimen. So the drug you should focus, which is very important for you, is this new drug pretomanid. This new drug you have to focus is pretomanid. Because of this pretomanid, now the duration of treatment is just 6 months. But this pretomanid is contraindicated right now in children less than 14 years of age, pregnancy and breastfeeding. So if the person is less than 14 years, pregnancy and breastfeeding, we will shift this pretomanid to levofloxacin. We will change this pretomanid to delamanid. Delamanid is safe. And we will add clofazimine. We will replace this pretomanid with two drugs in this specific age group. Understood this part? The complete treatment of TB. TB is very important for you. So tell me, a patient is treated with MDR TB, presented with tingling, numbness, suggestive of peripheral neuropathy. Which drug is the cause? सर अगर पेरिफेरल न्यूरोपैथी है तो आइसोनियाजिड होना चाहिए था. बट कैन यू सी आइसोनियाजिड इज इन द ऑप्शन? सर आइसोनियाजिड इज नॉट इन द ऑप्शन. Which was the first line drug? Which second line drug causes peripheral neuropathy? The second line drug which causes peripheral neuropathy is linezolid. The answer out here is linezolid. Which first line drug causes peripheral neuropathy? Isoniazid. So let's talk about these drugs, very important for you. So the first we have is bidaquilene. So I told you a trick, bed. बेटा जब हम बेड पे होते हैं, when you are at bed, क्या आप एनर्जी खर्च करते हो? क्या आप एटीपी खर्च करते हो? A for ATP आ गया. A for ATP आ गया. So जब हम बेड पे होते हैं, unless and until we are lying alone, We will not spend energy. So bidacolin inhibit ATP synthase. It decreases ATP production inside the bacteria. Agreed? Now after A you can see Q word is coming. What is the side effect of bidacolin? It causes QT prolongation as a side effect. It causes QT prolongation. Understood this part? Linezolid, very important. Linezolid inhibit protein synthesis. It inhibits protein synthesis. How it inhibits protein synthesis? Because it binds to 23S subunit of 50S ribosome. Very specific mechanism of action. It inhibits protein synthesis. Side effect of linezolid. Side effect of linezolid, very easy. Remember a mnemonic? Post. P-O-S-T, post. Where P stands for peripheral neuropathy, numbness and tingling sensation. Optic neuritis. It causes serotonin syndrome. Why? Because it inhibits degradation of serotonin by inhibiting which enzyme? MAO enzyme. So which antibiotic inhibit MAO enzyme? Monoamine oxidase inhibitor, linezolid. It also causes thrombocytopenia or bone marrow suppression. Understood this part? Now, let's talk about clofazimine. Clofazimine, it is given in TB. It is also given in leprosy. And before it was approved for TB and leprosy, it was a coloring dye used in textile industry. It causes brown skin hyperpigmentation because it also deposits in skin and color the skin brown. So it was a brown dye used in coloring industry. Cycloserine side effect. It causes CNS side effect. In CNS, it can lead to psychosis, which can increase the risk of suicides. It can increase the risk of suicides. Good. Now, delamanid, pretomanid. So you can see manid word is coming in both of them. MA stand for they inhibit mycolic acid. Mycolic acid is the cell wall of TB bacteria. So they inhibit cell wall synthesis. Now delamanid दिल होता है, दिल बड़ा प्यारा होता है, प्रीटोमेनिड प्यारा दिल. They both can cause QT prolongation as a side effect. So दिल बहुत प्यारा होता है. Agreed? Ethionamide. It causes hypothyroid goiter. It causes hypothyroid goiter. Thioacetazone, HI word is coming. It is contraindicated in HIV patient. It can cause allergy. Now, which two drugs we have to remember are bacteriostatic drug in TB? The first bacteriostatic drug is ethambutol. हमने पढ़ा. One second line drug which is bacteriostatic is thioacetazone. Thioacetazone is also bacteriostatic. Understood? Now, let's talk about this very important MCQ. A patient was started on ATT. After 10 days, investigations were done. AST and ALT levels were normal limit, but serum creatinine is high and serum uric acid is high. So the patient is having renal disease. What is the, sorry, not renal disease, the patient is having gout. The patient is having gout. What is the best treatment? What is the best treatment? So let's talk about now very important point. TB in special scenario. The first is TB in liver disease. Which drugs are hepatotoxic? Remember Z, followed by H, followed by R. So which is the most hepatotoxic drug? The most hepatotoxic drug is pyrazinamide. The most hepatotoxic drug is pyrazinamide. So AST, ALT level जो होंगे वो ज़्यादा होंगे. पर ये हमारे क्वेश्चन में नहीं था. So what we have to do? Stop them. We have to stop them. And we have to start which drug in liver safe in TB bacteria? We will start SLE. We will start SLE, where S stands for streptomycin. L for levofloxacin. I told you levofloxacin was liver safe, and ethambutol. And ethambutol. TB in gout. In gout means increase in uric acid level. Which antibiotic causes increase in uric acid level? Pyrazinamide and ethambutol. But remember, gout is not dangerous. So do not stop them. Do not stop them. Just add a drug which will lower uric acid level like allopurinol. Like allopurinol. So tell me the answer of this question. Tell me the answer of this question now. Patient is having gout. Do you stop pyrazinamide? The answer is false. Agreed? Okay. So what is the answer? Continue all drugs, monitor serum acid level and LFT वगैरह. ठीक है? I'm really sorry. एक मिनट. Sorry. The answer should be B. B will be the answer, है ना? Add uric acid reducing drug like allopurinol. Continue ATT with monitoring. So answer is B. Okay, B. So now TB in HIV. Remember, first we treat opportunistic infection. First treat TB, then treat HIV, then treat HIV. So first we will start ATT and then we will start ART, which is antiretroviral therapy, and gap of 2 to 8 weeks should be there between TB treatment and HIV treatment. The reason is this gap is important to avoid iris syndrome. To avoid which syndrome? Iris syndrome. Because if you will start HIV drugs initially, lymphocyte count will improve and suddenly the immunity of the body will improve, and this immunity will suddenly kill TB bacteria, which will start inflammation in the body because of improvement in immunity, and massive inflammation. Patient can go into shock also. So this syndrome is known as immune reconstitution inflammatory syndrome. So why we should not start both HIV and TB drugs together? Because it will lead to iris syndrome. It will lead to iris syndrome. Understood this part? Great. Now, a leprosy patient is having one palpable ulnar nerve thickening with no skin lesion. What is the treatment to be given? Remember, leprosy is divided into two types, possibacillary and multibacillary. In possibacillary, 1 to 5 skin lesion, but zero nerve involvement. Multibacillary, 6 or more than 6 skin lesion, and at least one or more than one nerve involvement. Now tell me, this patient is of possibacillary or multibacillary? Yes, nerve involvement is there. Patient is of multibacillary leprosy. In possibacillary, we give 3 drugs RDC for 6 months. In multibacillary, we give 3 drug RDC for 12 months, where RDC stands for rifampicin, dapsone and clofazimine. So the answer out here comes out to be B. It comes out to be B. Understood this part? We all know, you must have learnt in derma, rifampicin is given once a month. Dapsone is given daily. Rifampicin once a month in front of a doctor, supervised. Dapsone daily at home, unsupervised. Clofazimine both way. That doesn't mean इसमें से एक भी चीज हो जाएगा, एक भी चीज हो जाएगा तो मल्टीबैसिलरी में डाल देना है. ठीक है? If any of the thing is present, classify the patient into multibacillary first. Understood medico by choice? Now, dapsone, it's an antifolate drug. It inhibits folic acid synthesis. So remember, it is a folic acid inhibitor, and dapsone is also the drug of choice for one skin lesion known as dermatitis herpetiformis. It is also the drug of choice for dermatitis herpetiformis, which is a skin lesion seen in gluten sensitivity patient. Which drugs for leprosy are bactericidal? Only 2 drugs. First line drug is rifampicin and one second line drug ofloxacin. Second line drugs are ofloxacin. Lepra reaction, it is hypersensitivity to leprosy drug. Leprosy drugs are also known as MDT, multi-drug therapy, and there are 2 types of lepra reaction, type 1 and type 2 lepra reaction. Type 1 reversal reaction, which is type 4 hypersensitivity reaction. Type 2 is erythema nodosum leprosum, which is type 3 hypersensitivity reaction. What is the management? Management is do not stop MDT. In lepra reaction, do not stop MDT and start corticosteroid prednisolone. What is the treatment of choice? Prednisolone is the drug of choice without stopping MDT. Another point to be noted is that in erythema nodosum leprosum type 2 prednisolone resistant cases, we give a drug thalidomide. Remember, thalidomide, though word is coming, it is only given in resistant cases of ENL, that is erythema nodosum leprosum और टाइप 2 लेप्रा रिएक्शन. ये सिर्फ टाइप 2 में देंगे, 1 में नहीं देंगे. Understood this part? Now, a drug of choice, the drug of choice for the treatment of this helminthic infection. So it is a freshwater crab. It is a freshwater crab. Eating this crab can lead to one infection of worm Paragonomius. It can lead to Paragonomius infection. And what is the drug of choice for Paragonomius infection? That is praziquantel. Last year MCQ. So let's see all the helminthic infection at one place and correlate this slide with your microbiology slide. So if you talk about cestodes or tapeworm, like Taenia solium, Taenia saginata, Hymenelepsis nana, Diphyllobothrium latum. And if you talk about flukes, flukes are trematode like Paragonomia, Schistosomia. Everywhere the drug of choice is praziquantel. Everywhere the drug of choice is praziquantel. But there are certain exceptions. The first exception is hydatid cyst, Echinococcus albendazole. Drug of choice, albendazole. Neurocysticercosis, again the drug of choice is albendazole. But point to be noted is, before starting albendazole, in neurocysticercosis, first give corticosteroid and anti-epileptic drug phenytoin and then start albendazole. Don't give it them alone, otherwise it will lead to worsening. Lastly, fasciola hepatica, liver fluke. Here you give triclabendazole. Here you give triclabendazole. Now let's talk about nematodes. In all nematodes like roundworm, hookworm, pinworm, whipworm, either you can give albendazole or its brother mebendazole, or you can give mebendazole. Strongyloids, and which is threadworm, onchocerca, which causes river blindness, ivermectin, and lymphatic filariasis and loa loa, DEC, which is diethyl carbamazine. Diethyl carbamazine. Now let's talk about this question which was asked last year in INI-CET. Which of the following treatment is appropriate for scabies in infants? यहाँ पे infant word भी important है. Okay? Okay? So let me tell you treatment of scabies. In scabies, remember, either we have topical drugs or we have oral drug. So can you tell me the only oral drug for scabies? Ivermectin. In topical, we have permethrin, which is the overall drug of choice. 5% permethrin, 10% crotamidol. First two drugs are safe in children and pregnancy, while last two drugs are contraindicated in children less than 5 years of age and pregnancy. Agreed? Understood this part? Overall drug of choice, permethrin 5% cream, but crotamidol can be given. Now keeping this thing in mind, tell me the answer of this question. Infant word आ गया तो permethrin दोगे और crotamidol दोगे. So answer out here is A. Answer out here is A. Understood this part? This question came last year. Next question. Which of the following regimen is given in the induction phase of treatment of cryptococcal meningitis? What is the answer of this question? So let's see the treatment of all fungal infection at one place. सारे fungal infection पढ़ लेते हैं फटाफट, है ना? Okay. So mucormycosis, black fungus, the drug of choice is AMB. Amphotericin B. Cryptococcal meningitis, amphotericin B plus 5-flucytosine. Flucytosine. Kala azar, Leishmania donovani. Again, the drug of choice is amphotericin B. Agreed? What is graciofulvin? Microtubule inhibitor given in Tinea capitis. Caspofungin, anidulafungin. These drugs, they will end with the word fungin. They inhibit cell wall. And cell wall is made up of beta glucan in fungus. So they inhibit blue beta glucan synthase. Cyclopyroxolamine, terbinafine, and tavabarol. They are given for onychomycosis, that is fungal infection of nail. But the question comes, which drug is available as nail polish for onychomycosis? That is the first one. Cyclopyroxolamine, it is available as nail polish or nail lacquer also. While other drugs are given orally or creams, but which is available as nail polish? Cyclopyroxolamine. Another point, choice of fungus. Now, in a yeast-like fungi which divides by budding, the first treatment or induction phase or the first treatment of choice, the most effective antifungal drug is amphotericin B, which is given IV. But for long-term maintenance, we give azole. We give azole. So in maintenance phase of Candida, cryptococcal, coccidiomycosis, we give fluconazole. Dimorphic fungi, which can divide by budding also and spore formation also. Again, the induction phase, the initial drug of choice is amphotericin B. Try to maintain with itraconazole. In blastomycosis, histoplasmosis, aspergillosis. In aspergillosis, the first treatment of choice is voriconazole, which is voriconazole better than amphotericin B. But this voriconazole is not effective in which mold? Voriconazole is not effective in black fungus, mucormycosis. Again, in mucormycosis, we give amphotericin B and you can maintain on posaconazole. Try to remember one drug, posaconazole पे maintain करेंगे. Now the point is, antifungal in pregnancy, only and only amphotericin B. Only and only amphotericin B. Azoles are contraindicated in pregnancy. कोई भी azole वाला ड्रग हम प्रेगनेंसी में नहीं देंगे. Understood this part? This question comes in INI-CET. This type of MCQ comes in INI-CET. Understood this part? So tell me the answer of this question now. What is the answer? Is it amphotericin B with fluconazole, flucytosine, or itraconazole? What is the answer? Cryptococcal meningitis give amphotericin B, 5-flucytosine in the induction phase. In the induction phase. Understood this part? Good. Good. समझ आ गई? Now let's move. Let's take a. You want to take a small break? Okay, I'll give you one more break later on. So we are done with 50% of the topics. Okay. So I took antimicrobial little bit deeper with you because it's an important topic for INI-CET. So let's take a small break. You must be tired also. 5 minutes break will be fine. Okay, just 5 minutes break, and we will start exactly at 6:10 p.m. Okay. Okay. Don't worry. Check. Welcome back, everyone. Uh, Welcome back, everyone. So we are done with a very tough topic, which we have taken initially on public demand, antimicrobial. Let's start with the easier one. Let's start with autonomic nervous system and glaucoma now. So this question came in the dose response curve. The graph B represents acetylcholine. Okay. And which drug is responsible for the curve A, this curve? What is the answer of this question, beta? Yes, the answer out here is physostigmine. So what is physostigmine? Physostigmine is a carbamate and it is a inhibitor of choline esterase enzyme. Choline esterase enzyme degrades acetylcholine. So it will increase the levels of acetylcholine. So it will produce synergistic effect. So the answer out here is physostigmine. Okay, physostigmine. I will tell you about carbamate shortly. So let's talk about botulinum toxin inhibits the release of which molecule? Acetylcholine. And because of this reason, the muscles will relax. The muscles will relax. While tetanus toxin inhibits the release of inhibitory neurotransmitter like GABA and glycine, which normally produce muscle relaxation. Now, because they are not really released, the person will have muscle spasm. So both are opposite of each other. Among them, which drug is used? Botulinum toxin is clinically used. It is given by injection and its preparation is known as BTXA, botulinum toxin type A, and it is given for the treatment of muscle rigidity or muscle spasm like achalasia, torticollis. Agreed? It is also given for the treatment of excessive sweating, which is known as hyperhidrosis, because acetylcholine causes excessive sweating. Now, there is a class of a drug known as ganglionic blocker. Like trimethophan, it blocks N receptor of acetylcholine. N receptors are present in the area of ganglia. While any drug ending with the word curare, curium, they block NM receptor of acetylcholine. NM receptor of acetylcholine is present on muscles and these drugs are used as a muscle relaxant. Curare, curium wale drug. So what is the drug of choice for reversal of their effect? The drug of choice for reversal of their effect is neostigmine. कौन सा ड्रग देते हैं? Neostigmine, because neostigmine increases acetylcholine level, which will now stimulate NM receptor and now the muscles will contract. Okay, but remember there is another drug known as Sugamadex. Sugamadex is a specific reversal agent for rocuronium and vicuronium. We have a new drug, rocuronium and vicuronium. Specific reversal agent is Sugamadex, vicuronium and rocuronium. क्यूरोनियम वर्ड आएगा इनके एंड में, ठीक है बेटा. नाउ लेट्स टॉक अबाउट अ फार्मर. रिमेंबर, एक फार्मर है, presented to emergency with diarrhea, sweating, excessive lacrimation, salivation. सारी secretions increased है. Pulse is 55, patient is having bradycardia, less than 60 is the heart rate, and choline esterase level is low. So choline esterase is not working. Acetylcholine level increases because choline esterase enzyme degrades acetylcholine and acetylcholine increases all secretion. Which of the following drug is used for the treatment? So yes, the patient is suffering from either organophosphate poisoning or carbamate poisoning, because organophosphate and carbamate, they inhibit choline esterase enzyme. They inhibit choline esterase enzyme, which increases acetylcholine level. So the treatment is atropine. Treatment is atropine. So let's talk about organophosphate and carbamate poisoning. These molecules are used as an insecticides and farmer very commonly use in our India to protect their crops from insects damage. So try to remember organophosphate malathion, the brother parathion, TIC20, and tabun serine soman. They are nerve gases used to kill people. Carbamate, carb word remember, LD carb and carbaryl. These two drugs you have to remember. So what happens? These molecule, they inhibit choline esterase enzyme. Because choline esterase enzyme is inhibited, they increase acetylcholine level. And this acetylcholine produce clinical features of dumbbells. It produce clinical features of dumbbells. All the secretions of the bodies are increased. Diarrhea, urination, lacrimation, salivation, sweating. In eyes, there will be pinpoint pupil or meiosis. Pinpoint pupil means meiosis is there with bradycardia. So what we have to do? We have to block acetylcholine receptors. So we give atropine as a drug of choice. And why we give atropine? To treat the symptoms of dumbbells. But in cases of organophosphate, we give pralidoxime or any other oxime, because these oximes, they will reactivate which enzyme? They will reactivate cholinesterase enzyme that will degrade acetylcholine. But remember, pralidoxime is only given in cases of organophosphate poisoning. It is not given in cases of carbamate poisoning. Now let's talk about opposite. Atropine poisoning. Remember, atropine is an anti-muscarinic drug. It blocks muscarinic receptors of acetylcholine. And the symptoms of atropine poisoning is symptoms opposite of dumbbells. Can we say all the secretions in the body will reduce now? And this atropine is obtained from plant. Which plant? Datura plant or belladonna plant. It is also known as datura or belladonna poisoning. So let's reduce all body secretion. So let's reduce sweating. If sweating is reduced, what will happen to body temperature? In atropine poisoning, the classical feature is hyperthermia or increase in body temperature, and this hyperthermia will lead to vasodilation, and this vasodilation will lead to flushing. So remember, hot and red skin will be there in atropine poisoning. Now lacrimation, salivation will also reduce. Instead of meiosis, there will be mydriasis and cycloplegia. Cycloplegia means lens will paralyze. So there will be loss of accommodation. You will become blind. You will not able to focus on things. And atropine causes seizures and delirium due to reduced memory. And it causes decrease in all body secretion like constipation, urinary retention. So what is the antidote of atropine poisoning? One carbamate known as physostigmine is the drug of choice for the treatment of atropine poisoning, because it will increase acetylcholine levels now. It will increase acetylcholine level, which will overcome this blockage. Another question which was recently asked: what is the drug interaction between imipramine and diphenhydramine? Remember, imipramine is a tricyclic antidepressant, and diphenhydramine, they are also ending with the word amine. Any drug which ends with the word amine, they have atropine-like side effect. So it is an antihistaminic drug. So any drug which ends with the word amine, remember, they have atropine-like side effect. And can you tell me atropine block which receptor? Yes, they both block muscarinic receptors. They both block muscarinic receptor. Last year INI-CET MCQ amine word आ रहा है, याद हो जाएगा आपको. ठीक है. Now, what is the dose of epinephrine used in anaphylactic shock? What is the dose of epinephrine used in anaphylactic shock? The answer is A. In anaphylactic shock, either we give epinephrine IV 10,000 IV, or you can also give intraosseous into the bone. Okay, intraosseous. So this is nowhere used. Next is 1:1,000 intramuscularly. I'm really sorry. I'm really sorry. I'm really sorry. I'm really sorry. Okay. So the answer of this question is C. So this is the dose of epinephrine in anaphylactic shock. That is 1:1000 intramuscularly 0.5 ml. Now remember 1:10,000. It is not 1000. Intravenous or IO, this dose of epinephrine is given in cardiac arrest. It is given in cardiac arrest. Okay. Lastly, 1:2 lakh locally, it is given as an add-on drug to local anesthetic. It is given as an add-on drug to local anesthetic. Okay. So what is a sign of atropine poisoning in organophosphate poisoning? Hyperthermia. भाई atropine overdose दोगे तो hyperthermia हो जाएगा, dry eyes mouth हो जाएगा, instead of bradycardia tachycardia हो जाएगा. So in simple word, opposite of dumbbells it will happen. So let's talk about the treatment of all shock at one place. So first is septic shock, neurogenic shock, and cardiogenic shock with hypotension. In these three shock, the drug of choice is norepinephrine. The drug of choice is norepinephrine. Instead of cardiogenic shock, you can write acute heart failure. But if cardiogenic shock happens without hypotension, then the drug of choice is dobutamine. Then the drug of choice is dobutamine. Now remember, norepinephrine acts on all alpha and beta receptor except which receptor it will not act? It will not act on beta 2 receptor. Because it does not act on beta 2 receptor, it does not produce bronchodilation. And bronchoconstriction happens in anaphylactic shock. In anaphylaxis, patient has asthma. So if a question comes, anaphylactic shock, then the drug of choice is epinephrine. Because epinephrine acts on alpha and beta receptor, including beta 2 receptor, epinephrine causes bronchodilation. Now, if cardiogenic shock happens with oliguria, then the drug of choice is dopamine. Because dopamine acts on D1 receptor. D1 receptor is present in kidney, which increases GFR and urine production. Now, which drug is the drug of choice for stress echocardiography? That is dobutamine. Dobutamine is a specific drug which acts on beta 1 receptor. Beta 1 receptor is only present on heart and JG cells of kidney. So it is given for cardiogenic shock. And to do stress echocardiography as well, we give dobutamine. Lastly, cardiac arrest, we give epinephrine again. But the difference in dose is different. In anaphylaxis, we give 1:1000. In cardiac arrest, we give 1:10,000. 10,000. In above, we give intramuscularly. In cardiac arrest, we give IV or intraosseously into a bone like tibia bone. In resistant shock to any of the following drug, we add a drug vasopressin hormone if the shock is resistant to norepinephrine, dopamine, etc. Agreed? Now let's talk about match the following drugs with their respective receptors. So can you tell me which drug is acting on beta 1 receptor? So beta 1 receptor, dobutamine. So dobutamine acts on beta 1 receptor. Now see the name phenol dopam. See the name dopam. Dopam वर्ड आ रहा है तो किस पे काम करेगा? डोपाम वर्ड आएगा तो डोपामीन पे काम करेगा. So it acts on D1 receptor, phenol-dopam. Can we say phenol-dopam acts on D1 receptor? It also increases GFR. Because of this reason, phenol-dopam is also given in the treatment of acute renal failure or oliguria, just like dopamine. The drug which acts on beta 3 receptor. Now, beta 3 receptor, mirabegron. Mirabegron, beta 3 receptor. Remember why? Just a second. Now, mirabegron, why? Because beta 3 receptors are present on bladder. They are present on bladder. And mirabegron by beta 3, it relaxes detrusor muscle of bladder. That is why mirabegron is given in cases of overactive bladder. It is given in overactive bladder. And lastly, alpha 1 agonist. Alpha 1 agonist is midodrine. Midodrine acts on alpha 1 receptor Alpha 1 receptor produce vasoconstriction. It produces vasoconstriction, and this midodrine is given in the treatment of postural hypotension. It is given in the treatment of postural hypotension. So what is the correct answer? I think the correct answer is D. Now remember one point. If the word comes overactive bladder, if the word comes overactive bladder, and the patient is also having, the patient is having asthma, and if the patient is having Alzheimer disease, because both conditions can occur in old age. Now understand how to treat overactive bladder. The overall drug of choice for overactive bladder is oxybutynin. Overall drug of choice is oxybutynin. But oxybutynin is contraindicated in cases of asthma. It is contraindicated in cases of Alzheimer disease. If the word asthma comes, give mirabegron. गिव मीराबेग्रॉन. कौन सा ड्रग देना है? ओवर एक्टिव ब्लैडर के साथ एस्थमा है तो मीराबेग्रॉन, बीटा 3 वाला. बट इफ द वर्ड कम्स एल्जाइमर डिजीज, then the treatment of overactive bladder is a drug known as trospium. Trospium does not cross blood-brain barrier, does not reduce memory. Oxybutynin, atropine-like drug, anticholinergic drug, reduces memory. Understood this part? So this is an important treatment of overactive bladder. Now, what is the mechanism of action of phenol-dopam? Last year MCQ. See, dopam word is coming, dopamine. F means first receptor. So it is dopamine 1 receptor agonist, which increases GFR, given in the treatment of acute renal failure or oliguria. So the answer out here is A, phenol-dopam. Very easy question now. Now next is, what is the most effective drug for quitting smoking? So instead of most, let me write very effective drug for quitting smoking. Now tell me the answer. Very word लिख दिया. अगर very word लिख दिया तो very clean आंसर हो जाएगा. Agreed? और कैसे याद करें? Smoking contains nicotine. Very clean. Nic word is coming. तो इसमें भी कुछ निकोटीन वाला वर्ड आता है. So let's talk about drugs for quitting smoking. First line drug are nicotine, varenicline and bupropion. These are the three drugs. Nicotine, remember, transdermal patches से देते हैं, च्युइंगम्स देते हैं, नेजल स्प्रे आता है. Agreed? Nicotine is not given orally. It is not given orally. Chewing-gums are not swallowed. Chewing-gums are kept in mouth only. Agreed? Varenicline, nicotine wala, bupropion, antidepressant. So which drug is an antidepressant having an anti-smoking effect? That is bupropion. Now the point is, first three drugs, they are absolutely contraindicated in a patient of seizure. Or you will write CNS disease patient. They are contraindicated in a patient of hypertension and heart disease patient also. They are contraindicated in any heart disease patient. In these cases, which is the safe drug? The safe drug is clonidine. Clonidine is a second line drug for smoking cessation or smoking de-addiction. Which is the most effective drug? The most effective drug with best result is varenicline. Varenicline is the most effective drug we have for smoking cessation. Understood this part? Next question. Which drug is used to reduce catecholamine synthesis in cases of pheochromocytoma? What is the answer? Pheochromocytoma mein which drug reduces catecholamine synthesis? The answer out here is metyrosine. The answer out here is metyrosine. So remember, what is pheochromocytoma? It is a tumor of adrenal gland. And this adrenal gland, it makes excessive amount of norepinephrine, dopamine. It is produced excessively. Remember, this norepinephrine, dopamine and epinephrine, they are produced with the help of one enzyme, with the help of one amino acid, that is tyrosine. And the enzyme which is required name is tyrosine hydroxylase enzyme. कौन सा enzyme? Hydroxylase enzyme. So this norepinephrine, dopamine, they are known as catecholamines. Understood this part? Now when they act on blood vessel, they stimulate alpha receptor, and alpha receptor increases blood pressure, which will lead to hypertension. So the first point is, which drug reduce catecholamine synthesis? The drug is metyrosine. Mabityrosine. Metyrosine inhibit which enzyme? Metyrosine inhibit tyrosine hydroxylase enzyme. It reduces the production of catecholamines in pheochromocytoma. Second point, which drug is given to control hypertension? The drug which is given to control hypertension in pheochromocytoma is phenoxybenzamine. The drug name is phenoxybenzamine. So what is this phenoxybenzamine? Phenoxybenzamine is an alpha blocker. It blocks alpha receptors. And which drug is given for diagnosis of pheochromocytoma? You will write clonidine. Clonidine. We will not go into the detail why clonidine. Just these two MCQs are important. These two MCQs are important. Understood this part? Now what about this prazosin? So prazosin is given to control hypertension and pulmonary edema in cases of scorpion sting. In cases of scorpion sting. Phentolamine is given to control hypertension in cases of cheese reaction. In cases of cheese reaction. So cheese reaction occurs, cheese contains good amount of tyramine. And when you give with MAO inhibitor, monoamine oxidase inhibitor, it leads to hypertension or increase in blood pressure. So to control this BP, we give phentolamine. You know phenoxybenzamine, where it is given? We all know phenoxybenzamine to control hypertension in pheochromocytoma. But to reduce catecholamine production, give metyrosine. Give metyrosine. Now, which drug is given in diagnosis of myasthenia gravis? Very simple question, repetitive question. The answer out here is hydrophonium. Very simple and easy question, hydrophonium. So let's talk about myasthenia gravis. Autoimmune disease होता है, in which antibodies are produced, and these antibodies, they block which receptor? NM receptor. NM receptor of acetylcholine, which leads to muscle weakness. So muscle weakness or muscle paralysis is known as myos, means muscle, asthenia means weakness. And the first symptom is ptosis. The first symptom in myasthenia gravis is ptosis. So symptomatic treatment. Symptomatic means improve muscle weakness. Improve muscle weakness. We give neostigmine. Instead of neostigmine, you can give a longer acting drug, pyridostigmine. Whichever the drug you are using, neostigmine or pyridostigmine, you should always give atropine along with it. Remember, neostigmine, they will increase acetylcholine level, and acetylcholine will stimulate NM receptor. Why we give atropine? To block M receptor. We don't want acetylcholine should act on muscarinic receptor. If it will act on muscarinic receptor, symptoms of dumbbells will come. What is the definitive treatment? Definitive treatment is remove antibodies, reduce antibody production, give corticosteroid like prednisolone as an induction treatment. But for long-term maintenance, we maintain the patient on azathioprine. Now, in the resistant cases, if the patient is having thymoma tumor, because thymoma tumor will produce lot of antibodies which will not be reduced by prednisolone and azathioprine, we should do one surgery known as thymectomy, because thymus is the source of antibody production. Myasthenic crisis, crisis means emergency. In emergency, the patient is having respiratory paralysis also. So you have to remove this antibodies very fast. So you will remove the plasma and do plasma exchange, plasmapheresis, or you will give intravenous immunoglobulin, which will neutralize these antibodies. But which drug is given for diagnosis of myasthenia gravis? The shortest acting drug, that is hydrophonium. So when you will give hydrophonium, there will be sudden improvement. there will be sudden improvement in ptosis and the eyes will open up. So imagine this is a girl, she is suffering from ptosis. You have given hydrophonium to her. When you give hydrophonium, the eyes will open, she falls in love with you. So this is the test for diagnosis of myasthenia gravis, and this test is also known as tensilon test. It is also known as tensilon test. Tensilon is another name of hydrophonium given in diagnosis of myasthenia gravis. So we all know this part, है ना? Okay. There are other tests also: ice pack, single fiber electromyography, find anti-nicotinic antibodies, directly identify them. Those tests you will learn in medicine. In pharma, remember a drug name hydrophonium, the most important MCQ. So which of the following glaucoma medication is avoided in diabetic cystoid macular edema? Agree? Which causes anterior uveitis and which causes iritis, heterochromia iritis. Beta, just remember one thing. Iritis means inflammation of iris. Uveitis means inflammation in the eyes. Cystoid macular edema means inflammation is happening in retina. Which drug causes inflammation? Prostaglandins causes inflammation in our body. Which drug is a prostaglandin? See the drug ending with the word prost will be a prostaglandin. So the answer out here is latanoprost. The answer out here is latanoprost. Understood this part? So let's talk about which prostaglandin are given in glaucoma. Prostaglandin F2 alpha. What is their mechanism of action? They remove aqueous humor out of the eye. They increase uveoscleral outflow of aqueous humor. And if aqueous humor is removed out of the eye, don't you think pressure in the eyes will reduce? So they will decrease intraocular pressure. That is why they are given in the treatment of glaucoma. So these drugs are given by eye drops. So latanoprost, bimatoprost we have to remember, and they are the drug of choice for open angle glaucoma and angle closure glaucoma. Both, they are the initial drug of choice. Other glaucoma drugs are given in combination with these drugs. So what is their side effect? So these drugs, prostaglandin, they increase inflammation in eye. Let's take an example. Inflammation in anterior chamber of eye is known as anterior uveitis. And in anterior uveitis, don't you think iris will become damaged? If iris becomes damaged, color of eye will change. So we call it as heterochromia. Change in color means heterochromia due to inflammation of iris, iritis. If they will cause inflammation in retina, you will find edema in retina. Blood will leak out, edema. So this is known as cystoid, just like feathers. Just like feather means just like cloud. White spot of edemas will be there in inflammation, which is known as cystoid macular edema, because macula is also known as retina. Lastly, they can cause growth of eyebrows and eyelashes. They can cause growth of eyebrows and eyelashes, which is known as hyper. Hyper means excessive. Trichosis. Trichosis means hair growth of brows and eyelashes. सो हाउ टू रिमेंबर? बेमेटोप्रोस्ट जो है ब्रोस की ग्रोथ कौन करता है? बेमेटोप्रोस्ट करता है. एग्री? नाउ लेट्स टॉक अबाउट वन लाइनर. विच एंटी ग्लोकोमा ड्रग कॉजेस एलर्जी इन आईलिड एंड कंजक्टिवा ब्लेफेरोकंजक्टिवाइटिस? ए से एप्राक्लोनिडीन. ठीक है, एप्राक्लोनिडीन. इट इज एन अल्फा एगोनिस्ट. Now, which drug causes bronchospasm? Beta blocker like bitaxolol. Bitaxolol, beta blocker given in asthma. Sorry, given in glaucoma, and beta blockers are avoided in asthma. Which drug causes secondary, खुद कर सकते हैं, angle closure glaucoma? Why? Because of ciliary effusion. I will not go into the detail. Ophtha people will tell you, sir. So that is carbonic anhydrase inhibitor. They will end with the word zolamide. Zolamide like brinzolamide, dorzolamide, Okay, acetazolamide. So they can cause glaucoma. खुद ग्लोकोमा कर सकते हैं. डार्क और ब्लैक आई, that is dipivefrin. Dark or black eye, dipivefrin. Why? Because dipivefrin is a prodrug. It gets converted into epinephrine, and the color of epinephrine is black in color. तो कौन सा ड्रग डार्क या ब्लैक आई करता है? डिपीवेफ्रीन. विच आई ड्रॉप्स आर हाईली पेनफुल? पेनफुल आई ड्रॉप्स, पाइलोकार्पिन. Why? Because pilocarpine causes contraction of muscles. It causes meiosis, iris will contract. It contracts ciliary muscle. Ciliary spasm will happen. And when any muscle undergoes into spasm, pain होगा उससे. Which drug is avoided in children less than 2 years of age? तो बच्चों में कौन सा ड्रग नहीं देना? बच्चों में ड्रग अवॉइड करना है ब्राइमोनिडीन. Don't you think brimonidine and epiroclonidine, they both are ending with the word nidine, so they both are alpha agonist. But remember, बच्चों की मम्मी में कौन सा देना है? बच्चों की मम्मी में हमें ब्राइमोनिडीन देना है. बच्चों में ब्राइमोनिडीन नहीं देना, because it can lead to apnea or respiratory depression. It can enter into the brain of child easily. The blood brain barrier is not fully produced. तो ये ब्रेन में एपनिया कर देता है. ब्राइमोनिडीन बच्चों में नहीं देंगे, पर बच्चों की मम्मी में देंगे. इट इज द सेफेस्ट एंटी ग्लोकोमा ड्रग इन प्रेगनेंसी. Understood this part? So now let's talk about respiratory system. So, what is the drug of choice for acute attack of asthma? In acute attack of asthma, we give bronchodilator. We give bronchodilator, and now the drug of choice has become बीटा 2 एगोनिस्ट. पहले होता था सैल्ब्यूटामॉल, अब होता है फॉर्मेटरॉल. अब कौन सा होता है? फॉर्मेटरॉल. इन फॉर्मेटरॉल से भी अगर रिलीव नहीं हुआ, नॉट रिलीव्ड बाय बीटा 2 एगोनिस्ट, दिस इज नोन एज स्टेटस एस्थमेटिकस. इसे हम क्या बोलते हैं? स्टेटस एस्थमेटिकस. वी विल एड अदर ब्रोंकोडाइलेटर. अदर ब्रोंकोडाइलेटर, रिमेंबर मिया, सिर्फ मिया लिखेंगे, आगे का नाम नहीं लिखोगे. दैट इज मैग्नीशियम सल्फेट, इप्राट्रोपियम एंड अमाइनोफिलीन. They are the other bronchodilator. Now what about chronic or persistent asthma? For the long term treatment, we give anti-inflammatory drug. And the drug of choice for asthma long term treatment is ICS. ICS stands for inhalational corticosteroid, and the most commonly used inhalational corticosteroid is budesonide. कौन सा ड्रग? Budesonide. So if the patient is having mild chronic asthma, we give ICS in low dose. Patient is having moderate to severe, we will give ICS, and we will increase the dose of inhalational corticosteroid as the severity of asthma increases. So mild में low dose, moderate में ज़्यादा, severe में high dose. But in cases of moderate and severe variety, we give a drug LABA, long acting beta 2 agonist, and the same drug we will give formoterol. We will give the same drug formoterol with budesonide as long-term maintenance therapy also. Now, if the asthma is not relieved, not controlled by highest dose of inhalational corticosteroid, we call it as refractory asthma. In refractory asthma, we will start oral steroids with LABA. And if the asthma is still not controlled by oral steroid, we call it as corticosteroid resistant asthma. Here we give a drug MAB, monoclonal antibodies. They are given for corticosteroid resistant asthma in long term therapy for prevention of asthma. Understood ये बात समझ आई? Tell me the answer of this question. It is a very repetitive question. A clinical based question. A asthmatic patient is on formoterol and budesonide for long term. Now the patient is having exacerbation of asthma. अब भी asthma control नहीं हो रहा. So let's say the patient is on ICS. What is the next step? What is the next step? Tell me the next step. What is that? So this is LABA. What is the next step? The next step is increase the dose of inhalational corticosteroid. We increase the dose of, because the patient is having higher severity, so increase the dose of inhalational corticosteroid. Understood? So first step is always, if the patient is still having an attack, control or increase the dose of inhalational corticosteroid. Still not controlled, then you give oral steroid, then you give monoclonal antibody. First treatment is always to increase the dose of inhalational corticosteroid. Understood this part? Very good. So now let's talk about monoclonal antibody used in asthma, incorrect mechanism of action. The answer of this question is benralizumab. So let me tell you first all the monoclonal antibodies given in asthma. They are given in corticosteroid resistant asthma. The first is omalizumab. Omalizumab blocks which target IgE. It blocks IgE. Mepolizumab and reslizumab, they block interleukin 5. They block interleukin 5. Now we have a new monoclonal antibody approved 2-3 months back, that is depemokimab. It is also blocking interleukin 5 receptor. It is the longest acting drug. It is given once in 6 months. So it is the overall longest acting drug we have for asthma, depemokimab. Okay, Depi, because it is a depot injection which remains in the muscles and fat for very long duration of time, releases slowly. So why it is a longest acting drug? Because it is a depot injection. Depi means depot injection. Then we have benralizumab. It does not block interleukin 5, but it blocks the receptor of interleukin 5. Okay, dupilumab, it blocks interleukin 4 receptor. And the last monoclonal antibody, tezepelumab, it blocks TSL, that is some thymic stromal lymphopoietin. Thymic stromal lymphopoietin. Thymic stromal lymphopoietin. Okay, a new drug. So these are the new drugs I will be telling you for INI-CET. So which of the following is not an adverse effect of? Very important MCQ. Not an adverse effect of beta 2 agonist. So remember, adverse effect of beta 2 agonist, remember 2T, 2H. So the first side effect is tremors. Tremors is the most common side effect because of stimulation of beta receptors on muscle. Tachycardia or palpitations because of stimulation of beta receptor on heart. They cause hypokalemia. In blood, potassium level will fall. But in blood, which level will increase? They cause hyperglycemia. They increase glucose level and reduce potassium level. So what is the answer out here? What is the answer out here? The answer out here is, yes, hyperkalemia is not seen. It is rather hypokalemia. Next question, main mechanism of action of theophylline in asthma. Remember, theophylline has 4 mechanism of action. Patch. It has 4 mechanism of action. It is a phosphodiesterase inhibition, which increases cyclic AMP level. Cyclic AMP causes bronchodilation. It blocks adenosine receptor. Calcium blocker. It causes on histone protein also. But out of them, the main mechanism of action of theophylline in asthma is P. So answer out here is A. It is a phosphodiesterase 4 inhibition. Now we have a new drugs in asthma which are only and only specific phosphodiesterase 4 inhibitor. No other action is there. So no, these specific phosphodiesterase 4 inhibitor are roflumilast, Cilomilast. So these are the new bronchodilator drug which only are phosphodiesterase 4 inhibitor ending with the word milast. Okay? Now let's talk about theophylline toxicity. Remember, theophylline is present in tea and coffee. And if you drink excessive tea and coffee, the symptoms you will feel will be the side effect of theophylline. So the side effect of theophylline is suhag. Excessive tea and coffee can lead to seizure. It can lead to excessive urination. Heart rate will increase. Just imagine this thing. You will come to the correct answer. Heart rate increases, arrhythmia happen, जलन होती है, heartburn होता है, GIT upset, dyspepsia, and headache can also happen. The first two side effect on brain and kidney. Why it happens? Reason you will write on kidney it causes excessive urination because theophylline block adenosine receptor. Because it block adenosine receptor. In GIT and in brain headache happens because it is a phosphodiesterase inhibitor. It is a phosphodiesterase enzyme inhibitor. And on heart, arrhythmia happens because of both reasons. Arrhythmia happens because of both reasons, adenosine blockage and phosphodiesterase inhibition. So this is the most important question. Why consuming tea and coffee causes urination? Because of blockage of adenosine receptor on kidney. Now let's talk about which drug produce this side effect. So can we say it is a white patches? So this is oral thrush, which is also known as oral candida infection. And you know, candida is a white fungus. Candida is a white fungus. And which drug causes? Yes, when a person takes inhalational corticosteroid and they deposit in mouth, it can lead to a fungal infection. And oral steroids, they will end with the word son or nide, like fluticasone, beclamethasone, dexamethasone, budesonide, cyclesonide we discussed. So answer out here is fluticasone. Answer out here is fluticasone. So how you can prevent it? We can prevent this oral thrush by using plastic spacers. Recent MCQ. Plastic spacers, then take inhalation. Steroids will not deposit in mouth. But if you want to treat it, कैंडिडा का ड्रग ऑफ चॉइस क्या था? फ्लुकोनाजोल. कैंडिडा का ड्रग ऑफ चॉइस क्या था? फ्लुकोनाजोल. Understood this part? So this is how you prevent and treat this fungal infection. Now let's talk about a patient presented with cough, yellow green thick sputum. So can we say it is a productive cough? It is productive cough. Which drug should be given to the patient? Now, the drug which is given to the patient is bromhexine. The answer out here is bromhexine. So let's talk about cough. We have first class of drug for cough, that is expectorant, which will expel out mucus. Because they will expel out mucus, they are also known as mucolytic drug, and they are given for the treatment of productive cough. Because productive cough happens in cases of infection most of the time. Productive or infective cough. Agreed? Now we have three drugs. First is bromhexine. Bro word is coming. Another bro of bromhexine is ambroxol. And N-acetylcysteine, you know, antidote of paracetamol poisoning, also used in cough as a mucolytic drug. The second class of drug we have is antitussive. Antitussive drugs, they will act on brain and they will directly suppress cough. So they are also known as cough suppressant. So they are given in the treatment of dry or non-infective cough. Dry or non-infective cough. But the point to be noted is that antitussive drugs are absolutely contraindicated in cases of infective cough. Infection will not come outside. So what are the drugs we have? DON. So D stands for dextromethorphan. So dextromethorphan, you will write, it acts on brain and it blocks NMDA receptor. It is an NMDA receptor antagonist. Then we have opioids like morphine and codeine. Remember, from codeine we made pholcodeine. From morphine we made levorphenol. We made levorphenol. How we can remember? See, dextromethorphan orphan word आ रहा है इसमें. लिवोरफेनॉल ऑर्फन वर्ड आ रहा है इसमें भी. तो ऑर्फन वाले ड्रग्स क्या होंगे? ऑर्फन वाले ड्रग्स क्या होंगे? एंटीटसिव. एंड द लास्ट ड्रग वी हैव इज नॉस्केपीन. नाउ कैन यू टेल मी विच कफ ड्रग्स आर addictive drugs? So the problem with opioid is opioids have lot of addiction. Lot of addiction. Dextromethorphan and noscapine, non-addictive drugs. Non-addictive drugs. So the drug which is an addictive is opioids only. Okay. Okay. Levopropoxyphene is basically beta opioid only, but it is mainly given as an oral tablet most of the time. And propoxyphene in India, it has been recently banned also. People were abusing it. Most of the cough syrups now have been banned. Now, which last year MCQ, some 6 months back, synthetic prostaglandin receptor agonist given for the treatment of pulmonary artery hypertension. Now, if you see the word prost, you can see triprostinyl word is coming. Remember, it is also a prostaglandin. It is also a prostaglandin. Agreed? But remember, it is not a synthetic, it is a natural prostaglandin. The answer of this question is selexipag. The answer of this question is selexipag. Okay. So let's talk about what are the drugs we have for pulmonary artery hypertension. So the drugs for pulmonary artery hypertension is Pepsi, Coca-Cola. In Pepsi, the first P stands for prostaglandin I2. So all these drugs are vasodilator, which will dilate pulmonary artery and pressure will reduce. So these prostaglandins are Ti, 3 prostaglandin Ti. So triprostinyl, prost word is coming. Eloprost, prost word is coming. And epoprostinol, prost word is coming. Remember, these drugs are not given orally. They are either given IV or inhalationally. They are not given orally. But remember, they are the drug of choice for PAH because they are the most effective drug. Second class of drug we have is endothelin antagonist. Endothelin normally causes vasoconstriction. So block endothelin receptor. They will end with the word entan. They will end with the word entan. Why they will end with the word entan? Because they are endothelin antagonist. A very important drug, bosentan, ambrisentan, macitentan. Understood? Then we have phosphodiesterase 5 inhibitor. That is sildenafil and tadalafil. They are also the drug of choice for erectile dysfunction, that is impotence, erectile dysfunction or impotence. Then we have guanyllyl soluble, guanylyl cyclase activator, guat word will come, guanylyl cyclase activator. Then we have a drug which is not a prostaglandin but stimulate prostaglandin receptor. So which drugs stimulate I2 type of prostaglandin receptor agonist? The drug name is selexipag. How to remember? I2 type of prostaglandin, P for prostaglandin, AG for agonist. Agonist word aa raha hai, AG for agonist. Now why we have made this drug? Because this drug can be given orally. This drug can be given orally. Prostaglandins cannot be given orally. We can also give continuous nitric oxide inhalation. And lastly, we can give calcium channel blocker, amlodipine and nifedipine when the patient is having pulmonary artery hypertension with systemic hypertension. With systemic hypertension. Chalo, let me ask you a question. And let's see in which group you want to place this drug. Okay. So let me write a drug for you. Tell me in which group you want to place this drug. Vericiguat. Let's apply a maths. Can you tell me where would you like to place vericiguat, a new drug? Guat word is coming. GU for guanylyl cyclase, AT for activator. Don't you think it is looking like vericiguat? Remember, Riociguat is given for pulmonary artery hypertension, while Vericiguat is given for chronic heart failure. It's a new drug approved for chronic heart failure. Okay, chronic heart failure. Chalo, let me give you one more drug. Tell me the answer of this. Where would you like to place this drug? Aprocitentan. Where would you like to place this drug? Aprocitentan. See the last name. Antan word is coming. Antan word is coming. So it is similar to bosentan. Remember, bosentan is given for pulmonary artery hypertension and aprocitentan is given for resistant hypertension. Resistant hypertension means whole body hypertension. Whole body hypertension, we give aprocitentan, a new drug. So Vericiguat, aprocitentan, new drugs for INI-CET only. So now let's talk about CVS. So which of the following diuretic is matched correctly with its primary mechanism of action? So let me tell you all diuretics first. Diuretic is important topic. One or two question will definitely come. So let's see, this is nephron. So the first part of the nephron is PCT. You know PCT, proximal convoluted tubule. On PCT, which diuretic works? On PCT, carbonic anhydrase inhibitors, they will work. Agreed? They will end with the word zolamide or amide, acetazolamide, methazolamide, dichlorphenamide. Where they are used? So you will write acetazolamide used in glaucoma. It is given to alkalinize urine. Why it is given for alkalinizing urine? Because it will cause excretion of bicarbonate ion in urine. So if urine becomes alkaline, what will happen to blood? Acetazolamide causes metabolic acidosis in blood because in blood H plus ion will increase and they are given for epilepsy. Now the point you have to remember is, so remember a mnemonic game. Now because they cause metabolic acidosis, acetazolamide, this H plus ion stimulates our respiratory centers. It stimulates our respiratory centers and to increase breathing, acetazolamide is a drug of choice for mountain sickness. Because in mountain sickness, the person stops breathing. To increase breathing again, we give acetazolamide as a drug of choice for mountain sickness. But if I'll ask you, what is the logical treatment of mountain sickness? The first treatment should be माउंटेन पे चढ़े गए हो, सडनली पहुंच गए हो, वापस नीचे आ जाओ. फर्स्ट ट्रीटमेंट शुड बी रैपिड डिसेंट. फर्स्ट ट्रीटमेंट शुड बी रैपिड डिसेंट. अगर प्रॉब्लम हो रही है तो पहले नीचे आ जाओ, नीचे नहीं आ सकते तो एसिटाजोलामाइड ले लो. ठीक है, समझ आ गई बात. देन वी हैव नेक्स्ट पार्ट ऑफ द नेफ्रॉन, दिस पार्ट, दिस इज नोन एज लूप ऑफ हेनले. On loop of Henle, which diuretic works? On loop of Henle, osmotic diuretic work, and the osmotic diuretic we have is very famous drug mannitol. Agreed? Now remember, mannitol brain पे भी काम करता है, mannitol eyes पे भी काम करता है. In brain, mannitol decreases intracranial pressure. That is why mannitol is the drug of choice for cerebral edema. In eyes, mannitol reduces intraocular pressure. It can be given during acute attack of glaucoma. So two diuretics which are given in acute attack of glaucoma is acetazolamide, remember the word game. Second we have is mannitol, given in acute attack of glaucoma. Understood? And sometimes this cerebral edema can happen during dialysis also. डायलिसिस के दौरान भी आईसीपी इंक्रीज हो सकता है, ऑस्मोलैरिटी चेंज हो जाती है. दिस कंडीशन इज नोन एज डायलिसिस disequilibrium. We give mannitol. But mannitol is the only diuretic which is contraindicated in the patient of, I will tell you shortly, heart failure. कौन सा diuretic heart failure में नहीं देना? Mannitol heart failure में नहीं देना. Now above this loop of Henle we have thick ascending limb. We have thick ascending limb. On thick ascending limb, which diuretic work? Loop diuretics, they work on thick ascending limb and they inhibit one transporter, that is sodium, potassium, 2-chloride transporter. So the first diuretic which we made in loop diuretic is mercury containing, Marsalil, highly ototoxic, no longer use. Then we made no sulfur containing drug, like sulfur containing drug, furosemide, torsemide, and bumetanide. Okay, and then we have not mercury, non sulfur containing ethacrynic acid. ठीक है, we will come to loop diuretic. Remember, loop diuretic are the most effective diuretic we have. That is why they are known as high ceiling diuretic. So which diuretic are known as high ceiling diuretic? Loop diuretic. Above loop, let's talk about DCT, distal convoluted tubule. On DCT, which diuretic they work? Remember, thiazide diuretic they work. They inhibit one transporter known as sodium chloride symporter on distal convoluted tubule. So in thiazide diuretic, we have a drug, thiazides. They will end with our thiazide, like chlorothiazide, hydrochlorothiazide, or we can have thiazide like, very important name, CMI, cell mediated immunity, chlorthalidone, थैली वाला ड्रग, मेटल वाला ड्रग, मिटोलाजोन, इंडिया वाला ड्रग, इंडपामाइड. थैली, metal, India, try to remember. Among them, remember mitalazone, safe in low GFR condition or safe in renal failure. Which diuretic can we give among thiazide? Mitalazone. Agree? So where thiazides are used? Thiazides are among diuretic. They are the drug of choice for hypertension. They are the drug of choice for hypertension. We will come to thiazide. Lastly, we have the diuretic that will act on last portion of nephron, that is collecting duct. We have is potassium sparing diuretic. Either they will block aldosterone receptor on collecting duct, aldosterone receptor blocker, they will end with the word on, spironolactone, eplerenone. All they will block the protein which is produced by aldosterone, ENaC protein, epithelial sodium channel, amyloride and triamterene. So overall we have 4 potassium sparing diuretic, that is CET. Remember our mnemonic CET. And these are the only potassium sparing, only diuretic which causes in blood hyperkalemia. कौन से डायूरेटिक हाइपरकैलेमिया करते हैं ब्लड में? द नेम इटसेल्फ टेल्स यू सीट, potassium sparing diuretic. Understood this part? So let's see the important MCQs now. So edema में कौन सा diuretic देना है? The edema due to heart failure, pulmonary edema due to renal failure, the diuretic of choice is loop diuretic. So in pulmonary edema and periorbital edema, we give loop diuretic, but yes, you can give thiazides also. But which is more preferred one? Loop. Agreed? Second, liver failure में ascites edema, which diuretic you will give? Spironolactone. Lastly, cerebral edema, which diuretic you will give? We just discussed mannitol. Which diuretic you will give? Mannitol, osmotic diuretic. Now the point is very important. Let's understand. Mannitol, it is absolutely contraindicated in a patient of heart failure and renal failure. So in these diuretic, it is absolutely contraindicated. Now, which diuretic is absolutely contraindicated in liver failure? That is acetazolamide. Acetazolamide is contraindicated in cases of liver failure. Why? Because in liver failure, acetazolamide increases ammonia level, and ammonia will lead to encephalopathy in cases of liver failure. तो liver failure में कौन सा नहीं देना आपने? एसिटाजोलामाइड नहीं देना. हार्ट फेलियर और रीनल फेलियर में कौन सा नहीं देना? मैनिटॉल नहीं देना. Understood this point? Good. So which is the drug of choice for mountain sickness? That is acetazolamide. But remember, the first treatment is rapid descent. First treatment is rapid descent to lower altitude. To lower altitude. Second point, which diuretic preserve calcium? That is thiazides. Thiazides, they preserve calcium. That is why thiazides, they inhibit the excretion of calcium. They are given in the treatment of renal calcium stones. Like example, calcium phosphate stones treatment, calcium oxalate stone treatment. The diuretic which we give is thiazide diuretic. Point to be noted is thiazides rarely can cause calcium citrate stones. थाइजाइड्स खुद कौन से स्टोन्स कर सकते हैं? थाइजाइड्स आर गिवन इन द ट्रीटमेंट ऑफ कैल्शियम एंड oxalate and phosphate stone, but thiazide themselves can cause calcium citrate stone. Why? Because thiazides, they increase citrate excretion. Last year INI-CET MCQ, तो थाइजाइड से खुद कौन सा स्टोन हो जाता है? सिट्रेट वाला स्टोन हो जाता है. हाई सीलिंग डायूरेटिक, लूप डायूरेटिक. Which diuretic causes gynecomastia? Spironolactone. Why? Because spironolactone, apart from blocking aldosterone receptor, it also blocks testosterone receptor. Which diuretic is safe in renal failure? Drug of choice is loop diuretic. Drug of choice is loop diuretic. But which thiazide is safe in renal failure? Metolazone is safe in renal failure. So metolazone can be given as an add-on drug to loop diuretic in cases of renal failure. Understood this part? These are the specific INI-CET MCQs. Okay, they are specific INI-CET MCQs. So what is the drug of choice for bleeding, esophageal varices and hepatorenal syndrome? So the drug of choice for bleeding esophageal varices is terlipressin. What is hepatorenal syndrome? Chronic liver disease causing ARF is known as hepatorenal syndrome. So in both cases, the drug of choice is terlipressin. Now, in cases of bleeding esophageal varices, you can also give octreotide. You can also give octreotide, but terlipressin is more preferred. What is the drug of choice for bedwetting in children? Desmopressin. Desmopressin. Now, can we say terlipressin and desmopressin? They are ending with the word pressin. So they are vasopressin hormone. Because they are vasopressin hormone, on which receptor they will work? Terlipressin. If we see terlipressin, T का मतलब 1 होता है. It is V1 agonist. It stimulates vasopressin 1 receptor. Desmopressin, D का मतलब 2. It is V2 agonist. It stimulates desmopressin 2 receptor. Now, what is the drug of choice for neurogenic diabetes insipidus? Desmopressin. But what is the drug of choice for nephrogenic diabetes insipidus? Thiazide diuretics. Along with NSAIDs like indomethacin. NSAIDs like indomethacin. Why? Because thiazides and indomethacin, they have antidiuretic action. They have antidiuretic action in cases of diabetes insipidus. Why they become antidiuretic? Why thiazide is becoming opposite antidiuretic in diabetes insipidus? Because when you give thiazides in diabetes insipidus, it decreases GFR and it increases PCT absorption, which will decrease urine volume. So that is why thiazides, they become antidiuretic drug in nephrogenic diabetes insipidus. Now let's talk about opposite condition. When there is excess of ADH hormone in the body or vasopressin hormone, we call it as SIADH, syndrome of inappropriate ADH secretion. And in SIADH, the patient suffers from hyponatremia. So here we give a drug tolvaptan. or any drug which ends with the word veptan, like coniveptan, because these drugs, they block which receptor? Vasopressin receptor. So they are given in the treatment of veptans, SIADH. Understood this part? Good. Now let's talk about this question. Let's see the first question which we missed actually. Chalo, tell me the answer now. I think you can answer now very easily. You can answer now very easily. So tell me, spironolactone, potassium sparing diuretic acting on collecting duct? Absolutely true. Acetazolamide, carbonic anhydrase inhibitor, proximal convoluted tubule? Absolutely true. Chlorthalidone, थैली वाला drug, thiazide. PCT नहीं sir, thiazides they act on DCT. Mannitol, osmotic diuretic? No sir, it acts on loop of Henle. It acts on loop of Henle. So the answer out here is 3 and 4. Understood this part? Sama easy ho gaya. So you know this is the complete summary now in front of you. All diuretics. Now let me ask you this question. Incorrect match according to the usage. Incorrect match batao chalo. Fatafat. Mannitol. Is it given in heart failure? भाई बिल्कुल नहीं. Mannitol तो नहीं देना. False. Loop diuretic? True. Thiazide? Antidiuretic in diabetes insipidus? Ascites. So the answer out here is A. Answer out here is A. Understood this part? चलो. Next पे चलते हैं. Which of the following statement, this was the last year MCQ, following regarding phenerinon is false? Now remember, phenerinon is a new drug like spironolactone. It's a new drug like spironolactone. We have a new drug, phenerinon. So they both block which hormone receptor? Yes, they both block aldosterone receptor. They both block aldosterone receptor in which part of kidney? In collecting duct of kidney. Now the point is, spironolactone is a steroidal drug. Phenerinon is a non-steroidal drug. Agreed? Spironolactone also blocks testosterone receptor. That is why the side effect of spironolactone is gynecomastia. Phenerinon, no such side effect, no risk of gynecomastia. Now this aldosterone hormone is a very bad hormone. It damages organ. So when you give spironolactone, it also protects the heart. It also protects the liver. While phenerinon is mainly given to protect the kidney. So now tell me, where would you like to use spironolactone? Spironolactone is given in CHF and CLD, in chronic heart failure and in chronic liver disease. To protect heart and liver, we give spironolactone. But which drug has been approved for CKD, chronic kidney disease? The answer is phenerinon. समझ आई बात? Now, what is the risk? Remember, they increase potassium level and they decrease BP because of sodium loss in urine. So it has very high risk of causing hyperkalemia, very high risk of causing hypotension. Phenerinon, very low risk of causing hyperkalemia, very low risk of causing hypotension as compared to spironolactone. Understood this part? Last year, 6 months back, this question came in INI-CET. Keeps this thing in your mind, in front of you. Answer this question now. You have to find the false statement. Okay? It is cardioprotective. Yes, it is cardioprotective, but it is not approved for CHF. It is excreted through kidney. Obviously, diuretic है तो kidney से ही निकलेगा. It causes less hyperkalemia as compared to spironolactone. Yes. It produces significant BP reduction as compared to spironolactone. The answer is no. So the answer out here was D. The answer out here is D. I hope now you can answer this question. It's a tough one. I hope you can answer. So see this slide, keep this slide in front of you and read it. Next question, a 58-year-old man, stage 2 hypertension, without any comorbidities, which drug you will start? What is the answer? So the answer out here is, let me tell you, thiazide diuretic. So thiazide diuretics, remember, they are the drug of choice for essential hypertension. Essential hypertension means no comorbidity, and we say it is the BP is more than 130/80. Loop diuretic can be given for hypertensive emergency. Spironolactone, which is a potassium sparing diuretic, it is given for resistant hypertension. It is given for resistant hypertension. So let's talk about treatment of hypertension now. Okay? Essential hypertension, BP more than 130/80 plus no comorbidity, no other disease. So you can start any of these three drugs. CAT. C for calcium channel blocker DHP type. So these drugs, they will end with the word dipine, like amlodipine, any drug which ends with the word dipine, etc. You can start ACE inhibitor or ARB. They will end with the word pril or sartan. Or you can start thiazide diuretics, which we have just discussed. If the blood pressure is not controlled by, BP not controlled by three drugs, you have started three drugs. If the BP is not controlled by three drugs together, this is known as resistant hypertension. So here you will start aldosterone blockers like spironolactone, and the brother of spironolactone which you can start is eplerenone. You can start eplerenone in cases of resistant hypertension. But the choice of antihypertensive changes when there is some comorbidity. So hypertension with kidney disease, CKD. And in kidney disease, there is albuminuria. Hypertension with diabetes mellitus, stroke and retinopathy. Here you will start initially with ACE inhibitor. So you will start with any drug that will end with the word pril. Agreed? But ACE inhibitor has one problem. The problem with ACE inhibitor is that ACE inhibitor, they increase bradykinin level. प्रिल वाले ड्रग क्या करते हैं? ब्रेडिकाइनिन का लेवल बढ़ाते हैं. पेशेंट विल हैव कफ, patient can have allergy on face, angioedema. In that case, shift over to ARB. Shift over to ARB, angiotensin receptor blocker. These drugs, they will end with the word sartan. Agreed? Now, hypertension with stable angina, HOCM, hypertrophic obstructive cardiomyopathy, aortic dissection, migraine, thyroid storm. Here the drug of choice is beta blockers like propanolol, atenolol, etc. Okay? Any drug ending with the word lol. But problem with heart की बीमारियां तो beta blocker ही दोगे. But beta blocker, remember, they are contraindicated in a patient of asthma. If they are contraindicated, we start with calcium channel blocker non-DHP type. And there are two drugs which are used as a replacement for beta blocker in asthma people, that is verapamil and diltiazem. अगर कहीं भी एस्थमा वर्ड आएगा तो बीटा ब्लॉकर नहीं यूज करोगे. कौन सा यूज करोगे? वेरापामिल या डिल्टियाजाम. दे विल ऑल्सो एक्ट ऑन हार्ट. Now, hypertension with pulmonary artery hypertension. Agreed? Renal artery stenosis, vasoconstriction. यहाँ पे क्या होता है बेटा? यहाँ पे vasoconstriction हो जाती है. In this condition, you will start calcium channel blocker DHP type. And DHP type, they will end with the word dipine, like amlodipine, clenidipine, कोई भी dipine वाला drug, nimodipine. ठीक है? Nifedipine you can start because they will act on blood vessel, they don't act on heart. सो नॉन डीएचपी जो होते हैं वो हार्ट पे काम करते हैं, वेरापामिल एंड डिल्टियाजाम। डीएचपी ब्लड वेसल पे काम करते हैं। नाउ रिमेंबर वन ड्रग, नाइमोडिपीन। नाइमोडिपीन is a drug of choice for SAH, which stands for hypertension with subarachnoid hemorrhage. Hypertension with subarachnoid hemorrhage, give naimodipine. Hypertension with subarachnoid hemorrhage. Understood this part? Now, a 70-year-old male patient with hypertension, diabetes, progressive shortness of breath, bilateral pedal edema, ventricular hypertrophy. Ventricular hypertrophy. Can we say patient is suffering from CHF or heart failure, chronic heart failure? Which drug you will start? Which drug you will start? Remember, right now the patient cardiac output is maintained. Right now the cardiac output is maintained. Agreed? Do you agree? If the cardiac output is maintained, will you give inotropic drug? If cardiac output is maintained, only give cardioprotective drugs. Only give cardioprotective drugs. And if left ventricular ejection fraction is less than 40, that means cardiac output is reduced. If cardiac output is reduced, then we give inotropic drugs. Then we give inotropic drugs, and that inotropic drug is digoxin. Digoxin will increase cardiac output. Understood this part? Understood this part? Now tell me the answer. Will you give digoxin here? Will you give digoxin here? No, the answer out here is dapagliflozin. Dapagliflozin is SGLT2 inhibitor. It's a cardioprotective drug given in cases of CHF. So let's see what are the different cardioprotective drugs we have in cases of CHF. Mnemonic is SAHIBs. So you will give when the left ventricular ejection fraction is more than 50%. Give cardioprotective drugs. So first is sacubitril. Sacubitril is given in combination with the drug known as valsartan, and this combination is known as ARNI, that is angiotensin receptor and neprilysin inhibitor, which I'll be explaining you shortly. And this is the first drug to be started. According to new guidelines, first drug to be started is sacubitril with valsartan combination. Agreed? Then we have ACE inhibitor, pril and sartan wale drug. You can start. Aldosterone blocker, spironolactone. Hydralazine and ivabradine, only used as a replacement. Only used as a replacement to above drug. Otherwise, we will not start them. Then we have beta blocker. Remember, only and only 4 beta blockers have cardioprotective effect. कितने बीटा ब्लॉकर कार्डियोप्रोटेक्टिव होते हैं? सिर्फ और सिर्फ 4. सो रिमेंबर, न्यू बॉम्बे मेडिकल कॉलेज, ऐसे याद कर लो. So the first one, which beta blocker has cardioprotective effect? The first one you will write is nebivolol. Nebivolol. Second is bisoprolol. Then we have metoprolol. And lastly we have is carvedilol. And most of the time the examiner will ask you carvedilol. Most of the time examiner will ask you carvedilol. Okay. And lastly, we have SGLT2 inhibitor. SGLT2 inhibitor now are the second line drug we have. That means with these drugs, we will add now. We add now in combination SGLT2 inhibitor. Okay. We always add them. So we generally add them with them. And these drugs, they will end with the word gliflozin. Like dapagliflozin, empagliflozin, and canagliflozin. SGLT inhibitor, I'll explain you. Now, which drug is absolutely contraindicated in CHF? Calcium channel blocker, verapamil and diltiazem. They are absolutely contraindicated in CHF. Remember, beta blocker देते हैं, calcium channel blocker हम CHF में नहीं देते. The reason is beta blocker have cardioprotective effect. Calcium channel blocker do not have any cardioprotective effect. So verapamil and diltiazem have no cardioprotective effect in CHF. Understood this part? So now let's talk about very important point. Remember, in our body we have natriuretic peptides. So natriuretic peptides have diuretic action, and diuretic action, they are good for heart. They are good for heart. And that is why we have made synthetic form of BNP. BNP is B type of natriuretic peptide. That synthetic form is nesiritide. The drug name is nesiritide. And nesiritide is given in the treatment of CHF, chronic heart failure. Now, after these natriuretic peptides are produced, they go to the liver and they becomes degraded. They are degraded by an enzyme, neprilysin enzyme. Nepri means natriuretic, lysin means degrading enzyme, and neprilysin enzyme is also known as neutral endopeptidase enzyme. So we have a drug that will inhibit this enzyme and increase the level of natriuretic peptide. The drug name is sacubitril. समझ आ रहा है sacubitril? Sacubitril is a neprilysin or NEP inhibitor, increases natriuretic peptide level. Now we have a new drug, dual neprilysin inhibitor and ACE inhibitor. The drug name is omapetrilat. Sampetrilat. And remember, omapetrilat was asked last year which drug is a dual neprilysin and ACE inhibitor. Omapetrilat last year MCQ of INI-CET. Okay, last year MCQ of INI-CET. Understood this part? Good. Now let's move ahead. Another question: which drug act on the transporter in the given image? Let's identify this transporter. This transporter is using sodium, and sodium is going outside. ठीक है? Then potassium is coming inside. ठीक है? And it is using ATP. So which transporter we are talking about? Yes, we are talking about sodium potassium ATPase. So digoxin has inotropic effect because digoxin inhibit which transporter on heart? It inhibit sodium potassium ATPase transporter on the heart. Okay, I'll teach you about other drugs also. Okay, so the answer out here is digoxin. Let's talk about side effect of digoxin. Most common side effect of digoxin is nausea and vomiting. Digoxin blocks testosterone receptor and digoxin causes gynecomastia. So which drug causes gynecomastia? The list is in front of you. Disco. And try to remember digoxin and all other drugs, remember, like isoniazid, ketoconazole, omeprazole. All these drugs are CYP enzyme inhibitor. Remember, CYP enzymes, they make testosterone in our body. So isoniazid, ketoconazole, omeprazole we discussed, they are CYP inhibitor. Abhi padha humne. So they decrease testosterone production in our body. And we discussed diuretic. कौन सा diuretic? Spironolactone, which causes gynecomastia. Antifungal drug causing gynecomastia, ketoconazole. TB drug causing gynecomastia, isoniazid. Proton pump inhibitor causing gynecomastia, omeprazole. Now digoxin causes a very specific side effect of digoxin is yellow vision or xanthopsia. Okay, digoxin causes yellow vision. Blue green color blindness, side effect of sildenafil. Red green color blindness, side effect of TB drug ethambutol. Digoxin causes arrhythmia. It causes ventricular bigeminy. Bigeminy means extrasystole. It is asymptomatic arrhythmia. Asymptomatic arrhythmia require no treatment. But which is the most fatal arrhythmia? Ventricular fibrillation. Normally, what you do in ventricular fibrillation? You give electric shock or cardioversion. But if this ventricular fibrillation is caused by digoxin, remember, electric shock or cardioversion is absolutely contraindicated. We never give electric shock if VF is caused by digoxin. So what is the treatment? Give antiarrhythmic drug lignocaine. Give antiarrhythmic drug lignocaine. Digoxin never causes atrial flutter because it converts atrial flutter into fibrillation. So what is the digoxin therapeutic range in blood? In blood, the normal range of digoxin is 0.6 to 2.0 nanogram per ml. Hemodialysis is not effective in digoxin toxicity because digoxin has a very high volume of distribution, and antidote of digoxin poisoning we have already discussed is digibind, which is an antibody against digoxin, which is an antibody against digoxin. Understood this part? Now find the incorrect mechanism regarding anti-anginal drug. Okay, beta. I'll give you tricks. We will come back to this MCQ. First, let's talk about treatment of angina. For acute attack of angina, you give sublingual route with nitrate. Okay. You give sublingual nitrate like glyceryl trinitrate, isosorbide dinitrate. Okay. How nitrates they work in angina? Nitrates, remember, they are venodilators. They are venodilators. They will reduce the blood which is going to the heart. They will reduce preload in angina. Now for the long-term treatment of stable angina, we give beta blockers ending with the word lol. So chronic stable angina, chronic vasospastic angina, we give calcium channel blocker. Okay. But remember, never combine beta blocker with calcium channel blocker like verapamil and diltiazem. Never combine them together because patient will have sudden death because of bradycardia. Because of bradycardia, the patient will suddenly die. Similarly, never combine nitrates with sildenafil and tadalafil. Sildenafil and tadalafil, I told you they were phosphodiesterase 5 inhibitor given in pulmonary artery hypertension. Initially, they were tried in angina. Patient will have hypotension and sudden death. So never combine sildenafil and tadalafil with nitrate. Patient का honeymoon खराब हो जाएगा. Patient will suddenly die before he can make love. He can do anything to his loved one. Person will die on that bed only. Such a tragic death no one should get. Okay. Now let's talk about second line drugs for angina. Mnemonic is no drift. Yes, death on honeymoon. बिल्कुल सही. हमने पढ़ा है. No drift. N for Nicorandil. How we can remember Nicorandil? See Nicorandil. It is a COR DIL. COR DIL word aa raha hai. So Nicorandil is a potassium channel opener which causes coronary dilator. And opening potassium channel causes coronary artery dilation. See the word COR and DIL. It is a coronary dilator and it is given in angina, AN angina. Good. Then we have dipyridamole. It is also a coronary dilator. But in which area of the heart? Non-ischemic area. So what will happen? It will further reduce the blood supply. It will reduce the blood supply in ischemic area because it is dilating. It is dilating coronary artery in ischemic area. So can you tell me where the blood will flow? The blood will flow towards non-ischemic area. So that is why this dipyridamole got banned, because it causes coronary steal syndrome. It causes coronary steal syndrome. Then we have ranolazine. Na word is coming. So it blocks some sodium channel on heart. It causes sodium channel blockage. Side effect, QT prolongation. Why? Because it also blocks potassium channel on heart. It also blocks potassium channel. Side effect is QT prolongation. Ivabradine. Brady. It is a bradycardia. This drug causes bradycardia. How ivabradine causes bradycardia? It causes bradycardia By blocking which node? Obviously SA node. And which channels are present on SA node? That is funny channel. Side effect of ivabradine, it causes visual abnormality. It causes some luminous phenomena. Why? Because retina also contains funny channel. Fasudil, rho kinase inhibitor. This is important. Trimetazidine, PFOX inhibitor. Where does PFOX stands for? Partial fatty acid oxidation inhibitor. कैसे याद करेंगे? See, very simple. PFOX means P for partial, F for fatty acid, and OX for oxidation inhibitor. In simple word, when you give trimetazidine, fatty acids will not get oxidized and ATP will not be produced. Fatty acids will not produce ATP. Now, what the heart will do? Heart will shift the metabolism from fatty acid to glucose because glucose require less oxygen to produce ATP, which is a good thing in cases of angina. So which drug shift the metabolism? Metabolism को shift करने वाला मेटाजिडीन. मेटाजिडीन मेटाबॉलिज्म को शिफ्ट कर देता है. ट्राई का मतलब ट्राइग्लिसराइड्स और फैटी एसिड्स विल नॉट बी मेटाबोलाइज्ड. Heart will shift, now will use glucose as an energy source. Understood this part? Given in angina. Now, which drug is given in maintenance therapy of this given arrhythmia? So remember, in any ECG, the easiest wave to identify is always and always QRS complex. तो सबसे पहले QRS देखो. And there is a rule in ECG, the next wave after QRS will always be T wave. अब T wave के बाद क्या हुआ बेटा? दोबारा QRS आ गया. सो कौन सी वेव एब्सेंट है? सो देयर इज एब्सेंट P wave. Absent P wave is seen in which arrhythmia? That is PSVT. That is paroxysmal supraventricular tachycardia. Which drug is given as a maintenance therapy? The answer out here is verapamil. Answer out here is verapamil. Remember, adenosine is given in acute therapy. In maintenance, we give calcium channel blocker. So answer out here is verapamil. Don't see PSVT and blindly go with adenosine. Examiner will confuse you. कहीं भी PSVT दिखा adenosine नहीं mark करना. Understand, PSVT, adenosine, remember, it is a very short acting drug. So let's see the treatment of first PSVT. So PSVT, acute attack, we give adenosine IV drug. Agreed? Then in maintenance therapy, we give beta blocker. We give which drug? We give beta blocker. But remember, both adenosine and beta blocker are contraindicated in a patient of asthma. So, which drug can be given as a maintenance phase in asthma? In maintenance phase, in asthma, we give calcium channel blocker verapamil. Agreed? Second point, a new drug. Verapamil का ही भाई बनाया हमने. The drug name is recently got approved. Atripamil. Atripamil is available as nasal spray. So it is given for acute attack with asthma. कहानी समझ आई? Acute attack with asthma, Atripamil. Maintenance phase with asthma, Verapamil. Verapamil is a long-acting drug. Beta blocker, overall drug of choice for maintenance. Overall drug of choice for acute attack, PSVT, that is adenosine. Now see the next one. QRS complex with same morphology. Can we call them as monomorphic ventricular tachycardia? You can also write VF. The drug of choice for monomorphic ventricular tachycardia is amiodarone. The drug of choice is amiodarone. See the next image. Can we say again QRS complex with multiple types? So can we call it as polymorphic ventricular tachycardia? Polymorphic ventricular tachycardia, different shapes of QRS complex. Polymorphic ventricular tachycardia, it is also known as torsades de pointes. In torsades de pointes, amiodarone is absolutely contraindicated. It itself can cause polymorphic ventricular tachycardia. Here the drug of choice you all know is magnesium sulfate. Here the drug of choice is magnesium sulfate. But remember, if in any arrhythmia, if the patient is hypotensive, patient is going into shock, the first treatment is give shock. First treatment is shock, then we start drugs. Drugs tab start karenge if the patient blood pressure is normal. If the patient blood pressure is falling, first give shock, then give drugs. Understood this part? Agreed? So in PSVT atrial arrhythmia you will give synchronized cardioversion, while in ventricular arrhythmia you give high intensity shock, which is known as DC shock. Understood this part? Good. Now remember, any drug which blocks sodium channel. Sodium channel leads to depolarization. It will reduce which phase? Sodium channel blocker, they decrease phase 0 slope. They will decrease phase 0 slope. Drug like lignocaine is a sodium channel blocker. It reduces phase 0 slope. And any drug which block potassium channel will increase phase 3 duration. It will increase phase 3 duration. Which drug is a potassium channel blocker? Amiodarone. Amiodarone increases phase 3 duration, and any drug which is a potassium channel blocker is inhibiting repolarization. Any drug which is a potassium channel blocker also causes QT prolongation and increase the risk of torsades de pointes, and that is why amiodarone is contraindicated in torsades de pointes. Okay, now post MI amiodarone ही देना है. Now what are the side effects of amiodarone? Bitch. So amiodarone, you can see IOD word is coming. IOD word क्यों आता है? Because it contains iodine. 37% iodine. देखा है iodine पर्पल ब्लू कलर का बीटाडीन लोशन, when it deposits on skin, blue or purple man syndrome. It can lead to lung fibrosis. Iodine can lead to hypo and hyperthyroidism. And iodine, when this amiodarone deposits in cornea, this reversible deposition on cornea leads to cornea verticillata. You can see white hazy lines like this. So this is deposition of amiodarone on cornea. So this cornea verticillata, it is also known as vortex keratopathy. It is also known as vortex keratopathy. And lastly, it is hepatotoxic drug. Remember the side effect of Remember the side effects of this amiodarone. Now, which hypolipidemic drug reduces lipoprotein A levels? The answer of this question is niacin. Niacin reduces lipoprotein A levels. So let's discuss all hypolipidemic drugs commonly asked. So the first drug we have is statins. Second we have is resins. Third we have is fibrate. And which vitamin has hypolipidemic action? Niacin. So statins like atorvastatins and all, they inhibit HMG CoA reductase enzyme, which decrease cholesterol synthesis in liver. Understood this part? They are the drug of choice for decreasing LDL level. LDL contains which molecule? LDL contains cholesterol. The main side effect of statins is muscle pain, myopathy, muscle damage, cola colored urine, that is myoglobin Then we have raisins. So raisins, they will start with the word col. They are bile acid binders. They reduce the absorption of bile. If bile is not absorbed, cholesterol will be excreted out in feces. They are the drug of choice. They are the drug of choice to decrease LDL level in pregnancy. So drug of choice in pregnancy is raisins. Side effect malabsorption or steatorrhea because bile is not getting absorbed. Then we have fibrate, phenofibrate, bezafibrate, gemfibrozil fibrate word is coming. They are PPAR, alpha agonist, and by stimulating this receptor they increase the production of one enzyme, lipoprotein lipase enzyme, and this lipoprotein lipase removes triglycerides from the blood, so they are given to decrease triglyceride levels. So to reduce triglyceride level we give this drug. Again the side effect is myopathy. Again, the side effect is myopathy. And lastly, we have niacin. Niacin is also known as nicotinic acid and vitamin B3. Niacin increases HDL level, good lipid. And niacin is the only lipid which decreases the level of lipoprotein A, which is a marker of atherosclerosis. And this niacin is used as an add-on drug to statins. It is given as an add-on drug to statin. Now, what is the side effect of niacin? This is a very, very important topic. The most common side effect of niacin is flushing. कौन सा हाइपोलिपिडेमिक ड्रग फ्लशिंग करता है? दैट इज नियासिन. एंड फॉर द ट्रीटमेंट ऑफ दिस फ्लशिंग ड्यू टू नियासिन we give a drug aspirin. And which drug causes gout? Gout किससे होता है? यूरिक एसिड का लेवल बढ़ा देता है. Again the answer is niacin causes gout. This is a very very important MCQ. कौन सा फ्लशिंग करेगा? नियासिन. वेजोडायलेशन करेगा, यूरिक एसिड का लेवल बढ़ाएगा. रिमेंबर, क्वेश्चन विल कम फ्रॉम हियर ओनली. नाउ लेट्स टॉक अबाउट new hypolipidemic drug. So we have evolocumab, LOC word is coming. Alirocumab, LOC word is coming. These are the monoclonal antibodies which inhibit PCSK9 enzyme. They are PCSK9 inhibitor. Agreed? So next we have is inclisiran, a new drug. They are the PCSK9 inhibitor, and these drugs are given to decrease LDL level, which I will be telling you. So ये बिल्कुल true है, ठीक है. Next we have last year MCQ, bempedoic acid. Bempedoic acid inhibit ATP citrate lyase enzyme, but this is a false statement. It is not a non-competitive. It is rather a competitive inhibitor of ATP citrate lyase enzyme. It's a competitive inhibitor of ATP citrate lyase enzyme. Then we have ezetimibe, NPC1L1 transporter inhibitor. It decreases cholesterol absorption from GIT. Agreed? Now, what are the uses of first three drugs? The first three drugs, these drugs are given as an add-on drug to statins. They are given as an add-on drug to statin to decrease LDL level. This is a very important statement. A new drug, resmetirom. Resmetirom stimulate thyroid hormone receptor beta, and it is a drug which is given for the treatment of fatty liver. The only drug approved for the specifically for the treatment of fatty liver is resmetirom, which is also known as NAFLD, है ना? NAFLD, है ना? And non-alcoholic steatohepatitis liver disease, you know. NASH भी बोलते हो इसे. अब NASH की बजाय MASH भी बोलते हो. Metabolism associated steatohepatitis. So the answer out here was B. It is a competitive inhibitor, last year MCQ, not a non-competitive inhibitor. Which drug has antiplatelet action against GP2B3A? Which drug is a GP2B3A inhibitor antiplatelet drug? The answer is ABC वाली monoclonal antibody Abciximab. So let's discuss all antiplatelet drug in one place. The first antiplatelet drug is aspirin. Aspirin inhibit COX enzyme. In which fashion? Irreversible fashion. Any drug which is an irreversible inhibitor is also known as suicide inhibitor, hit and run drug. By inhibiting COX enzyme, it decreases thromboxane production inside the platelet. Platelet will not attach. Aspirin is the drug of choice for MI, stroke, and Burgess disease. What about other antiplatelet drug? All other antiplatelet drugs are given as an add-on drug to aspirin. So when we add other drugs to aspirin, this is known as DAPT. DAPT stands for dual antiplatelet therapy. So the second class of antiplatelet drug we have is ADP receptor blocker and P2 vital blocker. So they will either end with the word grel or they will end with the word grelor. ग्रेल वाले जो हैं इरिवर्सिबल ब्लॉकर हैं, लाइक क्लोपिडोग्रेल एंड प्रासुग्रेल. ग्रेलॉर वाले जो हैं वो रिवर्सिबल ब्लॉकर हैं. वन अनदर ड्रग इज टिक्लोपिडीन. ग्रेल वाले ड्रग इरिवर्सिबल ब्लॉकर, दे आर प्रो ड्रग्स. MCQ. रिवर्सिबल वाले जो हैं ग्रेलॉर वाले, दे आर नॉट प्रो ड्रग, दे आर एक्टिव ड्रग. Pro drug means they are inactive drug. Inside the body, they get converted into active form. Understood this part? Then we have phosphodiesterase 3 inhibitor. How to remember? P for pentoxifillin, D for dipyridamole, 3 third alphabet is C, that is cilostazol. So they are add-on drug with aspirin. Okay. Lastly, we have is GP2B3A inhibitor, glycoprotein 2B3A inhibitor, E80 eptifibatide, and the most important one is Abciximab. How to remember? A monoclonal antibody with word ABC. तीनों वर्ड आ रहे हैं. Antiplatelet drug है. And remember, all monoclonal antibodies, any type of monoclonal antibody is a protein. Proteins are safe in renal failure because proteins are not excreted out in urine. So remember one statement, all monoclonal antibodies, they are safe in renal failure. So which antiplatelet drug is safe in renal failure? That is Abciximab. A new antiplatelet drug is Vorapexar. PAR word is coming. It inhibits PAR1, which is some protease activating receptor, that is X inhibitor. So it's a new antiplatelet drug, protease activating receptor inhibitor, that is Vorapexar, given in MI patients along with aspirin. Now let's talk about which of the following antidote of anticoagulant drug is not correctly matched. Anyone? What is the correct answer of this question? Very simple one which was asked recently. So the answer of this question is option number D. Okay, option number D. Okay, option number D. Let's write the antidotes of all anticoagulant drug. So remember, warfarin inhibits weak or C1 enzyme, some vitamin K dependent C1 enzyme, and because of this reason, warfarin decreases 4 clotting factor in our body, that is 2, 7, 9 and 10. What do you think is the logical antidote of warfarin? The logical antidote of warfarin is vitamin K. Do you agree with this part? Now, if the patient is having bleeding, do you think that vitamin K can suddenly stop bleeding? No. It will increase the production of 2, 7, 9 and 10, which will take some time. If the patient is having bleeding, then we add a drug PCC. PCC stands for prothrombin complex conjugate. Can you tell me this prothrombin complex conjugate will contain how many clotting factors? It is a mixture of 4 clotting factor, that is 2, 7, 9 and 10. If the bleeding starts, then we add PCC. Then we have apixaban, rivaroxaban. So these drugs are factor, which inhibitor? XA word is coming. Factor 10A inhibitor. Agreed? Now these drugs antidote is Endexanet. Antidote क्या है? Endexanet. डेक्सा एक्से वर्ड भी आ रहा है, डेक्सा वर्ड भी आ रहा है. It is synthetic form of which clotting factor? Factor 10A. It is given to stop bleeding. Then we have dabigatran. TR means it is a thrombin inhibitor. It is a thrombin inhibitor. The antidote of dabigatran is idarukizumab. Idarukizumab. It's an antibody against dabigatran. How to remember? दारू वर्ड आ रहा है भाई, दारू वर्ड, डैबी वर्ड आ रहा है. व्हाट इज द न्यूमोनिक आई हैव टोल्ड यू? रिकॉल करो. दबा के दारू पियो, दबा के दारू पियो. डेबिगेट्रान, इदारुकिजुमैब, दारू वाली मोनोक्लोनल एंटीबॉडी. हाई मॉलिक्यूलर वेट हेपेरिन is given by IV route. Low molecular weight heparin like enoxaparin, dalteparin, by which route they are given? They are given by subcutaneous route for long-term treatment. Both their antidote is protamine sulfate. Their antidote is protamine sulfate. But this protamine sulfate is not effective. It is not effective in cases of ultra low molecular weight heparin. And ultra low molecular weight heparin, they end with the word perinux. So perinux like fondaparinux, idraparinux, we don't have any antidote. Now a little bit higher, we have a new drug for, let's make this point, apixaban, rivaroxaban, dabigatran, and heparin. These four drugs, we have a common antidote. That common antidote for apixaban, rivaroxaban, dabigatran, high molecular weight and low molecular weight heparin is siraparentag. Siraparentag. Next additional point, idraparinux, we don't have any antidote. We modified this idraparinux into a drug known as idrabiotaparinux. तो इसमें कौन सा वर्ड एक्स्ट्रा आ रहा है? इसमें कौन सा वर्ड एक्स्ट्रा आ रहा है? इड्रापेरिनुक्स और इड्राबायोटापेरिनुक्स में एक्स्ट्रा वर्ड आ रहा है बायोटिन. कैन वी सी अ वर्ड बायोटा वर्ड आ रहा है? इट कंटेन्स बायोटिन. Yes, we have antidote for idrabiotaparinux. The antidote is avidin. Avidin neutralizes or inactivates by binding to biotin part of idrabiotaparinux. Understood this part? So this is an antidote of all anticoagulant drugs. So now tell me the answer of this question. A patient of ST elevated MI started with retiplase. Within 30 minutes, CT angiography, left anterior coronary showed reperfusion. As the patient was about to shift to ward, he develops the signs of hemiplegia. And NCCT brain revealed left-sided intracranial hemorrhage. Bleeding शुरू हो गई retiplase से. What is the antidote? What is the antidote? What is the antidote of retiplase? The answer is epsilon aminocaproic acid. Epsilon aminocaproic acid. So let's talk about a class of a drug known as fibrinolytic or thrombolytic drug. They remove this thrombus very fast. And how do they act? These molecules, they activate one enzyme in our blood known as plasminogen to its active form plasmin. And this plasmin removes thrombus or remove this fibrin. Among these fibrinolytic, we have two drugs. We have natural enzyme, streptokinase and urokinase. Or we have TPA. You know the full form of TPA? TPA stands for tissue plasminogen activator. And these drugs, they will end with the word tiplase. TPA word will come. L-tiplase, retiplase and tenic-tiplase. And the most preferred drug nowadays is, the best drug we have is tenic-tiplase. What are the uses? The first use of streptokinase, tenic-tiplase like drug is, they are given in the treatment of STEMI. STEMI stands for ST elevated MI, these drugs are absolutely contraindicated in NSTEMI. Never give them in non-ST elevated MI because these drugs can cause fatal internal bleeding. So they are only given for dangerous disease. NSTEMI is not a dangerous thing. They are also given for ischemic stroke. ठीक है? Now in STEMI, they must be given within how many hours? 12 hours. In ischemic stroke, they must be given within how many hours? 4.5 hours. But they are absolutely contraindicated logically in hemorrhagic stroke. They are only given in ischemic stroke to remove thrombus. And lastly, they are also given for massive pulmonary embolism in which the patient is going into right heart failure and going to die. Then we give this drug. Otherwise, we don't give them in pulmonary embolism. Because they are removing thrombus, patient bleeding can start. And if the bleeding with this drug, the antidote of this drug is the antidote to stop bleeding with this drug is two drug, but overall drug of choice is epsilon aminocaproic acid, which is an antifibrinolytic drug which will prevent plasminogen activation. Another drug which we can give is tranexamic acid, but the better drug is epsilon aminocaproic acid. So they are having acid word in them. इनके end में acid word आएगा. Understood this part? So now let's talk about endocrine system. Okay, endocrine system. Done. So find the incorrect match for adverse effect. Metformin, unexplained diarrhea, B12 deficiency, lactic acidosis, true. So let's see first all the diabetic drug. So the first drug for diabetes mellitus we have is insulin secretagogue. These drugs, they will act on pancreas and causes insulin secretion. How they cause insulin secretion? They close ATP sensitive potassium channel. So we have the drug chlorpropamide, amide word will come. They will start with the word gly, or they will end with the word glenide, or they will end with the word glenide. They cause insulin secretion. Now the point is, these first two drugs, they are known as sulfonylurea. They are known as sulfonylurea. Now, what is the side effect of sulfonylurea in these drugs? These drugs in diabetes, they cause hypoglycemia and they can cause weight gain. Why, sir, hypoglycemia? Because insulin causes hypoglycemia and insulin is an anabolic hormone. They can cause weight gain. So which drug in diabetes causes hypoglycemia? Only three drugs. They will end with the word amide, start with the word gly, and end with the word glenide. Apart from this, no other drug in diabetes will produce hypoglycemia. So which drug in diabetes causes hypoglycemia? Only these three drugs you should remember. Next we have is GLP-1 agonist. GLP-1 stands for glucagon-like peptide. Glucagon-like peptide 1. They are also known as incretins. They are known as incretins. So these drugs, they end with the word tide. Now remember one rule. Any drug which ends with the word tide is a peptide. And peptides cannot be given orally. Pepsin trypsin will degrade. So these drugs are given by subcutaneous injection. But recently, we made this semaglutide. Semaglutide is now also available orally also. So which peptide can be given orally? Semaglutide. It is the most effective drug we have now for diabetes, and these drugs, they cause weight loss. They cause weight loss. That is why I will tell you liraglutide, semaglutide and tirzepatide I will be telling you. They are approved as an anti-obesity drug. Ozempic का नाम सुना है? Ozempic. Semaglutide is Ozempic. Side effect, pancreatitis. They can cause pancreatitis. Then we have a new drug, even better than semaglutide, tirzepatide. Tirzepatide is a dual GLP-1 plus GIP agonist. GIP is some glucose dependent insulotrophic peptide. It is also approved for diabetes mellitus, and it also causes weight weight loss. Then we have teduglutide. Teduglutide is GLP-2 agonist, glucagon like peptide 2 agonist. It is approved for the treatment of not diabetes mellitus, it is approved for the treatment of short bowel syndrome. कहाँ देते हैं इसे हम? Short bowel syndrome. It causes growth of intestinal cell. Now remember, these incretins, they are degraded by one enzyme known as DPP4 enzyme. DPP stands for some dipeptidyl peptidase enzyme. So if we inhibit this enzyme, can we say DPP inhibitor, they increase the level of GLP-1 inside the body. So DPP inhibitor, they increase the level of glucagon-like peptide inside the body. So these drugs, they will end with the word gliptin. While these drugs, they will end with the word tide. They will end with the word tide. They will end with the word gliptin. Why they are ending with the word gliptin? GLP-1 level is increased. IN word is coming. Like linagliptin, sitagliptin, vildagliptin, saxagliptin. Why we have made this drug? Because these drugs are oral drug. Remember, in diabetes, any drug which ends with the word tide will be injectable drug. Rest all other drugs will be oral drugs. Remember this part? Now, which gliptin is metabolized by CYP3A4? That is sitagliptin. Sitagliptin is degraded by CYP3A, sorry, the only gliptin which is degraded by CYP3A4 enzyme is saxagliptin. Last year INI-CET MCQ. So avoid giving saxagliptin with. Which student will tell me the reason? Avoid giving saxagliptin with ketoconazole. Any student who can tell me the reason for it? Why it should be avoided with ketoconazole? Because ketoconazole is a CYP inhibitor. It can lead to increase in toxicity of saxagliptin. It will increase saxagliptin. Last year MCQ. Which gliptin रीनल सेफ में कौन सा ड्रग लेना है? रीनल फेलियर में कौन सा ड्रग लेना है? लीनाग्लिप्टिन लेना है. बिकॉज लीनाग्लिप्टिन किससे एक्सक्रीट आउट होता है? सर यूरिन में एक्सक्रीट आउट नहीं होता. लीनाग्लिप्टिन लिवर से एक्सक्रीट होता है. तो लीनाग्लिप्टिन रीनल सेफ, बट अ न्यू ड्रग which is also renal safe is teneligliptin. A new drug available in India, commonly prescribed, teneligliptin and linagliptin, they both are safe in renal failure. Okay? Okay? Understood this part? All are the MCQs of INI-CET. So which of the following, this question came INI-CET 2025, okay, 6 months back. Which of the following DPP inhibitor has significant drug interaction with ketoconazole? The answer was saxagliptin. क्योंकि एक saxagliptin ही CYP3A4 से मेटाबोलाइज होता है, बाकी कोई नहीं होते. Okay. Now let's talk about metformin and pioglitazone. These two drugs, they are insulin sensitizer. That means they decrease the resistance of insulin in the body. Metformin reduce insulin resistance on which organ? Metformin reduce insulin resistance on liver by activating one enzyme, AMPK enzyme. Because of this reason, it inhibits hepatic gluconeogenesis just like insulin. Insulin also inhibit on liver hepatic gluconeogenesis. So glucose production will fall from non-carbohydrate source like lactic acid. While pioglitazone acts on adipose tissue, and pioglitazone stimulates which enzyme? It is a PPAR, gamma agonist, which will lead to lipogenesis, anabolic action, just like insulin. So they will reduce insulin resistance on liver and adipose tissue. Now, what about metformin? The most common side effect of metformin is unexplained diarrhea. It causes diarrhea. Metformin causes B12 deficiency, which can lead to megaloblastic anemia. And by inhibiting hepatic gluconeogenesis, metformin increase the level of lactic acid. It causes lactic acidosis. Because of the risk of lactic acidosis, remember metformin is contraindicated in renal failure. Metformin is contraindicated in cases of, just a second, renal failure. Understood this part? Good. Now what about pioglitazone? Pioglitazone increase the risk of urinary bladder cancer. And pioglitazone is contraindicated in heart failure. Okay. Now what about weight? Metformin, weight loss. What do you think pioglitazone will cause? It is causing lipogenesis. Pioglitazone, weight gain. Pioglitazone, weight gain. Understood this part? Very good. Let's talk about the most important drug, which is sure shot it will be asked in your exam. So this drug is SGLT2 inhibitor, which I will be telling you, dapagliflozin. But before that, let's solve this MCQ. Metformin, diarrhea, B12 deficiency, lactic acidosis, absolutely true. Glimepiride, starting with the word glee. So it's a sulfonylurea. It causes hypoglycemia, absolutely true. Pioglitazone, PPAR gamma, bladder cancer, heart failure, true. Linagliptin causes renal damage, absolutely false. Linagliptin तो renal failure में लेना है ना, पढ़ा हमने. Linagliptin तो renal failure में लेना है हमें. Good. चल आगे बढ़ते हैं. Let's talk about a beautiful drug, then I'll come back to this question. SGLT2 inhibitor. So they inhibit SGLT in PCT of nephron, which will lead to excretion of sodium and glucose in urine. So that is why they are known as sodium glucose transporter inhibitor. So these drugs, they will end with the word gliflozin. Flow word आ रहा है, फ्लो वर्ड आ रहा है, ये यूरिन का फ्लो बढ़ाते हैं ड्रग. कानाग्लिफ्लोजिन, डापाग्लिफ्लोजिन, एम्पाग्लिफ्लोजिन, SGLT2 inhibitor, sotagliflozin, SGLT1+2 inhibitor. It is a dual drug. And SGLT2 is present in DCT. SGLT1 is present in, 2 is present in PCT. SGLT2 जो है वो बाद में होता है, वो DCT में होता है. Now because there is glucosuria, glucose excretion in urine, they are given in the treatment of diabetes mellitus. Whenever I say a word diabetes mellitus, it always means type 2 diabetes mellitus, which is the common form of diabetes. They also cause sodium excretion that will reduce the pressure on heart and kidney. So they have cardioprotective effect in CHF. They have nephroprotective effect in CKD. So they are approved for CHF, which we have just discussed. What are the logical side effects? If there is glucosuria, they can increase the risk of UTI, urinary tract infection. They can cause both bacterial as well as fungal or candida UTI. And if this UTI spreads to perineal area, they can lead to Fournier's gangrene. With sodium, they also cause calcium excretion. Calcium excretion will weaken the bones. It will lead to osteoporosis. And which drug in diabetes itself increase the risk of diabetic ketoacidosis? The answer is these gliflozin drug, they increase the risk of ketoacidosis. Understood this part? Agreed? So which drug is given in CHF? Gliflozin drugs are given in CHF. Which drug is contraindicated in CHF, which I have just told you? Pioglitazone, because it has antidiuretic effect. Gliflozin drug, they have diuretic effect. Pioglitazone put more pressure on heart. It increases preload. तो pioglitazone हार्ट फेलियर में नहीं देना. ग्लिफ्लोजिन वाले ड्रग फ्लो बढ़ा रहे हैं, हार्ट फेलियर में देना है। एग्री? सो आंसर दिस क्वेश्चन नाउ। Which of the following is the rare but serious side effect of gliflozin वाले drug? Ketoacidosis, urosepsis, UTI, Fournier's gangrene. What about heart failure? Heart failure is not the side effect. It is rather the indication to give gliflozin वाले drug. They are rather given in cases of heart failure. Understood this part? So the answer out here is, what is the answer out here? What is the answer out here? Yes, B is the correct answer. समझ आ गई कहानी? चल आगे बढ़ते हैं. So let's talk about some complications of diabetes. Gastroparesis, diabetic gastroparesis. We give the treatment with one antibiotic, erythromycin. Because erythromycin stimulates which receptor? Motilin receptor, and it increases stomach motility. So tell me in which condition I am giving erythromycin? When the stomach is paralyzed in diabetes. Diabetic diarrhea, we give clonidine. Diabetic retinopathy. Remember, in diabetic retinopathy, there is formation of new blood vessels in retina. There is neovascularization. And these vessels, they can rupture and bleeding can happen. And why this neovascularization happens? Because of one molecule known as VEGF. You know the full form of VEGF? Vascular endothelial growth factor, which can lead to bleeding, and the person will become blind in diabetes. Now, which drug we give for diabetic retinopathy? The drug which are anti-VEGF. The drug which will block vascular endothelial growth factor, and these drugs will inhibit neovascularization. So which drugs are anti-VEGF? Remember a mnemonic: बेवफा रामू की रानी. बेवफा रामू की रानी. बेवफा means bevakizumab. The drug name is bevakizumab. बेवफा. Last year MCQ 6 month back, रामू वर्ड आ गया था भाई. रामू किरुमैब. रामू वर्ड याद रखना है. रानी, रानी भी ज्यूमैब. सो यही नाम याद कर लो, याद हो जाएगा. बेवाकी ज्यूमैब. ब्लड वेसल नहीं बन पाएगी. VEGF को इनहिबिट कर रहा है. VE वर्ड भी आ रहा है. बेवफा रामू की रानी. ओके, सो रिमेंबर लाइक दिस. बेवफा रामू की रानी. वो CI फॉर सर्कुलेशन बेटा एक कंसेप्ट होल्ड ट्रू नहीं करता. ठीक है, रानी भी जुमैब में CI वर्ड आ रहा है, नहीं आ रहा ना. सो दैट इज अ यूजलेस कंसेप्ट. जरूरत से ज्यादा निमोनिक नहीं बनाने चाहिए, कंफ्यूज हो जाओगे. ठीक है, ऐसा नहीं है कुछ भी. हाँ, मैप वर्ड आना चाहिए, ये पता होना चाहिए. ठीक है, ठीक है. चलो आगे बात करते हैं. विच डायबिटीज ड्रग्स आर एंटी ओबेसिटी ड्रग? विच आर अप्रूव्ड एज एंटी ओबेसिटी ड्रग? रिमेंबर स्लिट. निमोनिक क्या? स्लिट. तो बताओ एस से कौन सा पढ़ा था? ओजेम्पिक नाम से चल रहा है. सीमाग्लूटाइड, टाइड वाले ड्रग है. लीराग्लूटाइड. ठीक है बेटा. एंड अ न्यू ड्रग टिरजेपाटाइड. टिरजेपाटाइड. इनमें से मोस्ट इफेक्टिव ड्रग कौन सा है बेटा? सबसे पहले हमने बनाया था लीराग्लूटाइड. 15% वेट लॉस. वेरी गुड. सॉरी, 10% वेट लॉस. 10% वेट लॉस. फिर हमने बनाया सीमाग्लूटाइड. ठीक है, सीमाग्लूटाइड. अप्रोक्सीमेटली 15% वेट लॉस. नाउ वी मेड टिरजेपाटाइड. 20% वेट लॉस. ठीक है, 20% वेट लॉस. डू यू एग्री? अ न्यू ड्रग अंडर ट्रायल, 1-2 साल में अप्रूव हो ही जाएगा. रीटाटूट्राइड. 25% वेट लॉस. 25% वेट लॉस. ठीक है. So right now these are approved drug, and now you know which drug causes maximum weight loss. Maximum weight loss is by tirzepatide now. ठीक है. A potential drug not approved. When it will get approved I will tell you. Just remember कुछ रीटाट्रू कुछ वर्ड आ रहा है. ये भी कोई ड्रग है. The drug for diabetic neuropathy, pregabalin. Which drug is renal safe? We have discussed linagliptin and teneligliptin. Metformin was contraindicated. Do you agree with this part? Very good. Yes. Now let's talk about a patient of type 2 diabetes, microalbuminuria, that means kidney disease is there, CKD is there, with normal renal function test. Which drug is not useful to prevent renal damage protection? The question is, which drug is not nephroprotective? कौन सा ड्रग नेफ्रोप्रोटेक्टिव नहीं है? The answer out here is thiazides. So which drugs are nephroprotective in CKD? Only 3 drugs are nephroprotective in CKD. साफ वर्ड याद कर लो. SGLT inhibitor, gliflozin वाले, Pril and Sartan I have told you, and a new drug comparing with spironolactone, pheneridone. These are the 3 drugs which can protect kidney. Remember this mnemonic, very important for you. Okay. So next question, a 60-year-old post-menopausal female with a history of Colles fracture came with the complaint of lower backache. On evaluation her T score is 2.5. तो कौन सा स्कैन कराया आपने ऑस्टियोपोरोसिस के लिए? डेक्सा स्कैन. Which of the following statements are false about management of a condition? So don't worry. Let's see the drugs for osteoporosis. 2 classes of drug, most important. Drugs for osteoporosis is, first is bisphosphonate. Bisphosphonate inhibit osteoclast. Then we have teriparatide, which stimulate osteoblast. How bisphosphonate inhibit osteoclast? By inhibiting an enzyme, INI-CET MCQ, FPPS enzyme, some farnesyl pyrophosphate synthetase, F word याद कर लेना. All bisphosphonate, they will end with the word dronate. And bisphosphonate are the drug of choice for HOP. Hypercalcemia, osteoporosis, and Paget's disease of bone, they are the drug of choice. Side effect of bisphosphonate, ROS. They are contraindicated in renal failure. They can cause osteonecrosis or damage of bone of mandible. They can cause subtrochanteric femur fracture if bisphosphonates are used for more than 10 years. And they can damage esophagus, esophagitis. Then we have teriparatide. Para word is coming. It is a parathyroid hormone. And tide word is coming. It's a peptide. Peptides are only given by injection. And it is always given by intermittent injection like this. When we give intermittent injection, parathyroid hormone stimulate osteoblast. It stimulate osteoblast. New bone formation will happen. Remember, the only use of teriparatide is bisphosphonate resistant cases of osteoporosis. But in hypercalcemia and Paget's disease, it is absolutely contraindicated. Why? Because it can lead to tumor of osteoblast. Tumor of osteoblast is known as osteosarcoma, and osteosarcoma risk is already very high in cases of Paget's disease. And it is absolutely contraindicated in cases of hypercalcemia where bisphosphonate is used. Because it causes osteosarcoma, this teriparatide, it can be given maximum up to how many years? T for teriparatide, T for 2 years. Beyond 2 years, it increases the risk of osteosarcoma. Word समझ आया? Good. Other drugs for osteoporosis. But before that, let's see this question. Let's see this question. So, teriparatide is given as a continuous injection. False. It is given as an intermittent injection. Continuous injection दोगे तो osteoclast stimulate हो जाएंगे. ठीक है? False. Bisphosphonates are not given for more than 10 years. True. They can increase the risk of subtrochanteric femur fracture. Teriparatide is not given for more than 2 years. Osteosarcoma risk. And denosumab, mab word aa raha hai, preferred in kidney disease. And I have told you, all monoclonal antibodies are safe in renal disease patient, because monoclonal antibodies are proteins. Proteins are not excreted in urine. So let's talk about certain monoclonal antibodies in osteoporosis. The first is den मतलब डेंसिटी इंक्रीज हो जाएगी किसकी, बोन की. कौन सी बीमारी में देंगे, ओएस. ओएस का मतलब ऑस्टियोपोरोसिस में देंगे. सो द फर्स्ट वन इज मोस्ट इंपॉर्टेंट, denosumab. How it acts? It inhibit rank ligand, and that is why it inhibit osteoclast. It is renal safe drug. Romosozumab, it inhibits sclerostin. Because of this reason, it stimulates osteoblast. A new drug, burosumab, it inhibits fibroblast growth factor 23, which will reduce phosphate excretion. समझ आई बात. Fibroblast growth factor causes phosphate loss in urine. So it inhibits phosphate excretion in urine. So fibroblast growth factor, it is given for X-linked hypophosphatemic rickets. Understood this part? Let's move ahead. All of the following drugs are used in thyroid storm, excessive hyperthyroidism, hyperthyroid emergency, except which one? Except which one? Can we say in thyroid storm, what will happen to body temperature? Can we say body temperature will be increased in hyperthyroidism? Garam ho jata hai aadmi. Aspirin is never given because aspirin itself causes hyperthermia. So which drug is not given? Aspirin is not given. Agreed? कोई बात नहीं, सब बच्चों को पढ़ने का पूरा मिलना चाहिए. जहां मर्जी पढ़ो यार, नॉलेज जहां से मिले सब लो. यहाँ से पढ़ो, वहां से पढ़ो, सबसे बड़ा करो. So let's talk about thyroid storm. Which drug to be given? Don't worry. So let's talk about first this one. Which drug inhibit T4 to T3 conversion? Remember, T3 is the active form and the enzyme which convert T4 to T3 is 5-deiodinase enzyme. Make sense? 5-deiodinase enzyme, and these drugs are given in the treatment of thyroid storm. They are given in the treatment of thyroid storm. Check. Let's write a mnemonic. The drugs which are used in thyroid storm is PPID. PPID. The P stands for propranolol. So the MCQ is, which beta blocker inhibit T4 to T3 conversion? Propranolol. Then PTU, which I will tell you, propyl thiouracil. Iodides like Lugol's iodine and potassium iodide, and dexamethasone. Now remember, the first drug of choice for the treatment of thyroid storm is, first drug of choice for the treatment of thyroid storm is propranolol, and then we add other drugs subsequently. So first we give propranolol, then we give PTU, then we add other drugs for the treatment of thyroid storm. Now hyperthyroidism in first trimester of pregnancy, PTU. Second and third, we all know carbimazole and methimazole. Why carbimazole and methimazole are contraindicated in first trimester? They can cause aplasia cutis. Now iodine molecule can cause a side effect of parotitis, inflammation of salivary gland, which is also known as sialadenitis. Now radioactive iodine 131 is the only iodine isotope which can destroy thyroid gland. Other iodine isotopes are given for thyroid scan, and iodine 131 destroy thyroid gland by beta rays. Half-life is 8 days. Use is inoperable cases of hyperthyroidism. When you cannot do surgery, give iodine molecule. Rest you will learn in surgery. Okay, समझ आ रही है कहानी? ऊपर से तो नहीं जा रहा? ऊपर से तो नहीं जा रहा? Good. चलो, which enzyme do finasteride and dutasteride inhibit in order to treat male pattern baldness? The answer of this question is 5-alpha reductase enzyme. Now 5-alpha reductase converts testosterone into dihydrotestosterone, which is the active form, and this is inhibited by finasteride and dutasteride. They inhibit the conversion of testosterone into dihydrotestosterone. Now, where it is used, finasteride and dutasteride, it is given along with tamsulosin and silodosin. बताओ बेटा कौन सी बीमारी में osin word is coming? They are given as a combination with tamsulosin and silodosin for the treatment of BPH. They are also given along with minoxidil cream, minoxidil 2 to 5% cream in the treatment of male baldness or androgenic alopecia. So here we give finasteride and dutasteride. It is given along with tamsulosin and silodosin for BPH, along with minoxidil 2 to 5% cream for male baldness. Now, which drug is an aromatase inhibitor? Don't worry, I will be telling you later on. Letrozole. Now, aromatase enzyme, the function of aromatase enzyme is to convert testosterone into estrogen, and letrozole inhibits the conversion of testosterone into estrogen. So, where letrozole is used, letrozole is given in the treatment of breast cancer because estrogen causes breast cancer, and letrozole is also used as an ovulation inducer in cases of PCOD. In cases of PCOD. Now, which drug inhibit 11 beta hydroxylase enzyme? 11 beta hydroxylase inhibitor is metotane mitirapone. Okay, and these drugs are given in the treatment of Cushing disease because this enzyme is required for glucocorticoid like glucocorticoid synthesis. So it is also known as medical drug. दे रहे हो, adrenal gland काम नहीं करेगा, medical adrenalectomy. So these drugs, they decrease corticosteroid synthesis. 11 beta hydroxylase corticosteroid synthesis को inhibit करते हैं metotane and mitirapone. Phosphodiesterase 5 inhibitor, we have already discussed. Sildenafil and tadalafil, they are phosphodiesterase 5 inhibitor. Now, which of the following condition non-pulsatile dosing of leuprolide is not used? ठीक है, नॉन पल्सेटाइल का मतलब हम कौन सा दे रहे हैं, कंटिन्यूस दे रहे हैं. ठीक है. Now remember what is leuprolide? Leuprolide is gonadotrophin releasing hormone. And remember, if you give gonadotrophin releasing hormone in a pulsatile manner, if you give in pulsatile manner, they increase FSH and LH. And if you give them in continuous manner, they decrease FSH and LH production from pituitary. Apart from leuprolide, all other drugs, they will end with the word relin. तो एक leuprolide ही आपको पढ़ना है. How can remember leuprolide? Luteinizing hormone, LEU. Luteinizing hormone कम ज्यादा कौन सा ड्रग करता है? Leuprolide. So pulsatile injection, it will increase FSH and LH, increase testosterone, increase estrogen. So it is given for the treatment of azoospermia, male infertility, anovulation, female infertility, and they are the drug of choice for delayed puberty. When you want to reduce testosterone and estrogen, in cases of precocious puberty, they are given continuously. You want to decrease testosterone in prostate cancer, and you want to reduce estrogen in breast cancer and endometriosis. But the problem with continuous injection is when you start them continuously, initially FSH and LH will increase, and after 7 days FSH and LH will fall. So these drugs can cause initial increase in FSH and LH, which will flare up things, which will increase the things in prostate cancer. To overcome this problem, to avoid this initial flare up, we made a drug, gonadotrophin releasing antagonist, and these drugs, they will end with the word relics. ऊपर वाले किससे एंड कर रहे हैं? रेलिन वर्ड से एंड कर रहे हैं. द ग्रेट एडवांटेज इज रेलिक्स वाले ड्रग का क्या ग्रेट एडवांटेज है? दे विल ओनली ब्लॉक द रिसेप्टर, नो इनिशियल इंक्रीज इन FSH and LH like cetorelix, ganirelix, diagarelix, aba given for prostate cancer. E wala drug elagolix given for endometriosis. I hope you have understood this concept. Now tell me the answer of this question. So continuous वाला कहां यूज नहीं करोगे? कंटिन्यूस वाला कहां यूज नॉट यूज? बताओ। कंटिन्यूस वाला टेस्टोस्टेरोन और ईस्ट्रोजन कम करेगा। यस, इन प्रोस्टेट कैंसर वी वांट टू रिड्यूस टेस्टोस्टेरोन, वी वांट टू रिड्यूस टेस्टोस्टेरोन एंड ईस्ट्रोजन इन मेल्स एंड बॉयज in precocious puberty. We want to reduce estrogen in cases of endometriosis. But no, sir, in azoospermia, we want to rather increase testosterone level. So here you will give intermittent or pulsatile injection. Understood? It was a very tricky question asked last year. So this, now next very commonly asked question: combined OCP which contain estrogen and progesterone increase the risk of following cancer. So first, cancer risk with OCP reduce cancer risk CEO. They reduce the risk of colorectal cancer. They reduce the risk of endometrial cancer, and they reduce the risk of, very important, ovarian cancer. While OCP, they increase the risk of cervical cancer, HCC, hepatocellular carcinoma, which you can call it as hepatoma also, and very mild increase in the risk of breast cancer is also seen. Okay. Okay. So these cancer risk is increased. Tell me the answer now. What is the answer? Which cancer risk is increased? Increased. Yes, the answer of this question was, last year question was breast cancer. Was breast cancer. Understood this part? So now, last question, then I'll give you a small break also, and then we will finish very rapidly. A G2P1 delivered a preterm baby at 36 weeks. The baby was admitted to NICU. Unfortunately, baby died. What is the drug which is used to reduce pain and engorgement in lactating mother? You know that prolactin causes milk production, and the drug that will reduce prolactin level is dopamine. Dopamine acts from hypothalamus, goes to pituitary and suppresses prolactin production. So the drug is dopamine D2 receptor agonist. They reduce prolactin production. So the drug we have out here is cabergoline. So cabergoline, remember, it is given as a drug of choice for prolactinoma also. But if the question comes prolactinoma in pregnancy, then the drug of choice is bromocriptine. Then the drug of choice is bromocriptine. And these drugs are also given to suppress milk production. After neonatal death, we give these drugs for milk production also. Octreotide acromegaly के लिए देंगे when there is growth hormone excess. Somatropin is growth hormone. It is given for dwarfism. It is given in the treatment of opposite disease, dwarfism. Octreotide reduces growth hormone production, and it is given in the treatment of acromegaly. It is a somatostatin hormone. Agreed? So this is about your yes. So this is about your endocrine. Let's take a very small break. And now we will start our last part also, and we will finish up. So again, we will have a 10 minutes break. I think you will be comfortable in 10 minutes break. Okay, 10 minutes break will be fine. Good. So we will start at 8:55 p.m. will be fine for us. Okay, beta? Have a little bit coffee. It's a long session. I hope you are enjoying. You're able to understand each and every point I'm telling you. Okay? You're able to understand? Great. So I hope we can start now. Let's now start with autocoids, local hormones. So which drug is not given to control PPH, postpartum hemorrhage? The answer of this question is dinoprostone. Remember, dinoprostone is PGE2 and it is not given for controlling PPH. So let's talk about all prostaglandins. The first type of prostaglandin is PGE1. Prostaglandin E1, the drug name is misoprostol. Now, misoprostol is given for NSAID-induced peptic ulcer. But remember, the drug of choice for any peptic ulcer is PPI, proton pump inhibitor. Okay? It is also given for medical termination of pregnancy up to 63 days, first trimester. And it is given to control PPH according to the latest guideline we can give misoprostol. L-prostadil is given to maintain patency of ductus arteriosus. So L-prostadil, it is given to open ductus arteriosus. It is prostaglandin E1. But which drug is given to close patent ductus arteriosus? We give non-steroidal anti-inflammatory drug NSAIDs like ibuprofen and indomethacin. They are given for the closure of patent ductus arteriosus. Now, the most common side effect of misoprostol is diarrhea because it increases chloride secretion. We used this side effect and made a separate drug, lubiprostone. Lubiprostone is a chloride secretor. It causes diarrhea. That is why it is given in the treatment of constipation seen in irritable bowel syndrome. Then we have prostaglandin E2. E2 is dinoprostone. Though E2, it is available as a vaginal cream. Now, don't you think if it is available as vaginal cream, it will only act on lower part of uterus? And in lower part of uterus, it will be causing cervical dilatation, which is cervical ripening. Now remember, it does not act on upper part of uterus. Any drug which acts on upper part of the uterus will contract this upper part of uterus. And if we contract upper part of uterus, muscles will contract. They are given to control PPH. And the drug which can contract uterus are given by injection. इंजेक्शन से दोगे तो ऊपर भी काम करेगा ब्लड से आके. So that is prostaglandin F2 alpha, dinoprost and carboprost. So remember, don't get confused between dinoprost and carboprost. They are given to control PPH. But remember, carboprost like drug, they are contraindicated in asthma. Other drugs we have already discussed. Another prostaglandin F2 alpha, latanoprost, bimatoprost, eye drops, drug of choice for glaucoma. PGI2, TI, they are given for pulmonary artery hypertension, which we have discussed. Now remember, prostaglandin I2, it is also known as prostacyclin. It causes vasodilation and it has antiplatelet action, MCQ. Opposite to it, we have thromboxane A2, which is vasoconstriction and causes platelet aggregation. और प्लेटलेट का थ्रोम्बस बनेगा तो thromboxane A2. Don't you think they both are opposite of each other? And any molecule which is opposite of each other is known as physiological antagonist. So PGI2 and thromboxane A2, they are physiological antagonists of each other because they produce opposite action. Now, darbepoetin, it is useful in which type of anemia? Now, can you tell me any other drug which is ending with the word darbepoetin? Similar to darbepoetin, we have erythropoietin, we have epoetin, and erythropoietin, you know, it is produced from kidney and produces RBC formation. So they are given for the treatment of anemia due to CKD. Anemia due to CKD and anemia due to anti-cancer drug chemotherapy. Apart from this, they are not used in any other type of anemia. Only two type of anemia we give, erythropoietin and darbepoietin. Only two anemia, no other anemia. So are they given in aplastic anemia? No. यहाँ पे तो बोन मैरो के सेल्स डिवाइड ही नहीं करते. आयरन डेफिशिएंसी और न्यूट्रिशनल एनीमिया, नो. Myelofibrosis, bone marrow के cells in here. So they are only given for only and only two types of anemia. And they are given by which route? They are injectable drug. Now we have made oral drugs. Anemia due to CKD. Now we have made oral drugs, and these drugs they end with the word Dosage. So these drugs, remember, they increase the level of endogenous erythropoietin. They inhibit the degradation of erythropoietin. They inhibit the degradation of erythropoietin. So they are the new oral drugs for anemia due to CKD. Dosage word will come. Now, a patient of AML, acute myeloid leukemia, was started on anti-cancer drug busulfan. He developed damage of cells will lead to formation of uric acid. So uric acid level is increased, and which started gout-like syndrome and joint pain started. And this syndrome is known as tumor lysis syndrome. So which drug can oxidize uric acid into allantoin? This question was last year question. तो इनमें से कौन सा ड्रग ऑक्सीडाइज कर देगा? द आंसर इज पेग्लोटिकेस. पेग्लोटिकेस. Now remember, in the treatment of acute gout, acute attack of gout, the first drug we give is NSAIDs because they have anti-inflammatory action. And in NSAID resistant cases, we give a drug colchicine. Question come, how colchicine has anti-inflammatory action? Remember, colchicine is a microtubule inhibitor, and microtubule is required for movement of WBC. So it inhibits migration of WBC. If WBC will not move, it will inhibit inflammation in joint. So these drugs are given for acute attack of gout. But in the long-term treatment of gout, in the long-term treatment of chronic gout, we reduce blood uric acid level. How uric acid is produced? Uric acid is produced from purine. The name of the purine is hypoxanthine, goes to liver, and with the help of xanthine oxidase, it makes uric acid, and then uric acid is excreted out in urine. So the first drug that will reduce the production of uric acid is xanthine oxidase inhibitor. So allopurinol, oxypurinol, purine word is coming, febuxostat, exo word is coming, it inhibit xanthine oxidase enzyme. Exo word is coming. So they are the drug of choice to decrease uric acid level. Okay, and uric acid level increases in cases of CKD, kidney disease, and tumor lysis syndrome. So tumor lysis syndrome occurs when we give anti-cancer drug, uric acid is produced. Now the next class of drug we have is uric acid oxidase enzyme. So they oxidize uric acid into a molecule known as allantoin. Allantoin is harmless. It cannot cause gout. So they are enzymes. Enzymes will end with the word ACE. Pegloticase, mammalian enzyme. Rusburicase, bird's enzyme. So they are given in resistant cases of gout due to CKD, due to tumor lysis syndrome. And lastly, we have a drug that will increase uric acid excretion into the urine. So these drugs are known as uricose uric agent. They inhibit one transporter known as OATP transporter, which causes uric acid excretion. So the drug is probenecid, very famous drug. Now other drug, very easy. Sulfenpyrazone, benzbromarone, lesinurad, uric acid is decreased, desinurad. So they are simply add-on drugs in chronic gout. Understood this part? Now elderly women on treatment with migraine presented with chest pain. She has previous history of asthma. Which drug is given for prevention of migraine headache? Remember, the drug of choice for prevention of migraine is propranolol. Propranolol is a drug of choice for prevention. But remember, propranolol is a beta blocker. Beta blocker are contraindicated in asthma. Here the patient is having asthma also. So hence the drug of choice comes out to be topiramate. Okay. What about sumatriptan? Sumatriptan is only given in acute attack of migraine. It is not given for prevention of migraine. Understood this part? So answer out here, last year INI-CET question is topiramate. So let's see the treatment of migraine. So first let's talk about drugs for acute attack of migraine. The drugs which are acute attack of migraine is triptans. And how triptans they work? Triptans they act on 5-HT1B1D agonist. They stimulate 5-HT1B1D agonist. Agreed? Like sumatriptan, rizatriptan, ele and frova. So rizatriptan you will write rapid. Rapid means it is the fastest acting drug. Triptan is the longest acting drug, and the most effective drug we have for triptan is E for L-triptan. One more drug which we can give is ergotamine. Now the problem with these drugs is that all these drugs, their side effect is they produce vasoconstriction. They can lead to vasoconstriction. Can we say blood pressure will increase? So can we say coronary artery will constrict also? So triptans are contraindicated in a patient of hypertension, angina and MI. And sometimes this ergot, they can cause vasoconstriction in fingers. Vasoconstriction in fingers will lead to dry gangrene. And this dry gangrene, it is known as ergotism. It is known as ergotism. Understood this part? Now to overcome this problem, we made a new drug. This new drug is known as lasmiditan. Lasmiditan is 5-HT1F agonist. The great advantage of lasmiditan is no risk of vasoconstriction. That is why lasmiditan is safe in a patient of heart disease, hypertension, angina and MI. Heart disease, which drug is safe? Lasmiditan. Now let's talk about drugs for prevention of migraine or prophylaxis of migraine. Remember a mnemonic BACT. So overall drug of choice for prophylaxis of migraine is beta blocker propranolol. But we know propranolol is contraindicated in cases of asthma. In asthma, we can give the safe option. Other drugs are safe in cases of asthma. So we can give anti-epileptic drug, valproate. Most commonly asked MCQ is topiramate. And the third anti-epileptic drug is gabapentin. We can give a calcium channel blocker, flunarizine. We can give tricyclic antidepressant, amitriptyline, nortriptyline. Now we have new drugs for migraine. They are known as CGRP2 inhibitor. Very important for you. CGRP stands for calcitonin gene related peptide. So this is an inflammatory molecule which causes migraine. So we have new drugs which are given for acute attack of migraine, and these drugs are oral drugs. They are oral drugs and they are given for migraine. They will end with the word gepant. They will block CGRP2 receptor. And try to remember the name of the drug, rimegepant. So tell me the root of rimegepant, oral drug given for acute migraine, and the great advantage is no risk of vasoconstriction. So it is safe in heart disease patient. Unlike triptans, we have made rimegepant. Now we have a drug for prevention of migraine, erinumab. Erinumab is a monoclonal antibody that blocks CGRP2. It blocks CGRP2, so it can be given by injection. And let's answer this question of last year INI-CET. Which of the following statement regarding rimegepant is true? ठीक है. Is it given subcutaneously? No. Gepants are given orally. Makes sense? It causes vasoconstriction. No risk of vasoconstriction. Makes sense? It is CGRP1 receptor agonist? False. It is CGRP2 receptor, not agonist. It is antagonist. It blocks CGRP2 receptor. It is given for the treatment of acute attack of episodic migraine. Yes, this is the true statement. So this was the last year question on Remegipant in INI-CET. समझ आ गई कहानी बेटा? माइग्रेन पे बहुत सवाल आते हैं एंड आई होप आप गलत नहीं करोगे. नाउ लेट्स टॉक अबाउट अ पेशेंट प्रेजेंटेड विद गैस्ट्रोइसोफेजियल रिफ्लक्स डिजीज. All drugs help in contraction of LES and increase gastric emptyings. So answer is except. इसमें आगे लिख देते हैं except. Except. What is the answer of this question? The answer of this question is we give metoclopramide, domperidone, mozapride. All these drugs are prokinetic drug. Prokinetic drug, they can cause contraction of LES. The answer of this question was ondansetron. Ondansetron is not given in cases of GERD. So let's talk about what do you mean by prokinetic drug. Prokinetic drug means pro means they increase. Kinetic means GIT contraction. They increase GIT contraction or motility. So where they are used? If they will contract lower esophageal sphincter, they are given in the treatment of GERD. If they contract stomach, they are given in the treatment of gastroparesis. And if they contract intestine, they are given in the treatment of constipation. They are given in the treatment of constipation. Remember, serotonin increases contraction. So we give serotonin 5-HT4 receptor agonist. Dopamine reduces contraction. So we block dopamine receptor, dopamine antagonist. And lastly, acetylcholine also increases contraction. So we increase acetylcholine level by giving anticholinesterase drug. So first is 5-HT4 agonist. So these drugs, they will end with the word pride. Like Cisapride, Mozapride, Renzapride, Etopride. Last year MCQ, Prucalopride. So tell me, Prucalopride acts from which receptor? First MCQ. Is Prucalopride given in constipation? Yes, it is given. Now one name is different, Tigacerod, but don't worry. Both Cisapride and Tigacerod got banned because they cause QT prolongation. Then we have dopamine receptor antagonist, domperidone. Lastly, we have neostigmine. Now, which antibiotic increases GIT motility? Beta, I have already told you. Erythromycin, by stimulating which receptor on stomach? Motilin receptors on stomach. Okay. That is why the side effect of erythromycin is because of contraction of muscle, erythromycin can cause pyloric stenosis. It can cause pyloric stenosis. So we don't give erythromycin in cases of neonate because it can lead to hypertrophic pyloric stenosis. Now we have a drug which have all three action. All three action is of a drug metoclopramide. So metoclopramide is serotonin agonist, dopamine blocker, and it increases acetylcholine level. Now let's compare two drugs among themselves which block dopamine receptor. The first drug is domperidone and multiple action is metoclopramide. Now the difference is domperidone does not cross blood-brain barrier. So how we can remember? It do not cross. Domperidone do not cross blood-brain barrier, while metoclopramide cross blood-brain barrier. And which drug do you think blocks dopamine receptor inside the brain and can cause Parkinson disease? Which drug now do you think will cause Parkinson disease and blocking dopamine receptor will increase prolactin level? Yes, the answer is metoclopramide. It is not seen with domperidone. Parkinson disease due to drug is known as EPS, extrapyramidal symptom, and the muscles becomes rigid. So muscles becomes rigid. So it is also known as, the third name is known as muscle dystonia. So you can see abnormal posture. Abnormal posture is seen with metoclopramide. And how to treat this Parkinson disease? This is drug-induced Parkinsonism. We give anticholinergic drug like benzhexol. कौन सा drug दोगे? Benzhexol दोगे for the treatment of drug-induced Parkinson disease. Understood this part? Now let's move ahead. Which of the following, last year question, statement regarding dronabinol is not true? So let me tell you what is this dronabinol. So first let's talk about one topic, important topic. Chemotherapy induced nausea and vomiting. Chemotherapy means when you give anti-cancer drug, it can lead to nausea and vomiting, and the anti-cancer drug which causes maximum nausea and vomiting is cisplatin. Cisplatin causes maximum nausea and vomiting. Now to treat this nausea and vomiting, the first drug of choice is cetron, like ondansetron, granisetron, palanosetron. Remember cetron, they block serotonin 5-HT3 receptor. But remember, they are given in early phase. Early phase of vomiting means they are effective up to how many hours? 24 hours. If vomiting continues beyond 24 hours, we call it as delayed phase. Delayed phase means vomiting is continued beyond 24 hours. Now you will start the drug pitants like aprepitant, fosaprepitant, rolapitant, netipitant. Pitant what are they? Pitants, they block which receptor? NK1 receptor. NK1 stands for neurokinin 1 receptor. They block this neurokinin 1 receptor. If it is still refractory, we add corticosteroid. If it is still refractory, we give cannabinoid agonist. Remember, they are not blocker, they are agonist. And they stimulate which receptor of cannabinoid? CB1 receptor. How to identify these drugs? These drugs will have NABI word in them. Cannabinoid also have NABI word in them, like dronabinol, nabilon. So the first use of dronabinol is chemotherapy induced nausea and vomiting in refractory cases. Now you know that cannabinoid like bhang, charas, ganja, they increase appetite. So dronabinol and nabilon, cabinon, they stimulate appetite. Now beta, can you tell me, if you will eat a lot, can we say it will increase weight of a person? They will increase weight of a person. That is why these drugs are also given for the treatment of weight loss. Weight loss can be seen in cancer patient, and weight loss can be seen in AIDS patient in late stages also. So in late stages of cancer and AIDS, we give cannabinoid to increase appetite to restore the weight. Understood this part? Let's answer this question. Dronabinol. So it is cannabinoid 1 receptor agonist. Absolutely true statement. It is given for chronic pain management. ऐसा तो कुछ नहीं है. It is given for AIDS related weight loss. True. It is given to treat vomiting due to cisplatin. True. So what is the false statement beta here? The false statement of last year MCQ is it is given for pain management. Pain से लेना देना कुछ नहीं है इसका. Understood this part? Now let's move forward. Which of the following statement regarding lafutidine is false? Remember cimetidine, ranitidine. Don't you think all these drugs are ending with the word tidine? And any drug which ends with the word tidine is histamine H2 receptor blocker. And H2 receptor decreases HCl production. So they are given for the treatment of peptic ulcer. ठीक है? Okay. But why this lafutidine was asked? Because this lafutidine has some additional action. Lafutidine, it also increases nitric oxide production. And it also increases somatostatin levels. It also increases somatostatin level. Increase in nitric oxide increases mucosal blood flow, which will heal the ulcer faster. And somatostatin is a negative hormone which decreases gastrin hormone production, and gastrin will further reduce HCl production. So it's a new drug with other mechanism of action. So keeping this thing in mind, it increases mucosal blood flow, true. It increases somatostatin level, true. It decreases, no sir, it increases nitric oxide level, and it is an H2 blocker, histamine 2 receptor blocker, true. So the false statement was C. False statement was C. So remember this drug, important for you. Now, safest painkiller in a child with renal failure, renal stone, always, any time, safe word आ जाए, always the answer is paracetamol. सबसे सेफ कौन सा ड्रग होता है हमेशा? एसिटा वर्ड आ रहा है, एसिटा वर्ड आ रहा है, एसिटामिनोफेन इज अनदर नेम ऑफ पैरासिटामोल. So paracetamol, also known as acetaminophen, safest drug in renal failure, safest drug in children, safest drug in pregnancy, safest drug in peptic ulcer. Always the safest drug always is paracetamol. Now remember, when we give the dose of paracetamol by more than 4 grams per day, it gets converted into active form NAPQI. And NAPQI causes liver damage. It causes liver damage. It is the toxic form of paracetamol. So how it causes liver damage? It damages the cells around central vein, but the cells around portal triad in liver are spared. So we call it as centrilobular necrosis and periportal sparing. So only one zone around central vein, the cells will get died. This is known as zonal necrosis. And this increase in the risk of paracetamol hepatotoxicity is seen with alcohol, isoniazid and smoking. Try to remember, दारू और सुट्टे से पैरासीटामोल की hepatotoxicity का रिस्क बढ़ता है. The antidote of paracetamol toxicity is N-acetylcysteine, because N-acetylcysteine increases the levels of glutathione. It increases the level of glutathione in liver, and this glutathione removes NAPQI. It removes the toxic form of paracetamol, that is NAPQI. Understood this part? Another MCQ. Now let's talk about match the following adverse effect of NSAIDs. Now rofecoxib and valdecoxib, any drug which ends with the word coxib, is a selective COX-2 inhibitor. Sir, why we made this drug? Because these drugs have a great advantage. They have least risk of causing peptic ulcer. So any drug which ends with the word coxib has least risk of causing peptic ulcer, but these drugs, they got banned. Why they got banned? Because they were causing MI and stroke. So that is why these drugs, they got banned. Okay. Then we have nimesulide. Nimesulide also got banned. It has a risk of causing Stevens-Johnson syndrome, hepatotoxicity. Now, aspirin causes race syndrome. Because of the race syndrome, there is liver damage. So there is liver failure in cases of race syndrome. And this race syndrome risk is increased in cases of children. That is why aspirin is contraindicated in age group less than 18 years of age, except in two conditions. Except in cases of, we still give aspirin in children in cases of Kawasaki disease, and in cases of rheumatic fever, still we give aspirin in children. Otherwise, we don't give aspirin in children less than 18 years of age because of the risk of race syndrome. Second point, aspirin can cause Samter's triad. Samter's triad means aspirin can cause asthma, and it can lead to one polyp in nose known as ethmoidal polyps in nose. So this triad of aspirin is known as Samter's triad. Lastly, we have is indomethacin. Yes, indomethacin can cause seizure and sedation. It can cause seizure and sedation. Okay, seizures and sedation. ठीक है? Now, which Drugs are approved for both rheumatoid arthritis and inflammatory bowel disease, that is ulcerative colitis. Remember three common drugs for RA plus IBD. RA plus IBD, three common drugs are: first is sulfasalazine, second is infliximab, and the third drug is the most important, tofacitinib. Tofacitinib. So these three drugs are the common drugs we have, and the drug which is not given is not लिखा है except लिखा है indomethacin. Okay, indomethacin. Good. Now let's talk about the drugs for rheumatoid arthritis. These drugs are known as DMARD. DMARD stands for disease modifying anti-rheumatic drug. We have conventional drug. Conventional means they are old drugs and they are given orally. So the mnemonic is Malika Sherawat Pagal C. Among them, the first drug we have is methotrexate. Methotrexate is the overall drug of choice for RA. And how methotrexate works? Methotrexate inhibits one enzyme, DHFR enzyme, that is dihydrofolate reductase enzyme. It inhibits the conversion of folic acid into active form, and if there is methotrexate poisoning, the antidote is folinic acid. Fine. Then we have sulfasalazine, penicillamine, gold, leflunomide, chloroquine, and hydroxychloroquine. Leflunomide, how it works? It inhibits some enzyme, DHOD enzyme, dihydroorotate dehydrogenase enzyme. Now, what is the most effective drug for RA? That is methotrexate. But methotrexate is absolutely contraindicated in pregnancy. Can you tell me the reason why? It's an antifolate drug. It can lead to neural tube defects. So what is the safest DMARD in pregnancy? The safest DMARD in pregnancy is chloroquine, or its big brother, hydroxychloroquine. So they are the safest DMARD in pregnancy. Recent MCQ. Now we have new drugs, biological DMARD. So this is the complete list I have given you. You have to remember for INI-CET. So the drug which block TNF alpha, ICH, that is infliximab, certolizumab, adalimumab, golimumab, etanercept. Try to remember infliximab. Now, infliximab, where it is given? Infliximab is given in methotrexate resistant cases of RA, rheumatoid arthritis, ulcerative colitis and Crohn's disease, that is IBD. It is also given for psoriatic arthritis, methotrexate is given there, and ankylosing spondylitis. Now the big problem with giving infliximab is infliximab reduces TNF alpha, which leads to reactivation of latent TB. So before giving infliximab, you have to do which test? You have to do Montu test to rule out latent TB. Other drugs we have to remember: interleukin 6 blocker, tocilizumab, sarilumab, CD20 blocker, rituximab, interleukin 1 blocker, anakinra. Abatacept is not asked. Remember JAK inhibitor, JAK stand for Janus kinase enzyme, tofacitinib. And you will fill this thing yourself. Now you know the common drugs for both RA and IBD. You know the common drug for RA and IBD, T and S for sulfasalazine. Now let's talk about CNS. Now a 42-year-old alcoholic with raised ALT, AST and GGT level, that means the patient is having liver disease, patient is alcoholic. Which drug is given to control delirium tremens? So in simple word, the answer out here is lorazepam. ठीक है? Lorazepam. Agreed? Flumazenil, it is the antidote of benzodiazepine poisoning we have discussed. Fomepizole, it is an antidote of toxic alcohol poisoning we have already discussed. Methanol and ethylene glycol poisoning, they are neurotoxic alcohol. Agreed? Now understand one point. Fomepizole, O word is coming, alcohol. Disulfiram D word is coming, aldehyde. So disulfiram inhibit aldehyde dehydrogenase enzyme and fomepizole inhibit alcohol dehydrogenase enzyme. It inhibit alcohol dehydrogenase enzyme. Understood this part? Now, let's talk about alcohol or ethanol addiction. Just imagine a chronic alcoholic came to you in emergency. That emergency symptom is known as delirium tremens excitable. We give IV diazepam. We will sedate a person to calm down. After you have calmed down, you will start a maintenance phase to prevent withdrawal. To prevent withdrawal, we give an oral diazepam analog, that is oral chlordiazepoxide. Understood this part? They both class of drugs are benzodiazepine. But the problem with these two drugs are these two drugs should be avoided in a patient of liver disease. In liver disease, which benzodiazepines are safe? The benzodiazepines which are safe in liver disease is either lorazepam or oxazepam. So they are given in places of these two drugs if the patient is having liver disease. ठीक है? Now, after you have prevent withdrawal, after you have stopped giving this chlordiazepoxide, the person should not start taking or drinking again. We have to prevent relapse. Relapse means person should not start drinking again. This is known as abstinence therapy. Abstinence means the person will remain away from alcohol. So either you can reduce craving for alcohol or you can induce fear in that patient. To reduce craving for alcohol, you give combination of naltrexone with a camprosate. You give naltrexone a camprosate. Naltrexone block opioid receptor and a camprosate block NMDA receptor on which alcohol acts. But to induce fear, we give a drug disulfiram because disulfiram inhibit aldehyde dehydrogenase. If the person will consume alcohol, acetaldehyde will accumulate and acetaldehyde will produce harmful effect like nausea, vomiting, pain, hypotension, etc. That is why the person will have fear of drinking alcohol. Understood this part? Now, which of the following opioids increases serotonin level? The answer of this question was tramadol. Don't worry, I'll explain you. So tramadol and tapentadol, it acts on opioid receptor. Opioid receptor, that is mu receptor. It stimulates mu receptor, but it also has property of SNRI, that is serotonin norepinephrine reuptake inhibitor. They increase the level of serotonin and norepinephrine. Then we have methadone. Methadone is also mu agonist, but it also have NMDA antagonist action. It has NMDA antagonist action. Because of this reason, this methadone, remember, it has a side effect of QT prolongation on heart, which is a separate MCQ asked last year. Pethidine is also mu agonist and pethidine has anticholinergic action, just like atropine. Now, pethidine is the drug of choice among opioid in pregnancy. It is also the drug of choice for post-anesthetic shivering. It is also the drug of choice for post-anesthetic shivering. Sufentanil, overall most potent opioid, most powerful opioid कौन सा है? Sufentanil. And it is also maximum protein bound opioid. Remifentanil is the shortest opioid. Because when we give remifentanil, it comes into the plasma, and in plasma there is an enzyme known as esterase enzyme. This esterase enzyme degrades it. That is why this remifentanil is given with propofol. What is propofol? Propofol is a general anesthetic and this is given for day care surgeries. It is given for daycare surgery. In daycare surgery or minor procedure, when you same day discharge your patient, like hernia, hydrocele, small surgery, the general anesthetic you give is propofol, and the painkiller means analgesic you give is remifentanil. Now, a young man with a known with heroin, which is a congener of morphine addiction, brought to emergency in unconscious state. On examination, morphine causes decrease in bowel sound, absolutely fine. Respiratory depression, which is known as bradypnea, and pinpoint pupil because of meiosis. These are the features of opioid poisoning. What is the treatment of choice? The treatment of choice or antidote, I think we have already discussed, is IV naloxone. So I just told you ethanol addiction. Let me teach you now about opioid de-addiction. So if a patient comes to you with acute morphine and opioid poisoning, the antidote is intravenous naloxone. Intravenous naloxone. Any drug which starts with the word nal blocks opioid receptor. It blocks opioid receptor. After you have stabilized the patient, again you will start maintenance phase to prevent withdrawal. To prevent withdrawal, either you can give opioids. So three opioids are approved, that is BMT, bone marrow transplant, where B stands for buprenorphine, M stands for methadone, and the third drug which has been approved is tramadol. But to avoid their addiction, we have approved two non-opioid also, clonidine and lofexidine, which stimulates alpha-2 receptor and reduce craving or prevent withdrawal for opioid. So slowly you will taper them off. Now the person should not start taking again. Again, we have to do prevent relapse. We have to do abstinence therapy or aversion therapy. So let's block opioid receptor beforehand so that the person should not have craving for opioid. So we give oral naltrexone. So understood point where IV naloxone and oral naltrexone are given. IV naloxone, acute opioid poisoning. Oral naltrexone to prevent relapse as an aversion or abstinence therapy. Understood this part? So now let's talk about which of the following drug is not used in the management of status epilepticus. Okay. So the answer of this question was last year INI-CET question was ethosuximide. One more drug you will remember which is not given for the treatment of status epilepticus, that is lamotrigine. These two drugs are not given. So let me tell you anti-epileptic drug. Remember, if the patient comes to you with acute attack of seizure and if this attack lasts for more than 5 minutes, this is known as status epilepticus. And in status epilepticus, you have to give intravenous drug and the overall drug of choice is IV lorazepam. But you can give other benzodiazepine also like intramuscular midazolam also. In refractory cases, we can give injections of valproate, fosphenytoin, levetiracetam, and phenobarbital. Okay. Now you have stabilized the patient. Now we will maintain the patient on long-term basis on oral anti-epileptic drug to prevent another attack of epilepsy. And these oral anti-epileptic drugs are given for at least 2 years as a maintenance therapy. Now, which drug to be given? That depends upon the type of seizure. So the first one we have is GTCS, that is generalized tonic-clonic epilepsy or seizure, grand mal epilepsy. Here we have two first-line drug V and L, which stands for valproate and lamotrigine. Then we have absence seizure, petit mal seizure. Why it is known as petit mal? Because there is no body movement, so the person will keep staring you. So you can only diagnose absence seizure on the basis of EEG. There is 3 Hz wave spike pattern. ठीक है बेटा, वो जो टीबी का अपडेट आप बोल रहे हैं ना लोकेश जी, दैट इज इन यूएसए, नॉट इन इंडिया. इंडिया में टीबी का अपडेट अभी नहीं है, वो यूएस में चेंज हुआ है, अमेरिका में. आई हैव पोस्टेड ऑन माय चैनल एज वेल दिस पार्ट. Now, other types of absence scissor, we give V and L, but we add one more drug E, that is ethosuximide, valproate, and lamotrigine. And other types of generalized scissor, absence, myoclonic, tonic, and atonic, we give V and L, but we add a drug T, where T stands for topiramate. So topiramate is first line drug in which scissor? You know the answer. Lastly, we have focal scissor, in which only one part of the brain neurons are firing. So the mnemonic is Lokpal in front of you. And Lokpal, try to remember first three drug, that is lamotrigine, oxcarbazepine, and carbamazepine. Now let's talk about first MCQ. Which of the following drugs are given for absence scissor? This question came. Tell me the answer. I told you three drugs for absence scissor. Well, valproate, ethosuximide, lamotrigine. So here valproate and ethosuximide is given. कार्बामाज़ेपिन, गाबापेंटिन तो नहीं पढ़ा हमने कहीं भी. सो इसका आंसर का क्या हो गया बेटा? बी एंड सी ओनली. बी एंड सी ओनली. अंडरस्टूड दिस पार्ट? नेक्स्ट पॉइंट, फेब्राइल सीजर. फेब्राइल का मतलब फीवर है. किस में होता है? स्मॉल चिल्ड्रंस में होता है. स्मॉल चिल्ड्रन. सो द ड्रग ऑफ चॉइस इज आइदर रेक्टल डाइजिपाम, क्योंकि बच्चों में वेन्स तो मिलेगी नहीं, तो रेक्टल रूट से देना पड़ेगा, या फिर इंट्रानेजल स्प्रे भी दे सकते हो. सो यू कैन गिव इंट्रानेजल मिडाजोलाम. सो टू ड्रग्स फॉर फेब्राइल सीजर. Infantile spasm, also known as West syndrome, we give one hormone, that is ACTH hormone. ठीक है? But if this infantile spasm occurs with one genetic disease, that genetic disease is tuberous sclerosis, यहाँ पे तो लाइफ लॉन्ग होगा. लाइफ लॉन्ग होगा तो लॉन्ग टर्म हमें एंटी एपिलेप्टिक ड्रग देना पड़ेगा. हार्मोन से थोड़ी ना काम होगा. द ड्रग ऑफ चॉइस इज वीगाबैक्ट्रिन. Then we have Lennox-Gastaut syndrome, which generally has myoclonic types of scissor. Here we give three drugs for myoclonic epilepsy. VLT, T is commonly asked topiramate. But we have a new drug for Lennox-Gastaut syndrome, felbamate. The new drug is felbamate. Similarly, Dravet syndrome, severe myoclonic epilepsy of infancy. दोबारा myoclonic word है तो सेम ड्रग है VLT, बट वी हैव अ न्यू ड्रग फॉर Dravet syndrome, दैट इज स्टीरीपेंटॉल. न्यू ड्रग क्या है बेटा? स्टीरीपेंटॉल. नाउ लास्ट ईयर एमसीक्यू क्या करोगे? आखिरी के तीन एपिलेप्सी को एनसर्कल कर लो. सो जस्ट प्रोनाउंस इन योर माइंड और हेड. First is infantile spasm with tuberous sclerosis, Lennox-Gastaut syndrome, Dravet syndrome. इन तीनों के लिए कॉमन ड्रग है कैनाबिडायोल. कैनाबिनॉइड होता है. सो कैनाबिडायोल इज अप्रूव्ड फॉर विच थ्री टाइप्स ऑफ एपिलेप्सी? लास्ट ईयर एमसीक्यू. Lennox-Gastaut, Dravet syndrome, infantile spasm with tuberous sclerosis. Agreed? इन तीनों का कॉमन ड्रग है कैनाबिडायोल. Now, cannabidiol, last year INI-CET 2025 MCQ is not used for. So it is not used for it is not used for Rett syndrome. ठीक है? तो Rett syndrome का only drug is trofinetide. The only drug we have for Rett syndrome is trofinetide. Trofinetide. Understood this part? So don't worry, I will be telling you. So tell me, which anti-epileptic drug increases GABA levels by inhibiting following enzymes? See this part. Sir, how GABA is degraded? Sir, GABA is degraded first by GABA transaminase enzyme. Then it is degraded by some SSD enzyme. Agree? So which drug inhibit GABA transaminase enzyme? The drug which inhibit GABA transaminase enzyme is V-GABAtrin, which we have just written. How we can remember V-GABAtrin? See the name GABA. TR means transaminase. IN means inhibitor. Now, which drug inhibit both enzyme? GABA transaminase as well as SSD enzyme. The drug which inhibit both enzyme is valproate. Valproate inhibit both enzyme and the question is asking both enzyme. So the answer of this question was valproate. The answer of this question was not vigabatrin, it was valproate. Okay, so INI-CET people tricked you last year. Now, what is the main side effect of vigabatrin? Vigabatrin side effect is it causes visual field contraction. That means it decreases vision. So vigabatrin causes visual field contraction. It decreases vision. That is the side effect. The name itself will tell you everything about vigabatrin. Okay. Now isogagat, tiagabine. Tiagabine inhibit T for transporter, I for inhibitor of GABA. So that is why it inhibits GABA reuptake. It inhibits GABA reuptake. Izogabine inhibit, it opens potassium channel. It opens potassium channel. It opens potassium channel. पूछा गया है, you have to remember. Now, oxcarbazepine as compared to carbamazepine has higher risk of. Now remember, let's write two drugs, oxcarbazepine and carbamazepine. ठीक है? First point, oxcarbazepine has more risk of causing SIADH. Carbamazepine has risk of causing Stevens-Johnson syndrome. SIADH, the patient suffers from hyponatremia. Now the question is, which side effect is seen in children? Which side effect is seen in children? Can we say Stevens-Johnson, Johnson and Johnson baby powder? Johnson and Johnson baby powder मतलब children. ये children में देखा जाता है. SIADH old age में देखा जाता है. So avoid giving these drugs in old age and children. oxcarbazepine को old age में नहीं देना, हाइपोनेट्रीमिया होता है. कार्बामेज़ेपिन को चिल्ड्रन में नहीं देना, क्योंकि चिल्ड्रन में इससे क्या होता है, स्टीवन जॉनसन सिंड्रोम होता है. एंड बोथ दीज ड्रग्स दे कैन कॉज इक्वल इफेक्ट ऑफ सेरिबेलर डैमेज. दोनों क्या करते हैं, सेरिबेलर डैमेज करते हैं. और सेरिबेलर डैमेज में पेशेंट को क्या होगा, एटेक्सिया, निस्टैग्मस एंड डिप्लोपिया इन कोऑर्डिनेशन हो जाएगा. तो इस क्वेश्चन का आंसर क्या है? The answer of this question is A. The answer of this question is A. Oxcarbazepine has higher risk. Now, which anti-epileptic drug has no risk of causing Stevens-Johnson syndrome? Remember, all anti-epileptic drug can cause Stevens-Johnson syndrome, but it is not seen with lorazepam and diazepam. Lorazepam and diazepam has no risk of causing Stevens-Johnson syndrome. So this is a recent MCQ. Okay. Now, next question, a 32-year-old schizophrenic on haloperidol presented with rigidity, hyperthermia, altered mental status. What is the appropriate treatment? Now remember, haloperidol is an antipsychotic drug. And antipsychotic drug, they block which receptor? They block dopamine receptor, which can lead to drug-induced Parkinsonism, that is EPS, extrapyramidal symptom, that is Parkinson disease. Do you agree with this part? Now let's see what happens in Parkinson disease. It depends upon the time frame. Remember, various features of extrapyramidal symptom. The first symptom is an let's write what are the various types of extrapyramidal symptom. Question comes here. Let's write a mnemonic. Types of EPS, never apart. Never apart. ये mnemonic है. Okay. Among them, the first never is an emergency. सबसे पहला क्या है? Emergency. This is known as neurolept. Neurolept means antipsychotic drug. Malignant means emergency. So there is extreme rigidity in the body. Now just think about extreme rigidity. If there is extreme rigidity, what will happen to body temperature? Hyperthermia. muscles will become damaged, rhabdomyolysis, and this myoglobin from muscle will come in urine and cause kidney failure. And myoglobinuria means cola color urine. Do you agree? What is the treatment? Treatment is stop antipsychotic drug. Stop antipsychotic drug and start a muscle relaxant, dantrolene. And we can also give bromocriptine. Dantrolene is a muscle relaxant which block ryanodine receptor. Bromocriptine will now stimulate dopamine receptor. So these two drugs are given in cases of neuroleptic malignant syndrome. Now, what about apart? Apart are the mild EPS. And as we go from A to T, this is the first EPS and this is the last EPS to appear. Okay? Acute muscle dystonia, group of muscles of tongue and face will contract. Treatment is anticholinergic drugs like benzhexol, benztropine or promethazine. Now, after weeks, other features of Parkinson disease will come. Bradykinesia, rigidity and tremor. Give this anticholinergic drug but in oral form. Akathisia, anxiety-like situation. Give anti-anxiety drug propranolol. After many months, there will be peri-oral tremor, which you call it as rabbit syndrome. Again, give anticholinergic drug. Everywhere anticholinergic drug. And lastly, there will be tardive dyskinesia. Dyskinesia means chorea, excessive movement. Can you tell me any other disease which has chorea? Huntington's chorea. Tardive dyskinesia also have chorea or excessive movement. Here we give a drug dopamine depleter, valbenazine, tetrabenazine for tardive dyskinesia. This is a very important slide. Now read the question. Can you tell me which thing is occurring in this patient? Rigidity, hyperthermia, altered mental status because of hyperthermia. So yes, the patient is suffering from one emergency, that is neuroleptic malignant syndrome. Understood this part? What is the treatment? Stop giving antipsychotic drug and start giving which drug? Bromocriptine. So the answer is B. The answer is B. I hope it is absolutely clear. Many students mark benztropine. Many student marks bentropin. It was not the answer. The answer is B. Understood this part? Good. Chalo. Which of the following drug can be given during an acute attack of mania? So in acute attack of mania, which of the following drug can be used? Okay, accept कर देते हैं, शायद ढंग से आया नहीं. Accept. We can give these drugs antipsychotic drug. 3 drugs are given. Remember, amitriptyline is not given. Remember, amitriptyline is an antidepressant drug. Antidepressant drugs are not given in bipolar disorder. So let's talk about bipolar disorder, BPD. The drug which give in the treatment of BPD are mood stabilizer. Mnemonic is in front of you. Low voltage, in which we have lithium, we have antipsychotic, and rest all other drugs are anti-epileptic drug. Among them, remember, topiramate is not approved. Topiramate is not approved for BPD, but it is found to be effective, so it is known as off-label use. So which drug is not approved but found to be effective? Topiramate. Now, during an acute attack of mania, you can give 3 drugs to your patient. You can give lithium IV, you can give IV valproate, and you can give antipsychotic drug like haloperidol. Okay? Generally, we give combination. After you have stabilized the patient, we start maintenance therapy with oral lithium. In lithium resistant cases, which is known as rapid cycling bipolar disorder, we start oral valproate, which is even more effective drug than lithium. But remember, antidepressants drug, they are not mood stabilizers.
They are not mood stabilizers. If you will give antidepressant drugs in BPD, they increase the risk of mania. So antipsychotics are given in BPD. Antidepressant drugs are not mood stabilizer. Agreed? So what is a safe drug in pregnancy, which is not safe in pregnancy? I have already told you in the beginning of class. So which of the following is true about lithium? Okay? True about lithium. So let's talk about lithium. If you remember chemistry, lithium, sodium, they are same chemical of same periodic table. So lithium is a younger brother of sodium. So when you will give lithium orally, it has almost 100% bioavailability or absorption just like sodium. So is it not absorbed from gut? False. It rather has 100% oral absorption. Agreed? Now, lithium, it used for absence scissor? No, yaar, it is given for bipolar disorder. Lithium is not teratogenic, false. We have discussed Epstein anomaly. So lithium can cause fine tremors in normal dose. So let's talk about the side effect of lithium is lithiums. So lithiums increases WBC. ठीक है? So lithium causes increase in WBC. Any drug which decreases WBC level, that is clozapine, antipsychotic drug. So that is why clozapine causes one side effect of decrease in WBC, that is A granulocytosis. So in A granulocytosis, there is decrease in WBC and it can occur at any dose, dose independent side effect. Now lithium causes weight gain. Now lithium causes tremors. Remember, normal dose, fine tremors. Toxic dose, coarse tremors, MCQ. Lithium causes hypothyroid goiter. It decreases T3 and T4 synthesis. Most common side effect of lithium is GIT side effect. Now, lithium block ADH receptor on kidney. Lithium causes nephrogenic diabetes insipidus, which can lead to polyuria. Lithium causes mental changes like scissor. It can cause skin changes like acneiform eruption. Because lithium is such a dangerous drug, lithium requires monitoring. And we take the blood sample to see the level of lithium 12 hours after the last dose of lithium. Lithium is teratogenic, Epstein anomaly, cardiac anomaly. There is abnormal tricuspid valve which leads to box-shaped heart. It leads to box-shaped heart. So lithium can cause Epstein anomaly. Okay. A 35-year-old male presented to surgery emergency with painful erection from past 7 hours. Can we say the patient is suffering from priapism? एंड डोंट यू थिंक प्रियापिज्म इज अ ट्रेजेडी? चलो मैंने आपको नाम दिया, ट्रेजेडी हो गई है प्रियापिज्म। तो कौन सा ड्रग ट्रेजेडी कर सकता है? ट्रेजेडी करने वाला ड्रग हो गया आपका ट्राजोडोन। ट्राजोडोन इज अ ड्रग विच कॉजेस ट्रेजेडी। डन। सो लेट्स टॉक अबाउट एंटीडिप्रेसेंट्स। ब्यूप्रोपियन, it is NDRI, norepinephrine, dopamine, reuptake inhibitor. It is an anti-smoking drug, I have told you. It reduces craving for smoking. It also has anti-obesity action. It causes weight loss, but now very less weight loss, less commonly used. Side effect is seizure. Side effect is seizure. Trazodone side effect, priapism, painful penile erection. Metazapine and mianserine, they have sedative action. So that is why they can be given for the treatment of depression with insomnia. With insomnia. Now this is a very important one, last year question. Ketamine IV and S-ketamine nasal spray. These are the only drug we have for acute attack of depression. Remember, rest all other antidepressant drug, they are not given in acute depression. They are given for maintenance of depression. Only drug for acute depression we have is ketamine. Rest other things in ketamine you will learn in anesthesia, less commonly asked nowadays. Okay. Now, new drugs in CNS. So, postpartum depression, we have progesterone derivative. We have progesterone derivative. Because they are progesterone derivative, they will end with the word on, just like progesterone. Brixanolone, zuranolone. Next point, incorrect match among the uses. So riluzole and edaravone, these drugs are given for ALS, amyotrophic lateral sclerosis. Trofinetide, the only drug we have for Rett syndrome. Trientine, no, it is not given for Huntington's chorea. I will tell you, trientine is rather given in Wilson's disease. Pregabalin and gabapentin. Remember, yes, they are the drug of choice for restless leg syndrome. They are also the drug of choice in neuropathic pain and a diabetic neuropathic pain. Okay? Now, what is the mechanism of action of pregabalin and gabapentin? Remember, pregabalin and gabapentin, GABA word is coming. Till now, we used to believe that they act on GABA. So the point is, remember, they have no action on GABA. Recent MCQ. They have no action on GABA. So pregabalin and gabapentin, they block alpha 2 delta subunit of calcium channel. Last year INI-CET MCQ. So what is the mechanism of action of pregabalin and gabapentin? They don't have any sort of action on GABA. They act on alpha 2 delta subunit of calcium channel. Please mark, last year का सवाल है, इस साल भी आ सकता है. So okay, 5-6 months back it came. Now, let's talk about drug of choice. Restless leg syndrome, pregabalin or gabapentin. ठीक है. हंटिंगटन्स कोरिया, बेनाजीन वाले ड्रग, वेलबेनाजीन, tetrabenazine, they are dopamine depleter because dopamine causes chorea. Tourette syndrome, clonidine, guanfacine. ठीक है. Clonidine, guanfacine. So they are dopamine depleter. They are alpha 2 agonist. Sydenham's chorea, valbenazine. Sydenham's chorea, valproate. Now another point to be noted is in the resistant cases, of these drug, we give antipsychotic drug. In resistant cases, we give antipsychotic drug like haloperidol. Okay, initial drug of choice is different. In resistant cases, we add other drugs in these cases. Understood? Now let's talk about some rare disease asked in INI-CET. Wilson's disease, deficiency of ceruloplasmin, which leads to excessive copper deposition in organ. And there is brown color KF rings also. Basal ganglia becomes damaged, liver becomes damaged. The overall drug of choice for Wilson disease is zinc because zinc reduces copper absorption, and then we add copper chelator. The first is penicillamine, MCQ. Second copper chelator in Wilson disease is trientine. The third one which is approved, just write for your references, tetrathiomolybdate. So I think some people become very famous after their death. है ना? So some people become famous. So he is Stephen Hawkins. He was suffering from amyotrophic lateral sclerosis. So 3 drugs you have to remember. First 2 drugs have been asked in your exam. Riluzole, NMDA antagonist. Edaravone, antioxidant. A new drug, tofersen. ठीक है. Only drug approved for Rett syndrome is trofinetide. It's a neuroprotective drug. Rett syndrome, girl, female child, mental retardation. Friedreich's ataxia, the only drug we have is omaveloxolone. Progeria syndrome, only drug we have is lonafarnib. Rapidly aging PA movie, you know. ठीक है? Now, multiple sclerosis. The first is RRMS, relapsing remitting multiple sclerosis. We start with the drug interferon beta with glatiramar acetate. Now, sometimes this RRMS progresses. So it progresses and neuron damage starts. This is known as secondary progressive multiple sclerosis. We add drugs like metozentron and natalizumab. Metozentron is the most effective drug we have for SPMS because metozentron shows maximum improvement in scale known as EDSS scale, which is extended disability status scale in cases of which is used in multiple sclerosis. Natalizumab is a monoclonal antibody. It can cause one side effect known as PMLE, that is progressive multifocal leukoencephalopathy, which is due to opportunistic infection in brain by JC polyoma virus. Because these drugs reduce immunity, infection happens. But the last type of most dangerous one we have is PPMS, primary progressive multiple sclerosis. From the first day there is neuronal damage, patient dies very rapidly. For PPMS, the only drug we have for PPMS is ocrelizumab. The only drug for PPMS is ocrelizumab. It's a monoclonal antibody that blocks CD20 receptor. INI-CET question. Only drug for PPMS is ocrelizumab. Alzheimer disease. Remember, there is memory loss, so we give anticholinesterase. These drugs increases acetylcholine level, and acetylcholine in brain improves memory. So the four drugs are T-Duggar. First is tacrine, which has been banned because of hepatotoxicity. So the three drugs which are commonly in use is donepezil, galantamine and rivastigmine. Among them, rivastigmine is available as a transdermal patches as well. In anticholinesterase resistant cases, we give a drug memantine. So memantine, MEM word is coming. It also improves memory. Mechanism of action of memantine is it is NMDA antagonist action. It blocks NMDA receptor. Now, in Alzheimer disease, you know, there is deposition of beta 1 amyloid protein in brain. So we have monoclonal antibody that remove this beta 1 amyloid protein from the brain. So the first is aducanumab, which is an monoclonal antibody against beta 1 amyloid protein given for AND Alzheimer disease. And these are the two new drugs we have, lecanemab and donanemab. They are the monoclonal antibody against beta 1 amyloid protein. Then for the insomnia, we have Z drugs, zaleplon and zolpidem. They are the drug of choice for any type of insomnia. Melatonin, Rameltion is the drug of choice for jet lag. Tesimeltion is given for insomnia in blind people because they cannot see light or dark. But now we have new drug for insomnia. So these drugs are suvorexant and lemborexant. So these drugs are orexin antagonist. If you block orexin, the person will sleep. Orexin causes wakefulness. Understood this part? Okay. Then we have the last topic of our day. I hope your energy level is little bit less or you are still energetic because I can see still all the students are sitting. I don't want to leave anything actually. I want to discuss all the MCQs of past 5 to 7 years. So I think our last topic, you all are excited. All the new drugs I have taken care of. You know? For NEET and FMG, I don't take these new drugs. So let's start with anti-cancer drug. Let's finish it now. In just 15-20 minutes, we'll able to finish. Which antidote therapy is used for doxorubicin-induced cardiotoxicity? Now remember, any drug which ends with the word rubicin, doxorubicin, they affect heart. Okay. डॉक्सोरिबोसिन, डोनोरोबिसिन। और दिल को बचाने के लिए हमें दिल वाला ही ड्रग देना पड़ेगा, हमें दिल वाला ड्रग ही देना पड़ेगा। कौन से ड्रग का नाम डीई से स्टार्ट हो रहा है? फॉर डॉक्सोरिबोसिन वी गिव dexrazoxane. So remember, let's talk about all the anti-cancer drugs side effect in one place. This is a complete list and how to prevent it. So I will mark the important one for you, which is commonly asked. First is, which anti-cancer drug causes pulmonary fibrosis? Pulmonary fibrosis is bleomycin, which I will be telling you shortly. Then which anti-cancer drug causes cardiotoxicity? They will end with the word rubicin, like doxorubicin, donorubicin. Any drug which ends with the word rubicin causes cardiotoxicity. Another name of doxorubicin is adriamycin. Doxorubicin को हम adriamycin भी बोलते हैं. To treat this cardiotoxicity, the antidote to protect the heart is dexrazoxane. देन वी हैव नेफ्रोटॉक्सिसिटी, किडनी को बचाते हैं. नेफ्रोटॉक्सिसिटी इज बाय सिस्प्लाटिन. टू प्रोटेक्ट किडनी वी हैव अ ड्रग, नेफ्रोप्रोटेक्टर ड्रग एमीफॉस्टीन, which protects kidney from cisplatin. Then we have bladder damage. Below kidney we have bladder. Hemorrhagic cystitis. 5 months back this question came. Ifosfamide and cyclophosphamide. To protect the bladder, the antidote is mesna. To protect the bladder, the antidote is mesna. So can you see this name, amifostine, mesna, where they will be given, where dexrazoxane should be given? So we have written the antidote. Lastly, liver. In liver there will be hepatic vein fibrosis. Liver damage will be with busulfan, just like Budd-Chiari syndrome. To prevent this fibrosis in liver, we give an antidote, defibrotide. D means inhibit fibrosis. This is you have to remember. Okay. Now let's talk about other side effect. So the first side effect, can you see out here? This is flagellate pigmentation. Don't you think feather-like pigmentation? Flagellate pigmentation is a side effect of bleomycin. Which other side effect I have told you with bleomycin? Pulmonary fibrosis. These two side effects you have to remember. Now, second one, can we say hand and foot is getting damaged? So this is known as hand-foot syndrome. Hand-foot syndrome is a side effect of 5-fluorouracil and its prodrug capecitabine. Cardiotoxicity we already know, rubicin wale drug. And can you tell me which virus produces this vesicle? That is zoster virus infection, है ना? herpes zoster virus infection. zoster वाला ड्रग होता है bortezomib. इसमें भी zoom वर्ड आ रहा है, zomib. zoster virus infection. Now you can match it yourself. So now let's talk about what treatment options are available for breast cancer that is HER2 positive and resistant to trastuzumab. Anyone? Yes, the answer out here is lapatinib. So I will tell you lapatinib in great detail. Now what is sorafenib? Sorafenib inhibit VEGF, vascular endothelial growth factor. Sorafenib is given for the treatment of RCC plus HCC tumor. Similar to sorafenib, we have another drug, sunitinib. Sunitinib also inhibit VEGF and it is given for RCC with GIST, that is gastrointestinal stromal tumor. समझ आई कहानी? So they both are same drug, but there is another drug, imatinib, and its brother we will write nilotinib, dasatinib. They inhibit BCR, ABL, tyrosine kinase. So any drug which inhibits ends with the word nib is a tyrosine kinase inhibitor. They are given for CML. They are given for CML. But remember, sunitinib and imatinib, they are given for alag-alag tumor. These both drugs can be given for GIST. This both drugs can be given for GIST. Okay. Vemurafenib, RAF word is coming. It is a BRAF inhibitor. Vemurafenib is a BRAF inhibitor, and BRAF mutation causes melanoma. Erlotinib inhibit EGFR, epithelial growth factor. It is given for non-small cell lung cancer. It is given for non-small cell lung cancer. Okay? This is what you have to remember. Now, let's talk about breast cancer, various types. So, the first type of breast cancer is HER2. HER2 stands for Human Epidermal Growth Factor Receptor. So, HER, remember a word, trust her. Remember a word, trust her. So, trust her का मतलब, you give the drug trastuzumab. Trastuzumab is the drug of choice for HER2 positive breast cancer. But she will break your trust. If she breaks your trust, remember where you will feel pain, you will have pain in heart. So the main side effect of trastuzumab is cardiotoxicity. Pain होगा heart में अगर trust होगा. Now you have again trust her twice. That is HER2 receptor. Now, after your trust has been broken twice, now you will take revenge. Revenge means in trastuzumab resistant cases, you will give a slap. Slap is known as LAPA. In trastuzumab resistant cases, we give a drug lapatinib. We give a drug lapatinib. Second type of breast cancer we have is ER positive breast cancer, estrogen receptor positive breast cancer. So here the drug of choice is tamoxifen. Any drug which ends with the word fen is an SCRM, but tamoxifen is the drug of choice in premenopausal ER positive breast cancer. But in cases of postmenopausal cases of cases of breast cancer ER positive, we give a drug aromatase inhibitor, and I hope I have told you before. So we give letrozole. So either premenopausal tamoxifen, letrozole postmenopausal. So tamoxifen is given in the treatment of premenopausal breast cancer. Tamoxifen increase the risk of which cancer? Tamoxifen increases the risk of endometrial cancer. Now, in resistant cases of either tamoxifen or letrozole, we have a new drug ending with the word ciclib, palbociclib, abemaciclib. They are CDK4 and 6 inhibitor, cyclin dependent kinase inhibitor. So CDK inhibitor, ciclib वाले drug ER positive cancer में देने हैं. But what about BRCA positive cancer, BRCA positive cancer? In BRCA positive cancer, the only drug we have, they will end with the word parib. पैरिब वाले ड्रग कहाँ देते हैं हम? पैरिब वाले ड्रग हम बरका पॉजिटिव कैंसर में देते हैं. टेलाजोपैरिब, ओलापैरिब एंड रूकापैरिब, they are some PARP inhibitor. Full form, I don't think anybody will ask you. I have given you in full notes. But remember, पैरिब वाले ड्रग बरका पॉजिटिव, सिक्लिब वाले ड्रग ER positive. So tell me the answer of this question. Which of the following drug is an HER1 inhibitor? 2 नहीं है बेटा, 1 लिखा हुआ है. So let me tell you first. See this word, trastuzumab and a new drug, pertuzumab. They block which receptor? They block HER2 receptor given in breast cancer. But cetuximab, it block HER1 receptor. And HER1 is also known as EGFR receptor. It is also known as EGFR receptor, epithelial growth factor receptor. It is mainly given in colorectal cancer. but other cancers you can also give. You have to remember the name of these two new drugs similar to cetuximab. We have panitumumab, necitumumab. They block HER1. Trastuzumab blocks HER2 receptor. So see the name. So cetuximab HER1, trastuzumab HER2, pertuzumab HER2, bevakizumab I think we have already discussed. VEGF inhibit angiogenesis, है ना, inhibit angiogenesis, formation of new blood vessel. ठीक है, formation of new blood vessels. Now another drug very important is rituximab. I have given a trick. Imagine there is a girl with the name Ritu, and the age of Ritu is 20 years. Age of Ritu is 20 years, and after 20 years she got a job in a company known as Reliance. She got a job in Reliance. So rituximab block which receptor? Rituximab, Ritu वाला drug CD20 receptor को block करता है. So CD20 is present on lymphocyte. It decreases immunity of the body. It decreases immunity of the body. So it is given in any type of hyperimmune disease like rheumatoid arthritis, SLE, ITP, autoimmune hemolytic anemia. So it is also given for lymphomas also, because it is killing lymphocyte, that is non-Hodgkin's lymphoma. Just remember the name of regimen, R-CHOP regimen. It is also given in CLL. Remember the name of regimen, FCR regimen. Now, FCR regimen is asked sometimes. FCR stands for fludarabine, cyclophosphamide with rituximab. With rituximab. So this is the treatment of CLL, chronic lymphocytic leukemia. Now, a patient presented to with purpura, diagnosed with ITP. Which tyrosine kinase inhibitor is given in ITP? So the answer of this question is fosgamitinib, which I will be telling you. Now let's talk about other drug for the moment. Oprelvicin. ELVE and kin word is coming. It is interleukin 11. It is a drug of choice for thrombocytopenia, treatment of thrombocytopenia due to chemotherapy. How to treat platelet count? It is given as a drug of choice to treat thrombocytopenia. Interleukin 11 increases platelet count. Okay? Then we have filgrastim. Grastim means it is a granulocyte stimulator. It is basically granulocyte colony stimulating factor given by injection, and it is used as a drug of choice for leukopenia, or let's write neutropenia due to chemotherapy. Neutropenia due to chemotherapy or anti-cancer drug, we give filgrastim. L-trombopag, it is a thrombopoietin agonist. It is a thrombopoietin agonist. It is given in the treatment of ITP. Fosgamitinib. Tinib word is coming. T means tyrosine kinase. Inhib means inhibitor. Given in the treatment of ITP. Given in the treatment of ITP. Let me tell you the treatment of ITP now. What happens in ITP beta? Suppose this is a platelet. Antibodies are produced against platelet. And these antibodies, they will be attached to FYC receptor on macrophages. And this macrophages, they will damage platelet. And these macrophages are present in spleen cells, and that is why the patient has splenomegaly and low platelet count. So the first treatment is reduce antibody production, give corticosteroids. In corticosteroid resistant cases, we give rituximab. What they will do? They will reduce this antibody production. Let's inhibit macrophages FYC receptor. Let's inhibit FYC receptor on macrophages. So this FYC is a tyrosine kinase receptor. The drug name is fosgamitinib. Very important topic. Now, which drug is given to increase platelet count? Two drugs are approved to increase platelet count. First is romiplastim. How we can remember? Platelet stimulator. It is platelet stimulator. It increases platelet count. Second drug which is approved is L-trombopag. Can you recall trombopag word? Trombo means thrombopoietin agonist. So L-trombopag. In refractory or emergency cases, we will remove this antibodies very fast. How we can remove antibody? By giving intravenous immunoglobulin, and we will do plasmapheresis, which is done for any case of autoimmune disease in refractory cases. Okay. And lastly, we can also remove which organ? We can also remove splenectomy in refractory cases. In refractory cases, remove spleen. Remember, it's an important topic for ITP. ITP is an important topic for INI-CET. Okay, so now you know which drug to be used in which cases and where to use which drug. Okay. Now, lastly, ibrutinib. Brute word is coming. It is a Bruton's tyrosine kinase inhibitor. Brute word aa raha hai. So it is a Bruton's tyrosine kinase inhibitor. Bortezomib, zoom word आ रहा है. Proteasome में भी zoom word आ रहा है. So it's a proteasome inhibitor. And this bortezomib, now it has become the drug of choice for multiple myeloma. It has become the drug of choice for multiple myeloma, proteasome inhibitor. Erlotinib inhibit EGFR given for non-small cell lung cancer. Nilotinib beta we have already discussed, given for CML. Given for CML. Okay? So now you can mark the correct answer yourself. So which of the following is a new approved immune checkpoint inhibitor for carcinoma endometrium? What is the answer? Very important question for INI-CET. The answer of this question is beta pembrolizumab. Now let me tell you, what do you mean by immune checkpoint inhibitor? Remember, immune checkpoint inhibitor, they activate lymphocyte. They activate lymphocyte. And let's say this is lymphocyte, है ना? And this lymphocyte, it will kill cancer cells. Suppose these are the cancer cells, they will kill cancer cells. Now remember, there are two receptors on lymphocyte. The first receptor on lymphocyte is CTLA4. The second receptor on lymphocyte is program death receptor. These two receptors are inhibitory receptor. They are inhibitory receptor. These receptors, they stop lymphocyte from killing a cancer cells. They stop lymphocyte from killing a cancer cells. Now just think for a second. If I will block CTLA4 and let's say I block lymphocyte, lymphocyte will not stop. Lymphocyte will kill cancer cells and lymphocyte will become active. They will increase immunity of the body. So these drugs, they block inhibitory receptors on lymphocyte. So try to remember ipilimumab and tremelimumab. Ipilimumab block which receptor on lymphocyte? CTLA4. Okay. Atezolizumab, avelumab, durvalumab. Now this is important for you. Nivolumab and pembrolizumab. These drugs, they block PD1 receptor. Can you tell me what is PD1 receptor stands for? PD1 receptor stands for program death 1 receptor. Nivolumab याद रखना है, pembrolizumab आपको याद रखना है. So where they will be used? Ipilimumab, CTLA4 blocker, given for MNH. ठीक है? Melanoma, non-small cell lung cancer, and Hodgkin's lymphoma. Nivolumab, PD1 receptor blocker, given in same condition, MNH. So can we say we are combine these two drugs together? So these two drugs are given in combination. But the question comes out here, the famous drug. That famous drug is pembrolizumab. Pembrolizumab also blocks program death 1 receptor. It is approved for more than 50 cancers. It is approved for. Obviously, you cannot remember all 50 cancer. And just remember the first 6 word pembro. So pembrolizumab is given for pulmonary cancer and this trial was known as keynote trial. When it was tested in pulmonary cancer, keynote trial, and the brand name of pembrolizumab is Keytruda. Key नाम से इसका brand name भी है. And this you have to remember, it is given for endometrial cancer. Endometrial cancer. Remember these two only. The complete list is given in front of you. Drug which is used everywhere is pembrolizumab. Now, how cyclosporin exerts its mechanism of action? Okay, let me tell you all immunosuppressive drug. They are given in organ transplant people. So let me tell you one thing. Suppose this is an antigen. This is an antigen. Antigen acts on T helper 2 cells. In T helper 2 cells, there is an enzyme known as calcineurin enzyme. There is some enzyme known as calcineurin enzyme, which leads to production of interleukin 2. And interleukin 2 increases cell mediated immunity. How? This interleukin 2 goes on T cytotoxic cells, and the receptor is CD25 receptor. कौन सा receptor? This is an important one. CD25 receptor, which starts one pathway known as mTOR pathway. And mTOR pathway lead to cell division. And all T cytotoxic cells, they contain CD3 receptor pan-T cell marker. Do you agree? mTOR causes cell division. Now the first immunosuppressive drug which reduces cell mediated immunity is calcineurin inhibitor, which will decrease the production of interleukin 2. So tell me the name of calcineurin inhibitor which decrease the production of interleukin 2, reduces cell mediated immunity. The first drug is cyclosporin. Second is tacrolimus. Second drug is tacrolimus. The great advantage of these drugs are no risk of bone marrow suppression. No risk of bone marrow suppression. But what is the main side effect of these drugs, cyclosporin and tacrolimus? They are highly nephrotoxic drug. In nephrotoxicity, they can cause hyperkalemia. Agreed? Now see the next one. mTOR inhibitor. mTOR inhibitor, sirolimus, everolimus. ठीक है? CD25 blocker. The drug which blocks CD25 receptor of interleukin 2. Remember the name basiliximab and daclizumab, basiliximab. Lastly, we have a drug which will inhibit cell division. Mycophenolate inhibits cell division. And lastly, we have a drug which will block CD3. The drug which blocks CD3 receptor is muromonab. How mycophenolate mofetil inhibits cell division? By inhibiting IMPD enzyme. IMPD stands for inosine monophosphate dehydrogenase enzyme. ठीक है? Which is required for DNA synthesis. Now the point is, after this cyclosporin and tacrolimus, rest all other drug advantage, they are renal safe drug. They are renal safe. Which drug is nephrotoxic? Cyclosporin, tacrolimus. But their side effect make it opposite. They can cause bone marrow suppression. Opposite कर दो इस चीज को. That is why bone marrow suppression is more dangerous. The first drug to be started in organ transplantation is cyclosporin and tacrolimus. समझ आई कहानी? अच्छी लगी? ये बताया ना आपको, पूरी स्टोरी बता दी. सीधा बताता तो याद नहीं होगा. And this is a very important slide for INI-CET. Now cyclosporin, how does it act? Cyclosporin binds to cyclophilin, and then this cyclophilin inhibit calcineurin enzyme. Tacrolimus bind to FK binding protein, and then this FK binding protein inhibit calcineurin enzyme. A recent MCQ of INI-CET. ठीक है? Another name of tacrolimus is FK506. Now, which drug causes cosmetic side effect? Cyclosporin has cosmetic side effect? Which drug has cosmetic side effect? Cyclosporin. The first cosmetic side effect of cyclosporin is hirsutism. Cyclosporin causes hirsutism. And the second cosmetic side effect of cyclosporin is hyperplastic gums. It can cause hyperplastic gums, the second side effect of cyclosporin. Agreed? Now, beta, see the word this. What is the mechanism of cyclosporin? Inhibition of calcineurin. mTOR भी समझ आ रहा है, IMPD भी समझ आ रहा है, CD25 भी समझ आ रहा है, and the last slide of the day is a very important, very favorite topic of INI-CET is one drug, thalidomide. Thalidomide. Understood this part? So what is the statement? Let's talk about thalidomide. So thalidomide is a small molecule. Small molecule means it's an oral drug. And thalidomide decreases immunity of our body. How? It inhibits TNF alpha. It decreases interleukin 1, 6 production. Okay. And this thalidomide has decreases angiogenesis. How it inhibits angiogenesis? By inhibiting VEGF. That is why it is used in cancer. And all these effect of thalidomide occurs because of inhibition of one protein in our body known as cereblon protein. It inhibits cereblon protein. And this cereblon protein is also teratogenic. It can cause phocomelia in fetus. So thalidomide is teratogenic drug. Okay, in pregnancy, famous. What are the uses of thalidomide? It is given in 4 condition Tom. It is given for type 2 lepra reaction. मैंने आपको बताया था type 2 lepra reaction. It is given for oral ulcers which is seen in Behçet's disease. It is given in 2 cancers. 2 cancers where thalidomide is given is MDS, myelodysplastic syndrome, and multiple myeloma. And now we have 2 new drugs for MDS and multiple myeloma, lenalidomide and pomalidomide. They are same drugs which are ending with the word domide, congener of thalidomide. Now remember, thalidomide has 2 enantiomer, R form, S form. R form is sedative. S form is teratogenic, and this MCQ has been asked many times in your INI-CET. So S is not sedative, R is sedative. Now tell me, can we give R form in pregnancy? Remember, both are contraindicated in pregnancy. Can you tell me why both are contraindicated? Because inside the body, one can be converted into another form. They can interconvert. So both enantiomers are of thalidomide are contraindicated in pregnancy. Okay. So can we give only R form in pregnancy? Remember, R form is contraindicated. S form is also contraindicated in pregnancy because thalidomide shows a property of enantiomeric conversion. They can interconvert among themselves. Understood this part? Good. Tell me the answer of this question. Which of the following statement regarding thalidomide is correct? Let's start from R enantiomer is sedative. S is teratogenic. True statement. बिल्कुल ठीक बात है. It inhibits angiogenesis and cereblon protein. True statement. Given in the treatment of multiple myeloma and MDS, it is an anti-metabolite. No. Immunosuppressant. True. Okay. So it is not an anti-metabolite. Anti-metabolites are the drug which inhibit DNA synthesis like methotrexate, etc. It does not inhibit DNA synthesis, so it is not an anti-metabolite drug. So the answer is B, C, and D. Okay. Thank you very much. I hope you enjoyed this whole session. I took my time. I thought to take this session very nicely, आराम से, कोई बात नहीं, एक दिन जल्दी बैठ गए क्या हो गया, ज्यादा बैठ गए क्या हो गया, पर समझ आना चाहिए चीजें। नॉर्मी डॉक्टर, यू आर बिकमिंग नॉर्मी से हॉर्नी बन रहे हो आप। सो रिमेंबर बेटा, इफ यू हैव एनी डाउट्स आर वेलकम हेयर, you can ask me. I'll share the PDF right now. Within next 5 minutes I will share to the PrepLadder team. They will upload on the app. Just wait for a few minutes. They will also must be sleepy. They will upload in the app. You can download from there. And remember, अपने आप से कंपटीशन करना है, किसी और से कंपटीशन नहीं करना, अपने आप को इम्प्रूव करना है, किसी से कंपेयर नहीं करना। ठीक है? शीशे में देखो, शीशे में आपका कॉम्पिटिटर बैठा हुआ है। डे बाय डे आपने अपने आप को एक बेटर ह्यूमन बीइंग बनाना है, वेल एजुकेटेड, वेल नॉलेजेबल पर्सन बनाना है। कीप योर हेड डाउन एंड पढ़ते रहो। डॉक्टरी लाइन उठाई है, इफ यू आर बिकमिंग अ डॉक्टर नेक्स्ट 20 years 30 years till you will enter your grave, you have to study, and that is why you should love studying medicine, all the subjects of medicine. Enjoy your day. You have any doubts, you can ask me here. So PDF is finished. Okay, I'll upload the PDF. कोई बात नहीं बेटा, most of the questions I have covered with concepts also. I know INI-CET is a little bit tougher exam, but don't worry, NEET FMG is very simple, like in front of this. Okay, we don't have to go into very much great detail of our drugs in NEET and FMG, but yes, in INI-CET we have to go into the details of many drugs. Okay, yes, this is more than enough for INI-CET, don't worry. इतना कर लोगे INI-CET, I hope more than 90% of the questions will be easily covered from here. Okay, टेलीग्राम नेम भी यही है, डॉक्टर अंकित कुमार लिख देना, आ जाएगा। ठीक है, माई फोटो विल बी देयर। Many students are having my telegram, they are on telegram, you can ask me there, you can ask me on Instagram, I'll share you. So best wishes, keep learning, enjoy your day, take rest and read this session, and best wishes for your INI-CET एग्जाम। डट के पढ़ो, 12 घंटे 15 घंटे पढ़ना पड़े पढ़ो, जब तक एग्जाम आ रहा है खूब पढ़ाई करो, बाकी किसी चीज पे ध्यान नहीं लगाना आपने। ठीक है, बेस्ट विशेस।